This weekend. And with that, I end my talk.
So thank you everyone for making it on this beautiful morning. It's a very nice and cozy room. We'll start the first session, which is a very, very exciting session. It's in GU. It's in a topic that we elected all this year to have only debates. We're not going to have didactics. And the first session is a very, very interesting session led by two dear friends. And the speakers are excellent speakers and very dear friends. I would like to introduce the moderators, and they will introduce the speakers. It's my honor and pleasure to introduce one of my teachers, lovely person, human being, Dr. Dabra Mukherjee, who I had the privilege to work with in AUB before I moved to the US. And now she's practicing in Dubai. And she is a very prominent medical oncologist focusing on GU oncology, along with Dr. Amir Musa, who I just met today, but I read a lot about you in the background, mashallah, doctor. He's an excellent robotic surgeon who's also practicing in Dubai. So with that, please welcome you both and to introduce the speakers. Thanks.
Okay, welcoming everyone to our first debate. I'm not sure that I have a clicker. You've got the clicker? Bios on the slides. So I think we have some of our attendees mostly online. We're a small group, so the debate should be active, and we have one of our speakers online as well. So it's our great pleasure to start the session. We're going to have interactivity with the Slido, so please scan the QR code and you can answer the questions, and for our audience online, you can also do that online. So this is before we have our speakers offering you their opinions, and we can repeat the question at the end, which offers optimal balance of efficacy and safety. Of course, we're talking about localized prostate cancer here, in case anyone forgot. Brachytherapy or... Oh, okay. No one's voting for brachytherapy yet. We have only 2 votes, though. Someone else wants to vote? Here we go. 6 votes. We've got more than 6 people in the room. 8 votes. Head to head, 9 votes. Okay, so we have a lot of work to do for our 2 speakers. So perhaps brachytherapy is winning now. 10 votes. Okay, in the interest of time, we're going to continue, and we might repeat that at the end and see who wins this debate. Okay, so we're going to move on. It's not moving. Can we have the next slide? Ah, okay. All right. And if we could move on with the slides, please. Nope. So if we could remove the questions and go back to the slides. Yep. We're going to see what happens at the end, so All right, okay. So first of all, we're going to be hearing from Dr. Shad Al-Rashidi, who's with us, who is the chairman of the board of the Middle East Society for Therapeutic Radiation Oncology, associate professor Al-Faisal and Princess Noor Universities, and is going to be talking to us about brachytherapy. So Dr. Al-Rashidi, please welcome.
Thank you very much for Prof. Humaid Al-Shamsi and Dr. Ibrahim Abu Ghaida, Dr. Falah, and all the organizing committee. Really honored to be with you this year. So I will be talking about the brachytherapy, and I think everyone already knows about brachytherapy. I thought the group is a combined oncologist and radiation oncologist, but realize it's only radiation oncologist. So don't bother with some slide that also I present to medical oncologists. So I'll be focusing. So I'll be focusing about the brachytherapy in general, about the efficacy and safety. I'll try to convince you about at least shipping the patient to us from the radiation oncologist as well as the medical oncologist and the surgeon. The blame that all of us as radiation oncologists, what we do is really sterilizing the microscopic disease. We're doing so well with the treating the adjuvant diseases. Take an example of breast, prostate after surgery, and anything when we reach a dose of really not more than 60 gray, we only are good with sterilizing the microscopic disease. But the blame is the surgery really cut the disease and you remove the gross disease. That's the benefit of having a high dose that really ablate or at least fibrose any tissue underlying and maybe surprisingly that it can eliminate the disease as of the surgery. And only you can achieve with the brachytherapy when you introduce the source inside the tumor, respecting all other organ at risk. So dose escalation being attempted several times, and with the modern radiation technique like intensity modulated radiation therapy, proton, with the SPRT, either MD Anderson, they reach up to 84 with the modern proton technique, as well as in the other center that escalated the dose, but none of this technique reached the dose of having the highest dose of the brachytherapy. So prostate indicated as boost for the prostate high-risk patient, supplemented with external beam radiation, as well as for the unfavorable without even looking at the other risk. It can be utilized as monotherapy, as LDR, and the science is mature, and it can be also utilized as salvage. And here is our choice when we adopted the brachytherapy treatment. For the low risk, we adopted the LDR, although it's non-available, and we can send them for any center that can be offered brachytherapy. For unfavorable, intermediate, and high risk, we always boost for the prostate high-risk patient. So the two types, the LDR, HDR, and I don't need to go through all of these. For the LDR, usually the iodine 125, and it can be implanted as pre, and the quality is done after the implant. And for the high dose, we use the iridium 192, and it's temporarily implant. So the process for both, as outlined here, for the LDR, you have the pre-planning and also the insertion, and then the post-planning to check the dose was delivered to the prostate. For the HDR, what we implemented the high-dose brachytherapy, utilizing the ultrasound technique with the transperineal procedure, and it can be delivered intra-op and everything intra-op as the patient is not moving at all. So what's the advantage of brachytherapy versus the external beam radiation? There is oncological advantage. Greater RBE, that's from the radiobiology, similar toxicity to the IMRT alone, wherever you escalate the dose. And I know there is some debate about the toxicity with the SBRT, although it's like a short follow-up, but with the longer follow-up, we're really matching, especially with the high dose, with the modern technique, with the ultrasound-based technique. Improve the cancer control both. It can be argued that, you know, the high dose as well as the LDR, similar outcome. The patient advantage this time, especially patients who really live far in the urban area, less time consuming, especially with the high dose brachytherapy, and more convenient to the patient. Thank you very much. And more cost effective as well. So the BED for the external beam radiation, wherever you escalate with the other technique, like with the proton, aiming to get above 84, you'll never exceed 200 BED inside the prostate, and really never attempted any technique with external beam radiation. But with the brachytherapy, you're really escalating above that. And I think it was done also with the SBRT in the lung when the surgeon is trying to be convinced that really this is working. And they follow the patient at a certain time, and then they take a biopsy. With the brachytherapy, the biopsy rate for positive is less than 1%, really 6 to 1 year, roughly. The science is so mature. You can really refer to the ASCEND-RT as a randomized trial. Be careful, that's done with the LDR as dose escalation, and that's what we are blamed for, that it has more toxicity, GU and GI, because we know the LDR has some flare-up in acute toxicity, and later on with the also long-term complication like fibrosis. But with the modern technique, with the HDR brachytherapy, when you give really the boost, as well as when you supplement the intermediate risk as well patient, really the toxicity is so low that even not comparable to the SBRT. The outcome with all modality, I'm not comparing only to the external beam with the SBRT, but also for the surgery, and I'm not really attacking the surgeon or trying to have some friction with them because someone is sitting here, but really across the lines, it was being compared, again, it's not a randomized trial head-to-head, but it was compared to the oncological outcome. There is no superiority on both, but brachytherapy with the long term, especially with the biochemical control, is really superior. The guideline endorsed it, the ASCO guideline, especially in 2017, and still not updated, but for example, in Ontario, Canada, it is mandated that you have to boost the patient with the HDR if they are high-risk patient. The prostate from the NCCN, we published this with our colleague, and one of them is Dr. Rana Arfan sitting here. Thank you to him. He also agreed to endorse that for the low risk, really the LDR is a preferred option if available. For the high risk, you should boost, especially the very high risk patient. This is one example of the LDR, just to show you the process that you do the pre-planning, and then you plug the numbers, and you make sure you're giving a high dose to the prostate. Of course, you bring the patient to the procedure room, and you do the implant. And here's what we can see with the quality X-ray checks. You can see the seeds with the X-ray, as well as when you do post-implant dosimetry analysis, you can see also how you are pushing the dose around the whole prostate. 1 month later, you do a CT scan or MRI, and you fuse them, and you make sure the seeds are really delivering the good dose to the prostate. LDR versus the SBRT. From dosimetric perspective, you can see the 50%, how it's really painting the patient all over, around the hips, especially those are elder patients. And you want to give them 50% of your dose, that's really too much. But with the LDR that they prefer, or HDR that's boosted, really you're 1 millimeter falling off of the dose around with the seats or where you are pushing your dose. So high integral dose, and also the integral dose is so high, as well as the heterogeneity, which really give the blessing of maybe more oncological control with the resistant cells, and the delivering a high dose with respecting the normal tissue. The HDR technique, or what we do with the pushing the dose with the boost. So there are a lot of workflow and image-guided. Either you do it CT-based, which is a common across the world, and MRI-based, for example, in MD Anderson. It's a little bit time-consuming, but also you can do it with the ultrasound transperineal technique, which we adopted, with really very efficient and more trusted when you don't move the patient at all during the procedure. We adopted this in Saudi Arabia in 2022, the full HDR boost technique. And this is one of the pictures of our first patient. You move the patient, you connect, and then you deliver the dose, the treatment. What we can do also, compared to the SBRT, you can boost especially the peripheral nodes if they are really sitting at the edge of the prostate, and you know the you're gonna have a high dose with the HDR compared to the SBRT. But with the HDR technique, what we published, the GU toxicity really seldom, like it's almost 0.3%. GI toxicity also very small. You're not giving a dose to the rectum and barely giving only to the urethra. It is comparable, I would say, to the short follow-up of the SBRT. Efficacy-wise, if we compare both, the SBRT may be a little bit comparable in the 5 to 7 years, but I can tell you if you are exceeding 10 years, the same of the surgery, the biochemical control maybe will be struggling. Why not every center does brachytherapy? This is analysis from the North America and comparing also to Europe. In Canada, especially in Ontario, it is adopted and also mandated the PSA screening, almost not really mandated, but encouraged with every patient visit the GP. That's why it's taking off. The payment model is different. In the US, the coding system did not help in the past. I know they are revising it, the ABS nowadays, and it may also take off after the really good training adaptation, because in US, still the training is not good enough to graduate a lot of brachytherapists. So why should brachytherapy win out over the SBRT? And this is just stimulating for my opponent after me, Dr. Yasser Hassan. Major guideline, NCCN, as well as the ASCO endorsed it. So this is level 1 evidence. Brachytherapy allow for superior intra-prostatic dose escalation with high heterogeneity, which may be favor resistant cells. ADT can be shortened, especially with the dose escalation, and we know from ASCEND-RT 1 year perhaps is enough. The ultrasound intraoperative brachytherapy is well tolerated, and really that should be compared with the future trial, especially with SBRT, not LDR boost. Brachytherapy has benefit of extensive long-term follow-up. That's what I have, and thank you very much.
Thank you very much. It's my honor to be here with you today as a moderator in this nice session. Our next speaker is Dr. Yasser Mohammed Hassan. Is a distinguished radiation oncologist serving as the head of the radiation oncology department at the Kuwait Cancer Control Center. And this capacity has been instrumental in introducing advanced radiotherapy techniques such as MRI-guided brachytherapy for gynecological tumors, enhancing treatment precision and minimizing side effects for patients. Okay, thank you. Yeah, you can proceed, Doctor.
Later, and thank you for the Emirates Oncology Society. So without further delay, we'll be talking today about external beam SBRT for localized prostate cancer. Is it the best therapy? And just to emphasize before I proceed further, I'll put a few cases, and I guess the focus, knowing that the next session is high-risk prostate cancer SBRT versus brachytherapy, I think the focus of this session is localized earlier disease, so low risk and intermediate risk disease. So this is a case of a patient that we're talking about, 60-year-old patient. Screening PSA shows PSA of 9, otherwise Gleason score 6, in 4 out of 12 cores, no palpable nodules, and clinical T2A disease. So how would you manage this patient? Active surveillance or surgery, or radiation, brachytherapy versus external beam? Another patient is a 70-year-old male with urinary frequency PSA 15. Prostate biopsy shows Gleason 7, 4 plus 3, and MRI shows clinical T2C disease. Again, no disease beyond the prostate. How would you best manage this patient? And I guess the cases I'm not addressing in this session is something like this, with high-risk disease, PSA 55, Gleason score 9, and a bulky disease, or somebody with prostatic extension as seen here on this image, or somebody with lymph node positive disease. And I guess this will be the focus of the next session. So reviewing the evidence quickly, I think we cannot proceed overlooking this trial, which is the PROTECT trial that shed light into comparison between surgery, radiation, and monitoring for patients with localized disease. And for those patients with low and favorable intermediate risk disease, we know that external beam radiation therapy produces a prostate cancer specific survival at 10 years of as high as 99.6%. So during the trials I'll be presenting, we'll shed light and focus on the efficacy and the side effects of external beam radiation therapy alone. So we know patients on active surveillance, about half of the patients will require treatment by 10 years. And the second publication of this trial that reviewed the quality of life randomized data between the management arms showed, yes, surgery was associated with fewer bowel symptoms than radiation. But if you look at the graphs for radiation therapy and surgeon active surveillance here, radiation therapy is in yellow. You can see they're almost matching, but because of the huge number of patients, there is a significant difference. Surgery is associated with fewer obstructive symptoms than radiation, but less incontinence with radiation and worse erectile function with surgery. So in summary, we can conclude that erectile function and incontinence risk is better with radiation than surgery. Even if you look at the graphs specifically, you can see the graph of radiation therapy almost matching with those patients who were placed on active surveillance. Now, going into the landmark trials that reviewed moderate hyperfractionation, the CHIP trial, PROPHET, and RTOG trial, we know all those trials were large number trials, and they all established non-inferiority compared to regular fractionation. And that's mainly because of the alpha-beta ratio of prostate cancer. So here, I want to just show you this normal tissue alpha-beta ratio of 3 and prostate cancer alpha-beta ratio of 1.5. So as we hypofractionate in prostate cancer, we improve the therapeutic ratio until we hit the fair balance at this dose 36.25 in 5 fractions that we'll come back to later, where you achieve a good balance of improved biological effective dose to prostate cancer and less biological effective dose to normal tissues. So this is why this ultra-hyperfractionation works. Now, into the ultra-hyperfractionation trials, we have 2 important trials to review and 2 review papers to review. So the first one came, the Widmark trial from the Scandinavia. And this was a large 12-center trial of intermediate risk disease, randomizing between 42.77 fractions daily versus regular fractionation. A point of caution, they used 3D CRT in most of the patients. And the failure-free survival at 5 years was 84% in both groups. And there was an increase in acute toxicity, both urinary and GI, but beyond 3 months, the toxicity was similar between the 2 arms. There's no difference in erectile dysfunction, and leg toxicity was similar between the 2 arms. And with that, they established the non-inferiority and the primary endpoint and secondary endpoint for biochemical control and toxicity. Then the 2 review papers, the Keesham paper in 2018 and Jackson in 2019. So the Keesham paper addressed the question, is stereotactic radiotherapy safe and effective in long term for low risk and intermediate risk disease? And those are the patients we're addressing here. So it's a pooled individual patient data treated with SBRT, 10 institutions, over 2,000 patients, half and half between low risk and intermediate risk disease, and following a follow-up of around 7 years. The randomization, well, the fractionations used were 33.5 to 40 gray in 4 to 5 fractions, and they delivered or selected the trials that delivered more advanced techniques with robotic or gantry-mounted LINAC. And I mean, it's very hard to beat those numbers for my counterparts. So at 7 years, the low risk biochemical control is as high as 95.5%. And for all intermediate risk comers, it was 90%. For the favorable, of course, it was better than the unfavorable disease. As for the safety, the toxicity was very minimal. So acute GU-GI toxicity was below 1%, except for late GU toxicity, which was 2%. And they produced this very nice figure in their publication. At the bottom, you see this red arrow of the present study. And this is on the left side, the grade 3 GU toxicity and more. And on the right side, grade 3 and more GI toxicity. And they wanted to compare visually where their toxicity profile falls in comparison with other trials, whether it's LDR monotherapy, HDR monotherapy, conventional fractionation, moderate hyperfractionation. And you can see visually that the toxicity profile with SBRT, as depicted here in this trial, is lower than everywhere else. So the second one is the Jackson trial that assessed biochemical recurrence-free survival, physician-reported toxicity, and patient-reported outcomes. Again, a larger number of patients, over 6,000 patients, mostly T1, T2, low risk and intermediate risk disease. And again, they showed the very decent biochemical relapse-free survival at 5 years. For low risk is 96.7, and for intermediate risk disease is 92%. At 7 years, all comers is 93.7%. Again, toxicity was very minimal, so less than 1% for acute and late toxicity, except for late GU toxicity, which was minimal as well, but at 2%. So one final trial to end up with, and you cannot go past it in this discussion. So we know the Widmark trial was old practice that used protracted fractionation compared to conventional fractionation. So you really need something with the modern radiation doses, as I showed with the alpha-beta ratio, something like 36.25 to 40 gray in 5 fractions. Widmark used 3D CRT, and you need the more advanced delivery techniques. It used big margins, 10 to 15 millimeters to PTV, and we don't really use this now. We use smaller margins, 5 to 7 millimeters, with the more better image guidance and better assessment tools, just more than patient-reported outcomes in RTOG. And this is really what was employed in the PACE trials. So in PACE-B trial, which is relevant in our discussion, there was 874 localized prostate cancer patients randomized between moderate hyperfractionated or regular fractionation versus SBRT. And the dose of SBRT was 36.25 in 5 fractions. And you have the choice over daily treatments or every other day, and 40 grade to the CTV. And the primary endpoint was biochemical control, biochemical or clinical failure. So it was conducted in 37 countries in UK, Ireland, and Canada, and no ADT was allowed. Most of the patients were intermediate risk disease, so 90% in both arms. And the first publication at 12 weeks for acute toxicity, again, showed no difference between the 2 arms. The second publication at 2 years to assess late toxicity, again, showed no difference between the 2 arms. Then we have the publication, this was presented in Astro exactly 2 years ago in 2023, later on published. So we know that there's no difference in GU toxicity between the 2 arms at 5 years, no difference in GI toxicity between the 2 arms at 5 years, and it's very low, less than 1%. And the biochemical failure was high in both arms, and in the SBRT arm was above 95%. So following 5 years of follow-up, we know that the biochemical failure event-free survival with SBRT is 95.7%, and it's non-inferior to more protracted fractionations. And we know with regards to safety, it's very safe with grade 2 plus GU toxicity. For SBRT, around 5%, and for GI, it's less than 1%. So in conclusion, they suggested that this should be adopted as the current standard of care for low and intermediate risk disease. So back to our question, should you offer external beam radiation and not brachytherapy for localized prostate cancer? And again, we're talking here low risk, intermediate risk disease, and I think the answer is yes. It's well established, easy to deliver, non-invasive, robust with long-term data supporting it for over 30 years. And no need for those specialized, for the specialized training and special tools, softwares that can be very expensive. And whether you go with 20 fractions or 5 fractions, both produce decent biochemical control over 95% and low toxicity profile overall with less than 1% for GI grade 2 plus and within 5% for grade 2 GU toxicity. And with that, thank you very much.
Thank you very much for that overview. So we have some time for questions for our speakers, and we can get up the next Slido to vote again on our question. I'm not sure this is on. Not on. This is on. Okay, so perhaps we can get the Slido again for our first question while we see if anyone has any questions in the audience for our speaker. Yeah.
Yes. I just wanted to ask, what are the updates in terms of the trials between SBRT and brachytherapy? Ongoing? Are there any updates in that regard?
Do you want to stand at the podium so people online can hear through the microphone as well? Could we get the first Slido question back again so that we can... Yeah.
Yeah, so the question from Dr. Saif, is there any update about the comparison head-to-head? I think it will be very difficult comparing head-to-head. We know, we failed from the surgical also comparison long time ago. But I know Sunnybrook, they are comparing boosting with the nodule and comparing also boosting with the SBRT. I'm not aware that there is a trial that's running SBRT versus the brachytherapy. There is attempt to do combined SBRT with the also brachytherapy, and I think Dr. Rana will be talking about these aspects.
Dr. Rana.
Thank you very much for excellent talks for both SBRT and brachytherapy. My question is regarding for low risk or favorable intermediate risk. I think the results are already so good that it would be extremely hard to compete these two arms against each other in terms of improving the clinical outcome from the cancer control. However, what are your views in terms of improving how the patients go through it in terms of suffering? And in your views, is there a need to classify best patients for either approach and work towards that?
That's a really great question from expert. I know he's asking maybe like just also enlighten the audience, Dr. Rana, and the prostate. So just before answering this question, coming back to Dr. Yasser trial, especially the PROTECT trial, I have reservation about this trial because the majority of patients in those trials is extremely favorable, meaning those patients, you can observe them without any treatment, that he showed 99%, maybe the local control or the oncological control. So we're not comparing those patients that have extremely favorable outcome. And also with the trial that showed, like a short-term follow-up with the toxicity and in the efficacy. With the LDR, especially the ASCENT RT, and coming back to Dr. Rana question, the longer you follow those patients, you have 2 to 5% metastatic chance in the 10 to 15 years. So in LDR, basically we are improving the metastatic free survival. That could translate to long-term also control of the cancer. Now, I am not aware that the SBRT also reached this comparison. For the LDR patient, the biochemical control, although if you stratify them into maybe more unfavorable or at least with more risk with the favorable disease, if they have like more core and over 4% that it's really unfavorable risk, I think they will be served with the LDR better than the dose escalation or with the other model of the external beam radiation. So yes, definitely we need more stratification, especially with the favorable risk patient. I think toward the more higher risk or unfavorable risk, that you should also be careful saying the hypofractionation is enough with a short follow-up.
Thank you. So I think we're missing a question. We're missing an answer here, which is of course surgery for low risk disease. So in which patients? So let's hear from our radiation oncologists. In which patients are you preferring surgery for the low risk disease?
Definitely, surgery is the gold standard. Just to respect that one.
Dr. Pala.
Of course, even the PROTECT that Yasser he showed is surgery is doing so good. If you surgeries them, you do LDR, which I believe is better, and the intermediate. But with the young patients, especially below 60, it's still radiation, and we may introduce them secondary cancer long term, although in brachytherapy, less the risk with the secondary cancer. But with the less than 60-year-old patient, I tend also to say maybe focus on the surgery more than the at least give our surgeons some share. And if they are really above 60 or 70 and plus, I would offer them LDR if it's available.
Please go ahead. And I think, of course, about the PROTECT trial, this is old surgery, it's old radiation,
Absolutely.
it's
Very
risk
favorable
stratification,
patient.
which
Yeah.
is very low risk. So I think we probably shouldn't really be just
It's active surveillance trial.
discussing.
Yeah.
Exactly.
That's what I call it, active surveillance trial.
I think the problem with the voting is that most of us do not have access to brachytherapy, and they don't
they changed their
understand.
vote? Oh.
They don't understand
US election.
mechanism probably. Those who've been using brachytherapy, they know the advantage of that. But I think that's one of the reasons that maybe most people prefer SBRT or whether conventional or short courses.
It's a very good point about access and local expertise. So
Absolutely.
These have all great outcomes.
I will add to that. We're like our region is not the same. We're in the West country, so we have to be careful when you are even doing SBRT that you may need a spacer. You have to be careful with the imaging, the modality. I would say if you analyze the cost, and it was analyzed in Toronto, it may be the brachytherapy, the LDR is way cost effective than doing a 5 fraction of SBRT, and it's been already published from Toronto. But the LDR is so cheap. I can tell you I'm not advocating for any vendor, but it's the equipment is cheap. It's probably only like, the operator dependent. You need to have training, but the cost for the treatment is exceedingly low compared to any modality of external beam radiation. The machine is on. You need CBCT at least every treatment. You need the manpower, more manpower, and you need also more careful technique with the SBRT. So I think we're looking from one view, but we're forgetting the other view.
So I think in the interest of time, we're going to be moving to our next pair of speakers. Thank you very much, and we can have more questions afterwards. But I think to summarize this session, for low-risk prostate cancer, we have 3 modalities now. We have better techniques. We are curing cancer in majority of patients, and local expertise, patient preference, and discussion in our MDTs is incredibly important. Wonderful. So, okay, if we could introduce our next speaker, Dr. Wael is with us in person. Fantastic. And we have his bio on the next slide, please. Can I have the next slide? Yeah. There we are. Okay, this is on. That's for you. There's the moderator for this session. Ah, Dr. Yusra is also joining us, and that's the clicker. Wonderful. Please come and join us. Perhaps we can go and sit down. Yes, please. You can introduce our speaker.
Sorry. So, very good morning to all of you. Just a special thanks to the Emirates Oncology Society, Professor Humaid, Dr. Ibrahim, for giving me this opportunity. So, the last session actually set ground for the new. And just for those who are wondering, what different would we be discussing today? So this high-risk prostate cancer is a challenging subgroup, and we can cure these patients, but we have to optimize between quality of life versus oncological outcome. Now, what's different from last session? I believe for patients with high risk, when we start with non-invasive external beam and then offer an invasive brachy versus a non-invasive SBRT boost, this is a topic of debate. And so I think we can start with the first speaker. So Dr. Wael Al-Shashwati, he's a very highly regarded clinical oncologist and head of clinical oncology department in Al-Azhar University, Egypt. He completed a fellowship in radiation oncology from McGill University of Canada, specializing in advanced techniques of radiation therapy. And his research spans from various cancer therapies, IMRTs in lung and brain cancer, and lots of publications in lung, breast, and prostate cancer treatments. So I welcome the first speaker to begin the session. Thank you.
Thank you. Bismillah ar-Rahman ar-Rahim.
Do we have a poll before the session, Micheline? Yeah, just. I think there is a poll before, and then we'll have one after. Yeah.
طبعا. At least 2 brachy.
The fight is really good here. It's a very neck-to-neck discussion here, I guess. Yes, yes.
Bismillah ar-Rahman ar-Rahim. Thanks a lot for the introduction. Thanks, Dr. Ibrahim, for this kind invitation. Very happy to be with you today. I thought the competition will be more easy than that. Looks to me many are preferring to give or encouraging to give boost with brachytherapy. This is my disclosure. I have nothing to disclose. This is my agenda for today's presentation. I will start with guidelines and go through the evidence. Let's start with the NCCN guidelines. Maybe it's not the perfect one, but the most handsome one in stratifying the risk treatment for high-risk patients. If we look at the treatment modalities that are recommended as preferred options for these patients, we'll see the moderate hypofractionation radiotherapy is one of them, followed by the ultra hypofractionation, then the external beam boost with SIP, external beam radiation therapy with SIP boost, and finally the external beam radiotherapy followed by brachyboost. Actually, the story of hypofractionation, I think we all know about it. It's based mainly on the low alpha-beta ratio of the prostate cancer that ranging between 1.5 to 3 gray, according to different trials. We have many trials investigated the role of hypofractionation in high-risk prostate cancer, but most of these trials did not include purely the high-risk patients. If we look at the CHEP trial, only 12% was having high-risk disease. For the HYPRO trial, only 50% of the patient was having high-risk disease. However, the ABCS5 Canadian trials that published recently have 100% of the patient has high-risk disease. And if you look at the results of all these trials, it's all showing non-inferiority over the conventional fractionation radiotherapy. Let's take a deep look on the EBS5 trial that randomized high-risk patients between conventional fractionation over 38 fractions versus 25 fractions, 68 gray total dose. This trial, the baseline characteristic of patient was almost equal between both arms. The toxicity in general was highly acceptable in this trial. The early toxicity was in favor of conventional radiotherapy. However, the late toxicity was in favor of hypofractionation. So we have almost low incidence of grade 3 toxicity and almost comparable toxicities. The outcome showed almost equal results between the hypofractionation and conventional radiation therapy. What about the external beam dose escalation? Actually, the accumulated data in general showing very promising result from SBRT for prostate cancer patients. This is systematic analysis, included 6,000 patients of all risk groups. The impressive here is at 7 years we have about 94% biochemical free survival, which is very good number. And if you look at your right hand, you will see linear correlation between the dose of SBRT and the long-term biochemical control. The toxicity was in favor of external beam radiation therapy, conventional one. There is some higher toxicity with SBRT. But remember, this is like heterogeneous data. It's maybe with the advanced techniques and something like this, we may have less toxicities. We have retrospective study compared head-to-head the boost with SBRT and boost with the HRD. This is USS study. It's published in 2020. It included 130 patients in the SBRT arm and about 100 patients in the boost arm, SBRT boost. The patient included in the SBRT boost was high risk, was about 60%. However, for the brachytherapy boost, the patient with high risk disease was representing about 85%. The results showed equivalent outcome between both arms in terms of progression-free survival, biochemical progression-free survival. Even in the propensity score matched cohort, the result was equal between both arms. And for the patient who has Gleason score 8 or more, the result was also equal. And the patient with T3 or more, the result was also equal. Another trial looked at the external beam boost instead of the SBRT or the high-dose brachy or low-dose brachytherapy boost. And this trial was the FLAME trial that came from Netherlands and Belgium. This trial randomized 570 patients between either hypofractionation 2.2 gray per fraction for 25 fractions versus 77 and 35, in 35 fractions versus 77 gray in 35 fractions plus SIP boost for 2.7 gray per fraction for this group. The patient was distributed equally between the both trials. About 60% of the patient included in this trial was having T3 tumor. Glycemic score more than 8 was noticed in about 30% of patients, and about 60% of patients received hormonal treatment. Only 30% received long-term hormonal treatment, and finally no pelvic irradiation was used in this trial. The trial showed improvement in the progression biochemical disease-free survival with about 7% difference at 5 years, as well as improvement in the disease-free survival. However, the distant metastasis-free survival, which is considered the real surrogate outcome for overall survival for the patient with prostate cancer, did not show any improvement, just a trend towards improvement, but was non-statistically significant. And the prostate-specific overall survival and the overall survival were both negative. At 10 years follow-up, the separation of the curves started to grow, and now the difference between the SIP boost and the long course treatment is around 15%, and there is a linear also correlation between the dose used and the outcome, because in this trial the dose was isotoxic dose. That means we have to respect the organs at risk when we are prescribing the boost. If the boost is exceeding the organs at risk constraints, we go down by the dose to reach the to optimize the organs at risk dose. And at 10 years still we have 14% disease-free survival difference between both arms. Additionally, the local and regional control was excellent. At 5 years, at 10 years, it's 95% local control and 94% regional control with this technique. The distant metastasis-free survival is still non-significant. Also, we have some trend towards the improvement. Only 4% improvement has been noticed. Regarding toxicity, it was equal between both arms because the use of the isotoxic concept, this trial didn't exceed the organs at risk tolerance. And even at long-term follow-up, over time, there was no change in toxicity in both arms. Regarding quality of life, still we have got quality of life for both arms, almost equal. And currently, the idea, remember that this is long course treatment with SIP post. But in practice, we are all the time practicing hypofractionation. And even we are moving to the SBRT era. This is another trial. It's the second generation of the FLAME trial called the HypoFlame trial. It was a phase 2 trial, investigated the idea of giving SBRT with SBRT boost. So they gave 35 gray in 5 fraction SBRT and boost for the MRI-defined GTV, which is the era of posting currently, just to give the gross tumor volume, not all the gland as we used to practice in our practice. This trial showed was phase 2 single-arm trial. It was a feasibility trial. And the outcome for this trial was excellent. At 5 years, we have 93% biochemical progression-free survival. And on the other hand, the toxicity is highly acceptable. Quality of life was also maintained for these patients. And what about the brachytherapy boost? I know Dr. Rani will speak about it, but I will just remind you with the ASCENT trial that randomized patient between low risk, this is the only randomized trial that we have, randomized patient between the low dose rate brachytherapy boost and the external beam radiation. And this trial actually showed a very good biochemical control. However, the toxicity was high in this trial if we compare it, especially the late toxicity, GU toxicity. This is comparison between the FLAME trial and the ASCENT trial in terms of dose escalation for the with external beam or the brachytherapy in these high-risk patients. And as we see for both trials, we got very good results. The patient with T3P and D4 was excluded completely from the ASCENT trial and included in the patient in the FLAME trial. Additionally, if you look at the toxicities, the toxicity is equal between both arms in the ASCENT trial, the trial with dose escalation, and on the other hand, we have higher toxicity, especially geotoxicity within the patient who received brachytherapy. My take-home message, hypofractionation is now established as the standard radiation therapy option for patients with high-risk prostate cancer, supported by multiple phase 3 trials and the international guidelines. Dose escalation improved progression-free survival. However, it has not translated into significant gain in distant metastasis-free survival or overall survival. External beam boost provide the advantages of being non-invasive, only one technique will used a long run, broadly applicable across patients population, as I showed you before, the patient with T3P or even T4, in addition to the other contraindication or contraindication for brachytherapy, like the primary volume. I know currently there is moving area in choosing patient with high volume prostate cancer, but at least the trials was provided 75 milli for inclusion in the brachytherapy trials. And no associated excess toxicity, making it an attractive escalation strategy. Brachytherapy boosts to offer significant long-term PFS improvement, but this comes at the cost of increased treatment-related toxicity, require careful patient selection and expertise. Thanks a lot for your attention.
That was an excellent presentation from Dr. Weil. Thank you very much. Now we invite the next speaker, Dr. Rana Irfan Mahmood. He's a British trained oncologist of over more than 20 years experience, transition from the NHS, worked there as consultant oncologist and clinical director in cancer services. He's renowned for his pioneering advancement in image-guided radiotherapy, specifically brachytherapy. He's recognized with Fellowship of Royal College of Physicians, Royal College of Radiologists, continues to train oncologists and contributed to this field of teaching with his membership in prestigious associations like ASCO and ESTO. We welcome Dr. Rana for this
Thank you very much. So I think in the next 10 minutes, I will just try to emphasize only 2 or 3 points, not that many, because there are not that many points. The first point before I start is that as a co-author of PACE trial, I strongly believe that SBRT is a fantastic treatment. So there is no argument that SBRT is useless. And we are not going to focus on low or intermediate risk cancers because, as I asked in my question as well, there is waste of time to compare SBRT versus HDR or LDR monotherapy for low and favorable intermediate. I will be fully focusing on high-risk cancers because that is where we are failing, okay? Because as highlighted in the first talk, For low risk, there are active surveillance, surgery, but when it comes to high and very high risk cancers, active surveillance is out, and mostly surgeons will say no. So that is when the ball is completely in our court. So what we are going to talk about is what is the problem with high risk cancer and how can we solve it the best way. Before we start, already highlighted what is high risk. It is advanced cancers or very high Gleason score. This is the most up-to-date NCCN guidelines. And in the high risk category, it is basically just saying that boost it. Although they say that RT options ABRT or brachy boost, it doesn't say simultaneous boost, but I take it that boost it. That's the main thing. Why? Why boost it? And that is what I will show you. How did we learn that we must boost it? And the other point I want to highlight is that HDR and LDR is not the same thing. The data my colleague showed is for SNRT trial, which we all curse that trial because that used LDR, and none of us is practicing LDR here for a reason, because there is a randomized control trial now which shows that HDR is much more safer approach than LDR. And it makes sense because you are delivering the dose there and then. You're not waiting for seeds to melt and move. So this slide has already been shown, which says that brachytherapy boost is part of NCCN guidelines. This is a key slide. I think it's a very old slide now, but that is where it was very clearly shown using biological modeling that yes, you can increase the dose to the whole prostate. MD Anderson did it, Europeans did it, for the whole gland dose escalation. But we got to a point where further pushing the dose to the whole gland is not going to change anything. I will show you the data from Soren Benson's team where they did biological modeling to show that above 80 gray to the whole gland is useless. So that brings us to the pattern of failure, that where do patients fail in high-risk cancers? And we find that they fail in what we now call DIL, dominant intraprostatic lesion. So that is biological modeling to show that you must increase the dose to the dominant intraprostatic lesion rather than the whole prostate. I will not waste time on that. This is, again, a planning trial for a long time ago, which led to hypoflame and flame trials, showing that, yes, tumor control probability will go higher with dose escalation. Again, the same, another planning study showing that you can identify now with PSMA PET scan, you can identify with multi-parametric MRI scan, with systematic biopsies, you can identify the sector and DIL and boost it. Multiple planning studies. Already a flame trial has been highlighted, was the first attempt to boost only the dominant lesion rather than the whole gland and did very well. Hypoflame, already highlighted, did very well. And I will basically just tell you that it's a very good trial. However, the number of patients is only 100 and the follow-up is still only 5 years. And as Dr. Weil highlighted, even in the flame trial, something happens after 6-7 years and curves start departing. And I will show you in the SNRT trial or our beloved Peter Hoskins HDR trial as well. So SBRT boost is a very good thing, but let's wait for the longer results before you damage something. Okay, so let's move on quickly to the brachytherapy part. The people in the room who do not practice brachytherapy, for them, I will just show a couple of slides. What is brachytherapy and how do we do it? SNRT trial already highlighted. I only put it for one reason here, is that 4 to 5 years is the time, even for high-risk patients, when things go fine. And after 4 to 5 years, curves start departing. Unfortunately, the SBRT boost may well be a very good option. The data only is currently limited to 5 to 6 years. So we don't know that in 10 years' time, the curves will still be as good looking as it is. For brachytherapy boost, the data is more than 10 years. So this is a Peter Hoskin trial I was talking about, which is randomized HDR boost trial, showing exactly the same thing as SNRT, that if you boost the dominant lesion, 4 to 5 years, nothing happens. 4 to 5 years, even without boosting, is doing well. 4 to 5 years later, people who were not boosted starts failing. So we must wait. Only thing that is saying is that we must wait for mature data before we pull the trigger in one direction or the other. So this is just a simple slide to show brachytherapy. It may sound really tedious and very long process. It takes less than 2 hours to deliver the full dose of brachytherapy, including planning, insertion, the whole kind of stuff. This is our patient lying there. We insert, we plan, we treat. Within 2 hours, patient is outside the room recovering and go home. So huge dose of radiation. We already learned that alpha-beta ratio for prostate is low, so give high dose per treatment. How high you can give? Any higher than HDR boost, where you give 15 gray single session, but actually the dominant lesion is receiving 20 plus gray. So you are really blasting it. And this is one of our patient, again, showing the same thing. You can spare all these things. This is, again, the case we had last week. Very big lesion, high-risk tumor. Again, I call it iterative heterogeneity because when you are planning brachytherapy, you are putting the needles under direct vision. You can see the tumor. You can play with those needles, and the time the radiation source is going to stop in those needles, and the lateralize your dose away from urethra into the tumor. And that is where you see the dose of radiation going into the tumor is huge, nothing in the urethra, but the tumor is receiving nearly 200%, which is roughly about 30 gray single shot. I mean, ask any SBRT plan to generate that. The clinical data will follow eventually for SBRT, hopefully in next 10 years' time, but this data is available for more than 10 years for HDR boost. That is why HDR boost is the most prevalent way to escalate the dose so far. And again, people who practice the brachytherapy, they know that very easy to push the dose for the organs at risk to the right side and push the dose to the primary dominant lesion to the highest level possible. So this patient has received 15 gray, but if you look at the GTV, he has received 30 gray. So I will stop showing you any of these things any further. But just to also say that for salvage brachytherapy, for example, for radiation failures or SBRT failures, you can still plant a very high dose of radiation without going into the rectum or the urethra or anything, so you won't expect any side effects. This is what I was telling you, the randomized trial showing HDR versus LDR. HDR is way superior to LDR, so this is why S&RT people themselves repent that why did they do LDR. And now SBRT boost trial is going on where they have allowed the HDR as part of the boost. So this is one of the French data where they accumulated all boost HDR patients and LDR patients to show that you can save patients recurring and requiring long-term castration treatment, because no man wants to be in a long-term castration treatment and have all those menopause or so-called andropause side effects. So that is Soren Benson's biological model I was showing you, where he showed that beyond 80 gray, it doesn't make much difference. However, this predates the dominant lesion concept that you should escalate to the dominant lesion. So this is where we are right now, that there is no need to escalate further dose to the prostate gland. However, dominant lesion, yes. Again, this is the planning study, which is an excellent trial where they did compare the HDR versus a robotic SBRT, which is CyberKnife. So in that planning study, you can very clearly say a very neat and clean dose distribution to the prostate with a huge flexibility and adaptability of radiation in whichever direction you want to send. However, with SBRT, yes, you can achieve the prostate dose, but at the expense of other organs, which will restrict you to the dose you can escalate. Hypoflame is a brave trial receiving 50 gray. However, with HDR boost, the GTV is receiving 25 to 30 gray single shot, which is double the dose of SBRT. Will it translate compared to SBRT into better outcome? That is what has to be seen over the next 10 years. This is the hypoflame model. This is our HDR model, where you are escalating the dose onto the tumor side. I will not go into the details of this, already shown, however, just highlighted the fact that the largest SBRT boost trial has 5-year follow-up data only. And again, the pooled analysis from the SBRT data all goes until 5 years. However, the HDR boost trial is more than 10 years. This is 12 years data Peter Hoskin published, showing the same thing with a fantastic outcome in terms of the toxicity. SBRT trial is ongoing, where they are boosting now. This is the randomized trial where they're boosting either with SBRT or with brachytherapy, but this time they learned the lesson, Canadians. They are now doing the HDR boost. So this is the American brachytherapy consensus, showing that this UHE can achieve superior biochemical outcome. This is one of my last slides, where the author is sitting in front of us here, who already concluded with Jerry Morton to say, when HDR is producing such a beautiful dose distribution with ability to spread dose whichever direction you want, why to do anything else? And it is such a simple procedure. The people who basically do it, they know how simple it is. However, I will stop here, but I will show you a couple of more slides just to show you that SBRT is a fantastic approach, as I said before. So it is not something which I will say it is too inferior to HDR and everybody should have HDR boost. What I'm saying here is that this is the table I created, which when I imagine about what is the best way to escalate the dose into the part of the gland, okay? And what are the compromises? We know all this from evidence base. So if you focus only on this colorful diagram, we are saying that for the target itself, HDR is producing higher dose, which we know that. But remember, GTV receiving 30 gray, but at the expense of higher dose to urethra compared to SBRT. So when it comes to urethral dose, HDR is not as good as SBRT. But when it comes to bladder and rectum dose, HDR is better than the SBRT. So the idea would be, rather than just relying on one modality, the best way possible, in my opinion, where the future is leading us to, is to combine these two approaches. You can give 25 and 5 for SBRT, and then a boost session of HDR, which will have best of both worlds, because you are de-escalating HDR to meet urethral constraints, and you are de-escalating SBRT to meet bladder and rectum constraints. Okay, and this is exactly what is happening in large-scale trials. This one is from UCLA, and this is from MSKCC, and this is exactly what they are doing. People are getting 15 gray single-shot HDR, and a month later, 25 and 5 SBRT. I think that is where the future is leading us to. I hope you don't have any questions.
Thank you very much, Dr. Rana. Very insightful presentation and very diplomatic one. I'm sure it's going to be difficult to put the post-debate poll now. So before, do we have any questions, quick questions? Maybe we have a minute or so. Dr. Deborah, please.
Fantastic talks. So now we're talking about higher risk prostate cancer. So from your studies, we know that we're now using PET PSMA staging, so we're going to be weeding out those patients who have occult or visible metastasis on PET PSMA. But also for those well-staged patients, where are the recurrences happening? Because if it's distant recurrence, then you can give all the dose you want to the prostate, but it's the distant recurrence we're worried about. So do you think the future is going to be in higher doses, or will it be in optimizing the staging, risk stratification, and systemic therapy?
Excellent question, and it is all of that. Okay.
All of the above.
Yep.
All of you.
And it's very, 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 very easy to understand why. Because, of course, when you talk about high-risk cancer, you look at pattern of failure, you have both. The problem is that as a radiation oncologist or as a surgeon, what you really hate is a local failure. Because as a red onc, you are a local guy. Okay? And we need your help to control the systemic disease as a medical oncologist. But if my treatment fails in the prostate, I'm not happy, right? This is why we are talking about how to kill it in the prostate. Because after radiotherapy, when somebody fails in the prostate, it is very hard to salvage them. And after surgery, you can still give salvage radiation, but salvage prostatectomies are not a nice procedure. So what we really want is to kill the tumor in the prostate, and in doing so, believe in data that metastasis-free survival will be better, biochemical control will be better. So this is where the cooperation between medical oncologists will come eventually. But as a radiation oncologist, our task is nobody should relapse isolatedly in the prostate. And that is where we are boosting it. And the argument is how best to boost it. And for that argument, what modality can give you the highest dose? And that's where HDR so far is. This is what we were highlighting.
Dr. Ibrahim? Thank you.
It's regarding the use of hormonal therapy as well and the duration of hormonal therapy in these patients. I mean, a lot of those patients are elderly gentlemen with cardiovascular risk disease as well, and they're high risk. So, so would you recommend sticking to, 18 months to 36 months, or would you give only 1 year of hormonal therapy because based on the, the ascent as well? Just trying to see, because sometimes, I think we know that higher dose can mitigate maybe a longer duration of hormonal therapy. I don't know. I mean, just tell me about your thoughts about this, and maybe Dr. Rana also, I'll get your points on this as well.
Thank you, Dr. Ibrahim, for your question. Actually, if you look at the common practice, like what we have seen in the FLAME trial, we'll see about 60% maybe has high-risk disease, or even more, 80%, 80-something percent, and the patient who received the hormonal treatment was only 60%. So in clinical practice, yes, you can do this if you see like the expected side effects from the systemic treatment will be high. You can omit it, you can give it just short time. And in the FLAME 2, why FLAME is important? Because it's a recent one, reflecting the common practice currently. So if you look also at the duration of treatment, only 30% of the patient received long-term hormonal treatment. So I think, yes, we can shorten the time of hormonal treatment, and even we can omit it for certain patients.
Yep. I think it's a very good question. And the real answer, none of us know. The reason is that we have not even worked out yet that how does hormone treatment, in addition to what commonly we think that, microscopic metastatic disease, right? That is where the medical oncologist will come in and all kind of intensification for the ARPIs or whatever. But how does it interact with radiation dose as far as the local control and the local disease is concerned? We haven't worked out on that one. We need medical oncologists to join radiation oncology boards to work on that one. But one thing we have definitely learned from the trials is intensification of radiotherapy takes away the need of long-term androgen suppression. We have seen it over and over again. And SPRT boost trials, unfortunately, have not yet translated that particular benefit of dose escalation by shortening ADT. HDR or LDR trials have done that because, number one, they are being conducted for a long time, more than 10 years, 12, 15 years, number one. Number two, people who practice brachytherapy, like HDR, for example, when you know that you have just given 30 grays single shot to the GTV, you feel like you just basically blasted and tumor is dead. So this is the mentality was that, okay, well, we don't need hormone really now for the local thing. We only need for the distant disease. And that is where we don't know how long it is. So this is why brachytherapy boost trials, additional benefit, which we did not talk about, is that all the trials, none of these trials exceed 12 months. So even SNRT is 12 months. So this is additional benefit of that.
Dr. Falah has one more question. Yes.
Further to Dr. Ibrahim question, is it ADH only or anti-androgen only or together as a hormonal therapy? You
mean the ADT with ARPIs?
Alone, ADT alone, with the radiation, of course. ADT alone, ADT plus anti-androgen, anti-androgen alone.
Yeah. So again, you're asking a question which $1 million question, and nobody knows the answer to that. We take a step back. We don't even know that how ADT interacts in terms of local control
for radiotherapy inside the prostate. We believe that treatment intensification will lower down the need of duration of ADT. But will intensification with ARPIs, for example, with intensified radiation, will achieve the same thing? We don't know. We don't know that. So right now, no trial is intensifying with a concomitant intensification of the boost.
We can take one more question, yes,
Yeah.
in the interest
Dr.
of
Rana,
time.
I always enjoy your talks.
Thank you.
I love it. And I love most the conclusion that you put about having SBRT plus HDR as a boost. Now, the question is, as a traditional, the time I was resident, we was always obsessive with the pelvic nodal irradiation in high-risk prostate cancer. What do you think of that?
Yep. So this is exactly where I feel that we are going, because we are talking about high risk or very high risk disease, so we must do something to the lymph nodes. And for all SBRT trials, for example, PACE-C and beyond, all these trials have now the standard arm for SBRT as 25/5 for the whole pelvis, with escalation to the prostate as 40, okay, or even 50, right? Which means that almost everybody in the radiation community has agreed that prophylactic elective nodal dose is 25/5, right? So this is why this last trials, which are currently ongoing, one is ongoing, one is yet to start from MSKCC, UCLA is ongoing, is a fantastic trial. Why? Because you bring a patient with high-risk disease, you give them a single shot of HDR, and then a month later, you bring them back for 25/5 whole pelvis. 25/5 whole pelvis technically is not even SBRT. Otherwise, all rectum short courses will be SBRTs, for example. So this is why I like it, that you de-intensify all the SBRT thing, as opposed to if you are only going to do SBRT, you will be having 3 PTVs, one for 25/5 for elective, one for 35/5 for the prostate, and one for 50/5 for the dominant lesion, and possibly 40/5 for the prostate CTV as well. So there are 3-4 PTVs, complexity, and all kind of stuff, and yet you cannot escalate the dose same as the HDR, yet you cannot spare the bladder and the rectum that much. So this is why I feel that those 2 trials and further to come are going to shape how we do it. Single HDR, a month later, bring the patient for whole pelvis 25/5.
I'm getting reminders from the back. Probably we crossed the limit. Thank you very much. We'll move on to the next session then. Thank you. And yeah, I invite Dr. Yogini, my colleague radiation oncologist, and Dr. Yogesh, our surgeon, head and neck surgeon, on stage for the next session. Thank you.
Good morning, everyone. So today we are here gathered. Welcome to the session in the debate session on the induction chemotherapy in locally advanced head and neck cancer. This is a very important yet very controversial topic. So as we all know that induction chemotherapy has been there in the practice for over several decades, with some trials showing potential benefit in terms of organ preservation as well as resectability, while some are showing a decrease in the incidence of distant metastasis. Yet, with the absence of overall survival data, its role remains investigational and debated. So, we are here to show the opposing remarks from 2 of the distinguished speakers. So, without further delay, let me introduce our first speaker. Before that, can we have this poll? Yeah. Okay. Yeah, so most are going for induction chemotherapy. Okay. So let's see how after the session the poll changes. Yeah. So let me introduce our first speaker, Dr. Anand Bamakrama. She is a consultant radiation oncologist at King Faisal Specialist Hospital and Research Center. with a residency training as well as the residency training program director. She completed her radiation oncology residency at McGill University and head and neck radiation oncology fellowship at the McMaster University in Canada. She is certified by the Royal College of Physicians and Surgeons of Canada, as well as licensed by CPSO and RAMQ. Dr. Bamakarma is also a certified patient experience professional and pursuing an MBA in international healthcare management at Frankfurt School of Finance and Management. Her work focuses mainly on advancing oncology care and medical education. So let's welcome Dr. Anand.
Assalamu alaikum. Good morning, everyone. I'd like to begin by thanking Prof. Al-Shamsi, Dr. Abu Ghaida, Dr. Al-Ghamdi for this kind of invitation. And thank you to the organizer and scientific committee for putting this together. So I was asked to convince you and my dear colleague, Dr. Ibrahim, to why using induction chemotherapy in head and neck cancer is still important. And I'll try to do this in 10 minutes. So Bismillah ar-Rahman ar-Rahim. Let's start with where induction chemotherapy has made a real difference. And that was clear with many large trials testing the induction chemotherapy, specifically with GEM-CIS in non-keratinizing nasopharyngeal carcinoma. And it clearly showed the benefit, and that already has changed practice. However, for the interest of our debate today, we're shedding light on non-nasopharyngeal head and neck squamous cell carcinoma. And I'm starting with the McKinsey meta-analysis that looked at the benefit of chemotherapy in general with the across the three strategies, the induction, concurrent, and adjuvant. Although the induction chemotherapy did show overall survival benefit of 4.5% at 5 years, as well as distant metastasis benefit in N2 and 3 DCs. However, the winner was the concurrent chemoradiation with cisplatin chemotherapy, and that was the standard since the trial. So why consider induction chemotherapy? With improved local control, distant metastases has become a significant challenge. And this is where potential induction chemotherapy comes into play, as well as the theoretical concept of downstaging, improving outcomes, and minimizing toxicity for better quality of life for patients. 5 randomized trials looked at the benefit of induction chemotherapy followed by concurrent chemoradiation versus chemoradiation as a standard. And despite the fact that the DECIDE trial showed 3-year distant failure survival benefit and all the benefit that we're seeing in the highlighted in the green in different outcomes, however, those trials have their limitations. For instance, the American trials noted that the overall survival was higher than expected in the control arm, which could be due to HPV contribution. Other limitation as the lack of power, and also more importantly, the randomization was not based on the current standard chemotherapy, so it was other regimens other than cisplatin. So it remains to be demonstrated whether induction TPF followed by cisplatin-based chemoradiotherapy was equivalent or superior to the standard of care concurrent chemoradiation. And this randomized phase 3 trial comparing the induction with the TPF to the current standard, the radiation with cisplatin, it didn't show at first any benefit. However, when they looked at the analysis of per protocol, it showed, as you see, the difference between the two groups and survival. Here they're shedding light on resectability and comparing advanced stages of oral cancers with the same induction chemo, 2 cycles, then MDT to assess the resectability. There was a gain in this trial with 43% resectability chance, and that was reflected as well into survival benefit for those patients. Moving forward to another trial by Tata Memorial looking at the mandibular preservation, and that was a win. Patients with advanced stages of oral cavity and where the surgery would be requiring mandibular resection, they randomized them into upfront segmental resection versus testing the benefit of neoadjuvant TPF for 2 cycles and then surgery. And with that, they achieved a mandibular preservation higher by at least 17% to what they set at the beginning, and there was no positive or closed margins in their analysis. Here, paranasal sinus and nasal cavity extending to the orbit, the benefit of induction chemotherapy was translated into 82% achieved preservation of the involved eye, and also a benefit in overall survival. Now talking about the larynx hypopharynx preservation, and the evidence is clear in here. Back in the days with the VA trial that looked at the benefit of chemotherapy to try avoid the laryngectomy, and we established from there that advanced disease, in advanced disease going for a neoadjuvant PF 3 cycles, then if complete response or a partial response, radiation alone is better than total laryngectomy. And from there, the RTOG 9111 introduced the arm, which is the standard care now, of the concurrent chemoradiation with cisplatin-based chemotherapy. And although the induction followed by radiation did show organ preservation, however, the winner again was the concurrent chemoradiation, which is the standard of care. And the EORTC, it's the same randomization as the VA trial, however, they looked at hypopharynx cases, and that was also translated in a benefit. I'm showing the last one on the corner on the right to reflect the benefit of this approach in the laryngectomy-free survival, which I believe should be the outcome that we're looking for when we talk about organ preservation rather than just a larynx preservation. And that was 28.9% with TPF. Chemo selection. The Michigan University had taught us the tool to test induction chemotherapy for a cycle and then see if we're going into the right direction. Otherwise, we switch the plan of organ preservation into laryngectomy, trying to avoid the possibility of going for salvage laryngectomy later on. And the one at the top tested this with a different regimen induction with the theory that the TPF is a toxic treatment and they're trying to use other than PF induction chemotherapy. What about distant metastases? We have here several trials with their limitations, yet it showed benefit at with the decrease in distant metastases translated into survival in the first one, and then also the other ones too. Specifically in advanced cases with the N high risk, N2, N3 high risk for distant metastases. So reduction in the tumor volume, here again I'm listing a few of the trials that looked specifically into measuring the impact of induction chemotherapy into the volume itself. And on the first one you can tell that there was a good percentage of response rate, and that was translated into a distant metastasis-free survival benefit. Also, the tumor volume response ratio, when it goes more than 50% following the induction chemo, it reflects into 3-year overall survival benefit in the second trial published in 2022. And the last one also confirming the same benefit of tumor reduction. And that allows us as RADONC to go down with our dose and the possible toxicity. I'm not talking about this one. However, I just want to show you that the concept of induction chemotherapy was tested with the HPV group patients to sort of de-escalate the radiation part later on following the induction chemotherapy, and they were successful in showing some results. However, this is still investigational. So for larynx, hypopharynx preservation, I think induction chemotherapy is strongly suggested for organ preservation. And that was clearly documented with their outcomes. However, outside the organ preservation, I'm not arguing here for changing the standard, but I'm saying that the induction chemo, when it's used for carefully selected patients, it has its value in reaching a promising outcomes, and definitely a good consideration for those with N2 and 3 disease and high risk of metastases, looking for decrease the risk of metastases. I definitely consider it for patients with a big tumor, bulky, trying to downstage and decrease the volume and avoid the all the bunch of toxicities that comes with the radiation. It is a winner when we talk with a patient who's resistant to go for a laryngectomy and insistent on going for organ preservation approach. Then we can use the Michigan tool. Using one cycle, if nothing is improving or the patient has stable disease, then we convince them with evidence that the best way to go is a laryngectomy. And then predicting response and also predicting prognosis. If you have a patient who's borderline between palliative and curative, and then you can test the water by giving induction chemotherapy, and then you sort of have clue to which direction you move forward. And induction chemotherapy, always the backup when I'm Ali coming from a faraway city towards the end of Ramadan, where I cannot set the plan of radiation for him in 2 days. However, my medical oncology colleagues would be able to start him on treatment in much faster than me. Thank you.
Thank you very much, Dr. Anand. I would like to invite our next speaker, Dr. Ibrahim. He's the chairman of Radiation Oncology Department at the King Fahd Specialist Hospital. He's completed his fellowship training at the University of Toronto, followed by neuro-oncology and radiosurgery at University of Montreal. So Dr. Ibrahim is going to speak against the notion. So you can, stage is yours.
So good morning, everyone. Induction chemotherapy is still relevant in head and neck cancer? Short answer is no, it's not. So I'll tell you why. As mentioned by my colleague, the use of induction chemotherapy started a long time ago in the VA trial, where induction chemotherapy versus surgery was used to preserve the larynx, and it actually ended by having a very good laryngeal preservation of 64%. Without improvement in the overall survival. Bear in mind, this was compared to surgery, not compared to the standard of care, which is concurrent chemoradiotherapy. When the induction concept with BF at the time, compared to the standard of care, concurrent chemoradiotherapy in the R2G9111 trial, what did it show? It failed to show any improvement in the overall survival, and it's also showed lower results in laryngeal preservation. In other words, if you compare induction chemotherapy using PF versus concurrent chemoradiation will be better in laryngeal preservation, better in local regional control. So it's not good. One might think this was done at the era of the doublet chemotherapy where we use PF. Now the standard is the triplet TBF. It's much better in terms of local control. It's much better in laryngeal preservation, and shown by the GORTEC trial. But keep in mind, all those trials, the TAX trials and the GORTEC trial, they were comparing PF versus TBF. There was no head-to-head comparison with concurrent chemoradiation. And here it comes the main question. The question is not to use TBF or BF. The question whether we should use induction chemotherapy or go ahead with the definitive treatment, the standard of care, which is concurrent chemoradiation. There have been 5 different trials as shown by Dr. Anand a few minutes ago, and I'll show you 2 on the US trials. Induction chemotherapy, all using TBF, the modern one. Induction chemotherapy versus concurrent chemorad. no overall survival. Basically, no benefit. Although it showed some trend, as mentioned by Dr. Anand, toward improvement in high-risk patients in 2 and 3. Paradigm trial, to make it short, same result, no overall survival benefit. Though this slide already shown by Dr. Anand, and if you see, there have been some improvement in one of the trials in the distant-free metastasis, but this was not translated into real benefit in overall survival. If you take all the trials, including the Spanish one, which have been highlighted early on, if you compare it to cisplatin-based concurrent chemoradiotherapy, there was no overall survival benefit. So, this was confirmed in the MATCH and C trial, published in 2009, and also confirmed in the updated one published a few years ago, where you can clearly see that there is the only one that showed any improvement is the concurrent chemoradiotherapy. I think this is very clear that induction chemotherapy, as you can see clearly, is not benefiting the patients in terms of overall survival. So again, the only one which has overall survival benefit is the concurrent chemoradiotherapy. So it's not only it's something that doesn't really improve the overall survival, but it's very toxic, very toxic. If you look to the trials that I showed you earlier, you will see that a lot of hematological toxicity, specifically febrile neutropenia, and also mortality rate of 6%, according to the GORDIC trial. They were using antibiotic prophylaxis, they were using GCSF, and still 6% death. Very toxic. It's not only toxic, it causes delaying the main treatment, which is the definitive concurrent chemoradiotherapy. So you are depriving some patients, actually, according to what you can see, from having their appropriate definitive treatment. It's not good. So why we should not use it? Because it doesn't add anything to the overall survival. It does increase the toxicity, and it also delays the definitive treatment. So don't use it. Do I use it? Yes. To be honest, I had to play the bad guy. Do I use it? Of course I do. When it's, as mentioned earlier, for clinical crisis, when you have patients that actually not treatable with definitive concurrent chemoradiotherapy, patients with a huge stage, patients with impending airway obstruction where you need a quick decompression, downsizing, this is where induction chemotherapy is good. For those patients, and if I use it, for example, for laryngeal preservation, of course, the number 1 and number 2 and number 3, the only subsite in head and neck where the rule is well established is larynx. So if I use it for laryngeal preservation for non-operable patients or patients refusing surgery, I'll be using it for laryngeal cancer. Otherwise, the standard definitely, if we can wait, if I can do it in appropriate timing, concurrent chemoradiotherapy will be the way. Thank you.
I think yes, the notion is quite mixed against and as well as for. So we are open to questions.
I think both are good. Here you're talking only about overall survival. You don't talk about local control. With induction chemotherapy, definitely you reduce the size of the tumor, you better contour your plan, you can escalate the dose, and therefore you get better control locally. That's one thing. Second thing, most of these patients came to stage 3 or 4 that need immediate intervention. And radiotherapy, by its practice, takes a long time. Maybe it takes 3-4 weeks before you can plan the patient and put them in sorts of while you can start chemotherapy immediately. So give induction chemotherapy would help you to control the disease until you get your radiotherapy ready. I can tell you from my personal experience, I've been 50 years in the field, And I did induction chemotherapy. We had a protocol called Price Hill chemotherapy, which is before the tax. And honestly, day 1, day 14, by the time you come to radiotherapy, the disease almost completely disappeared locally. And these patients, I have some of them that treated at Tawam 36 years ago. Head and neck, nasopharynx, larynx, and hypopharynx.
Thank you, but studies didn't show that. Trials didn't show it. Local control in the R2G trial was better with concurrent chemoradiotherapy, significantly better. Laryngeal preservation, significantly. And this was done with the PF, not the TPF. Easy. No doubt.
You have a second question? Go ahead.
Thank you for the nice talk. I'm for induction chemotherapy in certain situations in certain sites. We also have some new data on the use of immunotherapy in the induction setting for oral cavity, which has shown survival advantage. So it's an emerging, induction. I think it's going to be more emerging as systemic therapy improves, and that's what's happening right now. But my issue with induction systemic therapy, and probably this pain is shared by my radiation oncology colleagues, is that your volumes are always a struggle, your contouring volumes after induction chemo. What do you include in the high dose, in the intermediate dose, areas that were very clearly involved in the GTV, especially in the nasopharynx when it's involving the skull base or the cavernous sinus. To what dose do you take that? And I think there's still evolving research in that area, but it's always a struggle, to be honest, because these cases are very different, their responses are very different, and that's my only issue with induction systemic therapy. So you have any comment on that?
What part? The induction volumes or the immuno or the oral cavity or all of the above? So first, immunotherapy, I agree. It's the way to go, but not chemotherapy. Because TBF, what we are using right now, it doesn't seem to improve the survival. And it's toxic. Okay, so this is out. Second was about oral cavity. Oral cavity, yes, Indian data, but keep in mind the Indian trials or the Indian experiences to make patient operable for oral cavity. It's not patients that will go for definitive treatment, and all I showed you here, something different. It's patients that will be treatable for concurrent chemoradiotherapy. It's downsizing for us, for radiation oncology part, not for this surgery. So those are different. And I also honestly believe that induction pre-op chemotherapy, let's say, pre-op chemotherapy is good for oral cavity, but we need good evidence. Last. Volumes. Volumes, we're talking about how difficult it is. Nasopharynx. Nasopharynx is completely different. We're not talking about it. And there have been a study right now, I think, recently, last year, how to define volumes and based on the pre and the post-treatment volumes, which we don't do, because we are scared that whenever we take only the residual disease, that will be ending with the local recurrence. And as mentioned early on in the prostate cancer, local recurrence for us is the worst thing we can have. And it's so difficult to salvage. So, yes.
No, I think we're just going to conclude. As a moderator, let me take this liberty to give the conclusion slides. So yes, it's a good mix for and against. And I'm from the Head and Neck Institute with my colleagues from Radiation Oncology at Burjeel Medical City and Burjeel Cancer Institute. Next slide, please. Next slide, please. So, basically in all the head and neck subsites, we have the surgery, the radiation, as well as the medical oncology. And every subsite has some good, some bad, and some ugly. Next. Larynx, very clear. Nasopharynx, very clear. Tongue base, very clear. Where is the problem? The problem is in the oral cavity. 50% of our tumors are in the oral cavity globally. Asia, probably 70%. So what is resectable what is unresectable and what is technically unresectable. So in unresectable tumors, no doubt, no role of surgery. That's the ugly one. In the technically unresectable one, which was the question of the gentleman, where it is kind of going high skull base, where your treatment is going to cause more damage to the patient than your treatment modalities. In these cases, there is some role of induction chemotherapy. Next slide. So yeah, we just talked about this resectable and technically unresectable, and the upper limit for a surgeon is kind of the skull base. The moment you touch there, you will not get a free margin. Next slide. So just to conclude, in technically unresectable cancers, yes, there is definitely a role of induction chemotherapy. It does help in organ preservation. In resectable cancer, Dr. Ibrahim very clearly said there is no survival benefit, no role of induction chemotherapy. But what we know is if you give induction chemotherapy and the patients who do well, this is like a bioselection. So probably we are looking at a set of patients who are giving good response. This is where you need to intensify your treatment. So the future lies in biology and biomarkers. So last slide, I'm just going to end up with this fantastic comment from Blake Carey. He says that in the realm of oncology, biology is the king. Selection, the patient selection is the queen. Technical maneuver are the prince and the princess. Now in our debate, it is the induction chemotherapy. Occasionally, the prince and the princess try to overthrow the powerful forces of the king and queen with temporary victories, but no long-term benefit. Thank you. We'll move on to the next session. Just going to, we have 40 moderators.
Yes. So I'd just like to welcome again everyone. The crowd is getting more, and I see more and more familiar faces. I'd like to thank the moderators, really. I didn't have the chance to introduce my colleague, Dr. Yusra, my colleague, Dr. Yegini, and my colleague, Dr. Yogesh. The reason why we have moderators in different specialties is honestly, so a lot of people are in astro, as you can know, but also we really want to have the input of the surgeons, the medical oncologists for the sessions. So for the next session, it gives me great pleasure to introduce the moderators of the session. And just to give you an update, Dr. Edward Black, who is the surgeon, who is supposed to be giving the surgical talk, has apologized because he's unfortunately really down with fever. So I will be the surgeon, so don't shoot me. So I will be the one trying to give you the surgeon's argument, which what we hear in the tumor boards. But without further ado, we do have two experts in lung cancer. It's my great pleasure and honor to introduce Professor Solange Peters. She's the ex-president of ESMO, and she is a lead in lung cancer, and she's coming all the way for the Emirates Oncology Society. And my dear friend and colleague, Professor Marwan Ghusson, who his name does not need further introduction. He's one of the most famous oncologists in the region, and he's also one of our great colleagues in Burjeel. Thank you so much. The stage is yours.
Thank you very much, Dr. Ibrahim.
As a surgeon.
Yes, thank you very much, Dr. Ibrahim, for this nice introduction, and congratulations for your first UAE GCC radiation oncology meeting. We hope that you'll get to hundreds of them, inshallah. Not tens, hundreds of them, inshallah. Okay. Dr. Solange,
just wanted to thanks again for the invitation. It's my favorite country. As you know, I come very often here, as often as I can. And I'm very happy to see that the radiation oncology has now its congress. It's very important because medical oncology usually meets several times a year, but radiation oncology is more and more technical and important in every discipline, you know. We try to cure with oligometastasis, with the stereotactic radiation, so we need to have congresses in radiation oncology. So wonderful to be here. Thanks so much.
Thank you so much. So again, I don't have slides because I was just informed. So I'll start with, this is a questionnaire for everyone. So obviously the group is, for the first time ever, biased towards radiation in a meeting. But I'll talk, I'll put the hat of the surgeon and we can start. So let's take a scenario. We have a 55-year-old smoker in a good performance status who presented with a screening detected lesion. This lesion is highly suspicious for lung primary, and his staging was negative. Sorry, before the staging, everyone will go for a biopsy, I would assume, right? Would anyone go without a biopsy? Okay, no biopsy. So for biopsy, sorry. So biopsy was adenocarcinoma. And the patient is very fit patient. And what would you guys, and by show of hands, would anyone offer SBRT, or would you, so who would offer surgery for this patient? Okay, even the SBRT guy. Okay. He's an early stage, stage 1, healthy, fit for surgery. So everyone will offer surgery. Well, I don't. But anyway, I have to be the surgeon. Okay. So you would offer surgery. Same patient, okay, with a smoker with a borderline lung function. Would you offer him or her surgery? He can go for surgery, but slightly higher risk. 50, 60, just for the sake of discussion. Young, exactly. Surgery? Anyone offer surgery? Okay, so we still have more and more surgery. So I would obviously be the surgeon now, so I would say surgery. So let's talk about the advantages of surgery versus SBRT. And I will stop here. It will only take 2 minutes. So we know when we are doing surgery, first of all, we have the material. Second of all, we are most importantly checking the lymph nodes in those patients who are fit for lymph node sampling. We do know that most of our patients are getting PET stage. Some centers do PET stage and EBUS as well prior to SBRT, but it's not the standard. So why give local therapy for someone who has micrometastatic disease? Also, if we look at the ongoing immunotherapy trials, with the neoadjuvant immunotherapy, we are able to see the response on surgery, on the surgical specimen. So with that, and we all agree, even without the medical oncologist being here, that immunotherapy or systemic therapy is the key in treating non-small cell lung cancer, because most of the patients die from metastasis rather than from local disease. So my debate or my argument is, with radiation, you really don't know how did this tumor respond. You're looking at images. You might be causing, there is also a very much difficulty in interpreting post-SBRT radiology changes. A lot of patients might be called progression, they are actually pseudo-progression, or a lot might be called pseudo-progression, but they are actually progressing. So we are missing the chance of curing these patients. So with that, I would stop here because I don't have a lot of arguments to push for surgery. But I just want to tell you what we usually hear from the surgeons in the MDTs. And maybe Dr. Solange and Dr. Marwan, you guys can also push for, why would you prefer surgery over radiation in those early stages?
No, I'm not a surgeon, I'm a medical oncologist, but there are maybe 2 or 3 things which we have very strong surgeons, so the argument we have the same probably as you in the tumor board with this kind of fight. I think the reason why we debated, first of all, is because we were never able to complete a trial between surgery and stereotactic radiation. All the trials trying to do that failed because it's very difficult to convince a patient to do that, telling a patient you are operable, but we will randomize you between radiation and surgery. There is a bias, right? The fit patient will say, I want surgery, and he will decline the randomization if he doesn't. So we were never able to really complete this trial. By pulling everything we have, to be very honest, the results are the same. Pulling the small numbers in each of the trial, or looking retrospectively to the data with a critical look, I must say local and distant control look to be the same. But it's not properly randomized, so it's not properly controlled, so you cannot really today confirm that. My surgeons were very disappointing when they saw that, because one of the arguments for surgery is nodal examination. You look at the lymph node, you make sure you don't have an N1, because if you have an N1, you need to give chemo and you can give immunotherapy today. So you will improve the survival of your patient because you know about the N1. And they were convinced, the surgeon, that there will be more local relapse, nodal relapse, and at the end, a shorter survival. What we have doesn't look like showing that. So, but again, it's not controlled. So maybe one of the arguments I very often have in my tumor board with the screening, because we implemented screening, is that you cannot do a biopsy. Too small nodule, maybe too central, difficult to reach. You know you will not make it. So probably the surgery is sometimes just mandated to have tissue, because the biopsy is a planned failure. And I must say, in these cases, we don't even try the biopsy, because if it's negative, you do surgery. If it's positive, you do surgery. So, but it's quite important, because in your country, it's a bit less in mind, it can be GFR mutated. It can be ALK, it can be something else. You'd like to know. And you also would like to know if suddenly you have an N1. So one of the arguments is sometimes a difficulty to have the certainty it's a cancer and the certainty of which type of cancer it can be. So there's probably one of the arguments. And the other arguments are really possibly how it's sold to the patient. If the surgeon sees the patient, if the radiation oncologist sees the patient, or the medical oncologist, the talk, the little chat will be completely different. In the UK, when they were doing the trial, they had the formal rule that they should all be together. Because if you just see one, he will bias the decision, oh, surgery now, do radiation. So they had to be together. The last argument is immunotherapy. Despite MD Anderson's wonderful data published in Lancet, the phase 3 was negative. So when you do stereotactic radiation and you want to improve your outcome by giving very short course of immunotherapy, there's no impact of immunotherapy. That's quite strange. It's even, if anything, it's slightly detrimental, but it's probably just a number, but it's not beneficial. While we feel like after surgery, there is room for immunotherapy. So can you handle a bit more, at the time being, immunotherapy with surgery or outside of radiation, maybe because we know how to do it better? So that's maybe one of the arguments, is the room for immunotherapy has still to be defined with radiation.
That was very, 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 very clear. So what to say after that? But just I have two small things to add. Being a multi-organ medical oncologist from the old generations, I have seen tremendous improvement in the treatment of breast cancer. And in the 10 recent years, we have seen revolution in the treatment of lung cancer. So I think that because it's so tiny, as you said, tissue is the issue, and molecular biology evaluation is the future. I think that we will have tests like Oncotype DX we have in the breast or something like that, where we will be able to help us to decide between stereotactic radiotherapy and surgery. For the time being, I like so much surgery. Sorry for our friends, radiation therapy. I like it for the patients who are frail, who are not able to do it, but I still go definitively for surgery. But let's hear our colleague, the radiation therapist, what he will say. Maybe he will surprise us. Maybe he will surprise us. So without any delay, let me introduce again Dr. Rana Irfan Mahmoud from MediClinic. We are eager to hear you.
Yeah. Thank you very much. Thank you for the invite. Yeah, so I think it looks like that surgery is the way forward. And I think the talk already had been perhaps more than what Edward would have said. So there is no missing his absence. And that's what my thoughts are, right? So we really don't need to spend next 10 minutes on anything, because we have already concluded that surgery is the gold standard. There is no argument, and khalas. Okay? So, but when I think more about it, I feel that all what we talked about is a very standard fit case, which Ibrahim highlighted as the first one, and possibly was being highlighted by my colleagues. And we are saying lobectomy is a gold standard in a standard case. So that's my starting point. Let's agree on that one. And then comes the high-risk operable case. And again, when I was thinking about this talk, I kind of went into that trance. And I said, okay, can we say that SBRT is a gold standard for inoperable frail patients? So we have an agreement already that for inoperable frail patient, no arguments. SBRT is the standard. For operable fit patients, no argument for whatever reasons highlighted. Surgery is the standard. So, but then there is a bigger group in the middle, and that is where this is the slide which come to my mind. I created this just on a cup of tea, just to sit back and see how I look at the pool of lung cancer patients in my practice or other people's practice. So I would say that there are we're talking about early lung cancer, T1, T2, N0 on PET scan, and possibly mediastinal scope and everything, right? So when I see those group of patients, I can immediately put them into 3 categories, and more or less it is defined now, and I will show you how by American Thoracic Society. So we have inoperable patients, SBRT colored green, surgery colored red, not because it is bloody, but it is red. So everybody agreed on the previous slide that there is no argument there, and everybody agreed there is no argument there. So we are focusing on this high-risk operable case. And I will come back to this slide at the very end. There are only 8 or 9 slides, by the way. This trial, I will just show you a couple of slides, or maybe just one slide, RTOG 0236. That just firmed up what we already believed, that inoperable patients should not be left alone. They should have SBRT. This is the data collected by American College of Chest Physicians and Society of Thoracic Surgeons consensus statement for high-risk stage 1 patients. And what should they have? That will determine how we are looking at that group. And at the end, we finally have a revised STARS. People who practice SBRT lung, they remember that there was STARS and ROSELL, but that was showing that SBRT is very good for operable patients, but the numbers are very small, follow-up was very short, so STARS was revised, okay? So let's move on very quickly to NCCN guidelines. What does it say? It says exactly what we have already agreed as a group, that for operable patients, go for surgery, inoperable patients, go for SABR. Okay, no argument about it, and we are not arguing about it. This is the standard dose of SBRT. I don't have to spend time on that one. So RTOG 0236 is what I just said, just firmed up our belief that for inoperable patients, we should just treat them with SBRT. But it just defined in the inclusion criteria for our MDTs to be more objective instead of just Edward saying inoperable, but somebody else in the other MDT saying operable. So it basically just defined the eligibility criteria. It's the largest North American study where all T1, T2s, FEV1, medically inoperable, has to have less than 40% predicted, number 1. Number 2, post-op FEV1 should drop less than 30% predicted. And DLCO should be less than 40%, or they have baseline hypoxemia, hypercapnia, pulmonary hypertension, diabetes, severe cerebrovascular, cardiovascular disease, chronic heart disease, all kind of stuff. So very unwell patient who everybody thinks that, well, this is inoperable. We can't put him through anesthesia. So that was the category of patients in RTOG 0236. And yet, these patients lived longer. This is the patient course. We already knew that this is the phase 2 trial, remember? This is not a randomized trial between doing nothing or that. But this is the overall survival and progression-free survival. And you can see, I don't know whether on your screen you can see that or not, but it goes to nearly 3 years and more than 50% patients having disease-free survival of 50% on 3 years. And that is those patients who are so unwell and their tumor could have been just left untreated, which wasn't. So I think RTOG 0236 closed that thing, which we already agreed, so we don't need to waste time on that one. Now we are moving on to the middle group of patients where we said that, okay, they are high-risk operable patients. And this is, again, an interesting trial, Alliance trial, again, the American trial, which basically, again, if did nothing, at least defined what is high-risk operable. Okay, so these are the patients who are not that category, which was in RTOG 0236. They are slightly better than that. So they are supposed to have 1 major or 2 minor criterias. FEV1 less than 50% predicted. Remember, in that one, there was 40% predicted. Again, DLCO in that one, 40%, this is 50%. Minor criterias, elderly guy, patients, FEV1 predicted is low, all these other things as well. So you have to have 2 minor or 1 major to say, well, this is operable but high risk. What do you mean by high risk? You mean by high risk is that there is morbidity and mortality you have to sign up for if you go for surgery. And what surgery we are talking about? We are talking about not surely lobectomy, because lobectomy for these patients will be possibly will be end of the road. So this is why there is something called sublobar resection. And the sublobar resection, which basically will mean either you're doing segmentectomy, an anatomical segmentectomy, or you're doing a wedge resection, which introduces the fact that there are patients then with closed margin, positive margins, recurrence rates will be higher than lobectomy. Remember, lobectomy is the standard of care, not the segmental or the wedge resection. There is data that in some patients it works very well. However, then it opens up the alternative, which is SBRT. Because SBRT, yes, against lobectomy one can argue, but if you're not doing lobectomy, you're only doing the wedge resection, then SBRT could well be an option. However, this trial just focused on the overall survival and disease-free survival there. Remember, so this trial, the curves I'm highlighting here are basically, there are two curves you can see. You can ignore the second curve because this trial was doing sublobar resection plus minus adding brachytherapy for the positive margins or closed margins. So trial was negative for brachytherapy part to say brachytherapy did not add anything. However, just focus on one curve because they are overlapping anyway, that what will be the outcome, potential outcome after sublobar resection. So this is the consensus statement for those high-risk patients, which we just highlighted on the previous slide. I just summarized that instead of the whole consensus document, and that will be that your oxygen consumptions, DLCO, FEV1, we already knew it correlates with mortality and morbidity. It just says that, number one. Number two, when it comes to sublobar resection, wedge resection is the worst. Anatomical segmentectomy is still better than wedge resection. So it says it will be preferred option. And then consensus statement from the society was that SBRT is preferred over conventionally fractionated radiation. Again, there is no argument in the radiation community about that. But one thing they also came up with that some MDTs suggest that, oh, well, just ablating is the whole thing, then why not just do RFA? So RFA results are way inferior to SBRT, and that is what I'm not going to go to the details, but this is the consensus statement from the society that only reserves RFA for somebody who has got so low reserves that even SBRT is not possible. And here is the data they accumulated from various trials, and the top table here is talking about lobectomy or sublobar resection, and the bottom table, number 6, is talking about the SBRT data accumulated from the literature in this society meeting. So if you can clearly see, I don't know whether this is presenting it good on the screen or not, but you can see that sublobar resection was way inferior to lobectomy, which is, again, which we don't want. We want lobectomy, if possible, yes. If it is sublobar lobectomy, then, of course, you should open about SBRT. Why? Because SBRT, if you look at the 3 years primary control rate in two largest trials, is 92 to 95%. Remember, surgery or radiotherapy or SBRT, we're only interested in the local control. Distant disease is a different thing, and that is where we will come to. Cancer-specific survival, again, approaching very high numbers, and these numbers are equivalent at least to sublobar resection, if not lobectomy, in high-risk patients. So the final study which I was going to show you was revised stars. So revised stars is called revised stars because all the limitations of the original stars with small number of patients, shorter follow-up, was compensated on this one. So very clean trial for very small tumors, but having the patient who is otherwise fit for surgery. Their FEV1 and DLCO is very acceptable. So the patients had SBRT, and then they had a pre-specified comparison to surgical patients. They were not randomized. But when you look at the final outcome, you see that even in operable patients, as far as the local regional control is concerned, equivalent. So that is the data which now goes on to 5 years. So this is 5 years rate of recurrence was 17.6%, same lobe recurrence 6%. And that is exactly what you will expect after surgery. So this trial stamped the possibility of bringing SBRT for operable patients. And that is where we are currently. This is the closest we get to the randomized comparison. And randomized comparison, anytime you do surgery versus not surgery, is extremely, extremely hard. I completely agree with you. In UK, despite the fact that you have NHS and all kind of things, we did 2 studies. I'm a GU oncologist mostly. So we did SPARE trial for bladder, failed to recruit. And then we did the SPACE trial for surgery versus SBRT for prostate, very hard to recruit. We recruited, still managed to achieve the numbers, but it was extremely hard to recruit. But you would think that it will be because the patients want to have surgery. Our experience we found in SPARE and PACE is that the patients, when they were told equipoise during the consultation that, oh, we think that surgery and SBRT is same, but you want to randomize it, they will say, well, if it is same, I don't want to have surgery. So the patients were refusing the trial to basically not have surgery. It's the opposite one which we found the difficulty. And the last slide here is the Japanese data, where basically it just took all the SBRT patients in the Japanese multi-institutional database, plug it next to the Japanese and American data for the surgical outcome. And this is the one where you should focus down there, that for stage 1 and stage 1B, you see, as far as database was concerned, this was very, very equivalent. And remember, these are those patients who are operable and otherwise fit patients. So, in my opinion, I will show you that the same slide, colorful slide again, because that's where I think we have to think about as categorizing these 3 patients. And I fully agree with the comments made about the systemic therapy, that surgeons and radiation oncologists will always argue with each other, but only in terms of the local control. However, we do know that lung cancer is not a local disease. We are rapidly learning about it. And that is where the adjuvant treatments are coming in. So it just does make sense that if you want to ablate with SBRT, you should still be thinking about 35% distant relapses, which we see even in stage 1 cases. And can you do anything? So this is Swedish asteroid, which is going on for durvalumab, and this is the Pacific 4, which is going on for durvalumab. So just concluding, just the final slide again, which I showed at the very, very start, that right now, every time we see a patient in the MDT, we should identify them into one of these 3 categories based on pre-specified eligibility criteria for these trials I showed you. So if it is inoperable, no question, SBRT. If it is high-risk operable, instead of doing sublobar resection, offer SBRT, in my opinion, because data is same or maybe even better, but there is no randomized trial, and perhaps there will be never randomized trial. However, all the evidence is showing that it is not inferior to the doing surgery. And we are talking about biopsy-proven cases, so you do have a tissue as well, if tissue was the only reason for doing surgery. The operable patients, this is where the door is opening, because there are patients who will look at that data, the Japanese data, the American data will just highlighted there in the revised stars, will say, well, I mean, if I can go ahead with SBRT instead of doing surgery, why not? So that is where we are heading. So SBRT is moving in this direction, and eventually surgery patients will be shrinking. But as I highlighted in the previous slide, we need to work very closely as a team to make sure that we don't lose sight on the systemic recurrence.
Thank you very much, Dr. Rana Irfan. This was 12 minutes versus 5 minutes. Just to tell you how much radiation therapists are swimming hard, trying to get it into. But you convinced, I think, a lot of us that SBRT might be or should be in the future. I don't know, might be or should be in the future of the treatment of those very, very, very tiny lesions. I have 2 questions. First question: do we have strict criteria, radiological criteria, on the efficacy of SBRT, trying to say if there is any residual disease without doing any other biopsies? This is number 1. And do we have any studies on circulating maybe tumor DNA after SBRT? Maybe it will help us also in our decision.
Excellent. Thank you very much. But 5% you only counted for Ibrahim. You did not count 10% of you too as well. So that was 15 minutes versus 12 minutes. Okay, so So the first question is about how do you response assess after SBRT? This is not clear. So we do not know whether this scar-looking lesion is an active lesion or not active lesion. People are not biopsying it, and PET scans are not really that helpful. So what you're looking at is, in radiation world, you're looking at two things. One is the growth of the primary lesion, number one. And number two, you are looking at a new lesion appearing adjacent to the previous lesion or in the same lobe, if you are talking about eventually lobectomy versus SBRT. So short answer to your question is that there is no identified and well-agreed criteria for assessing response in terms of objective RECIST criteria. So that is not available. In terms of the second question, which was the circulating tumor cells, again, for the early lung cancer patients, we do not know. But of course, you know much better than me for advanced cancers that it is becoming rapidly established in many other cancers, including lung cancer. And will that be applicable in future to stratify those patients who we believe that following SBRT, they will benefit with immuno rather than having a negative trial, as Professor Peters highlighted, for all comers. And that is where I think we are heading, because we do know that SBRT does provide an opportunity to have a spatial and temporal cooperation with immunotherapy checkpoint inhibitors. We know that from the oligoprogression trials and the oligometastatic trials. So whether in early stage lung cancers, it will also be true whether we have enough biomarkers, including circulatory tumor cells. How are we going to use that? I think that is where the future studies are going to be, rather than just focusing on surgery or radiation, because that is where they are going to show that they are equivalent. And if somebody needs to take thing out or blast it, it should be the same result, depend on the patient preference.
I have three remarks, but two questions for you, which are quite important. First of all, you're perfectly right about, and it's being seen by the vote, the equipoise. I mean, when we see the patients, we have probably a historical bias for surgery. Also because the surgeons are usually more vocal than the radiation oncologists, they speak louder. But not only that, and there's really kind of because radiation was not the same quality 15 years ago. So it's a generation gap, right? Sometimes we think that radiation cannot lead to cure. So there's something also in the general population. So the equipoise, if you present the things concretely with the three categories you define, I think the discussion is healthier. It's kind of stricter. Immunotherapy, you've shown Pacific 4. I think we still struggle about how to combine immunotherapy and radiation. I also did this BMS trial, the 73L, where we had lots of pneumonitis. The pembrolizumab equivalent trial is negative. So I think that the main question point is, sure, they collaborate, but how to fraction, how to give, what sequence. It's really something. And maybe my last remark would be about ctDNA. More DNA than circulating cell. We now start to have amazing assays, multi-omics, methylation, plus mutation, looking at introns and so on. And at some point, they will be okay for early disease. Now not, because at the time being 95%, 90% negative because of the small size. But at some point, we will have them. And this will be very useful for the follow-up of patients. So this will define the future.
Yep. I think you are absolutely right that we're talking about even stage 1B. The patients do not really fail in the local area. That is why the topic of SBRT versus surgery perhaps is an ancient topic, because these two doesn't make any difference. So you can choose either depending on the patient preference. The only thing I can add in your comments is that when you talk about radiation pneumonitis and the pembro, for example, as you rightly pointed out, that the radiation techniques are improving. We have identified the right appropriate dose fractionations, volumes, image guidance, breathing controls, all kind of stuff. So if somebody did a trial for pembro and radiation showing pneumonitis 10 years ago is not relevant anymore, number one. Number two, majority of the patients with a single small dot in the periphery of the lung will come in for a single shot of SBRT. And that is it. You come in, get a scan, single shot, done. So, and that opens up many things. Number one, it opens up the logistic benefits. Number two, recovery and things. Number three, if you were going to give systemic therapy, it's all yours now rather than having post-operative complications or even VATS-related complications or whatever. So for local disease, for local control, that is what the topic is. And I think for that, we have reached to a point of very clear mindset, inoperable SBRT, high-risk SBRT, for operable, knocking the door of the surgeons to say, let us in.
Two very short questions just to finish. The middle category, right? The trial was going up to 5 centimeter. Do you really consider SRS for 5 centimeter tumor? And second thing, just 2 words about your next competitor is RFA, radiofrequency ablation, because my interventional radiologists are terrible. They always tell me we're as good as surgeons, right? So what do you answer to that? So very short answer.
Yeah. The first question of 5 centimeter, again, we have learned over time that single shot versus 3 shots. So that is easy. 5 centimeter, we'll give it 3 shots and give the same biological dose. The second question is also very easy because your radiologist can say whatever, but American Thoracic Society looked at all the data and concluded that the RFA local failures are higher than SBRT. So that is why the consensus, 100% expert consensus, was reserve RFA for those patients who are not suitable for SBRT.
Thank you.
Thank you very much. Thank you.
No one else but Dr. Rana can really defend our profession. So we have a slight change on the schedule. Since we have a nicely audience right now, we have a small gesture. And afterwards, we want to invite everyone for a group picture. So for those of you who don't know, every field struggles to start. And it's always difficult to start something. And today, under the leadership of Emirates Oncology Society, we thought we need to really thank someone who has given this field and continues to provide to this field on a daily basis. He is the founder of radiation oncology in the UAE. He is the person who started the largest prospective cancer registry in Tawam Hospital, way before even I thought about going into medicine. And he's still practicing. And the nicest thing about him, he's very supportive, always attending our meetings, always supporting new talents. And he is a real good mentor for a lot of us. So without further ado, please welcome Dr. One more thing.
The first lifetime achievement from EOS few years back.
Correct. And he is the awardee of the first.
It's never enough for him.
Correct. Exactly. The first awardee of the lifetime achiever in the US. And I really want to thank my friend and brother Humaid for really acknowledging the field of radiation therapy since I got him here as well and supporting this conference. It would not happen without your vision and insistence on having this meeting in parallel with the US session. So thank you, Professor Humaid and Dr. Falah.
Also part of the US. Yes, Dr. Arfan.
So can we call everyone, please, to come join us? We'll do 2 lines. For a
Yes.
Okay. Now, I'm speechless, actually. I'm very humble, but I'm very proud. That's one thing. When I started at Tawam, 86, it was only me and one other doctor at Sheikh Shakhbout, now called Mafraq Hospital. There were no radiotherapy anywhere in the Oman, Qatar, Kuwait they had, Bahrain, and Emirates, only us. And it was a cobalt machine in the basement with handmade contouring, on the wall contouring. We didn't have anything. And we managed to treat, amazingly, 10,000 patients on that. And it was only me and another one. Now, mashallah, when we see all this group, and with about 10 centers of excellence in radiotherapy with the advancement that we have. I'm proud to be part of that. That's all.
I'll stand over here. Thank you.
Thank you so much for everyone. Guys, stay. We're still on schedule. We need to. There are still more talks. Can I have the agenda? Next. Okay. So I think. All right, guys. So we want. Micheline? Agenda. Thank you so much. Philip. Okay, so ladies and gentlemen, we will continue. أعطيهم 2 minutes بس. يريحوا. Okay. Okay. So, good afternoon, everyone. We will continue. Just a couple of words. I need Dr. Majid. So, guys, we do have our opening ceremony for the EOS meeting at 12 p.m. sharp. So we are trying to stick to time. We are, I think, 15 minutes late now. So I'm going to ask the moderators, not the speakers, I'm going to ask the moderators for the next 2 sessions to really try to speed it up because we do have our session. So I would like to invite my colleague moderator, Dr. Ibrahim and Dr. Yusra, for the stage to moderate the next talk. And, Dr. Ibrahim is moderator. He will stick to time. I know him. So at 12, we need to be at the main opening. Okay. So both have been introduced, so all yours. Well, Doctor.
Thank you so much, Dr. Ibrahim. For the sake of time, I'll just carry on with the next session. I'll start with Dr. Saif Al-Jibab, who's an assistant professor in radiation oncology at King Saud University in Riyadh. He finished his residency training in Ottawa. Then he followed a fellowship specifically in proton therapy in University of Washington in USA. He will be talking about that in a minute. But before that, please don't forget to do the survey, the active poll. Please scan the code and do it. Whether you will be for proton therapy for common cancers, yes or no.
Thank you. I'd like to thank the organizing committee, EUS, and the scientific committee for inviting me today to speak. And thank you to Prof. Hamd Shamsi, as well as my colleagues, Dr. Ibrahim and Dr. Majid, for inviting me. And
so just for the probably sake of time, we'll have a quick, small change in the program.
Okay. Are you sure? Okay.
Sessions like that, it's not uploaded.
Sure. No, I'm more than happy. We're going to start with the opponent, actually, who I'm actually thrilled that he will come up, because I just found out that he's also an Ottomanian, so he's also from the University of Ottawa. He's my senior. So it's out of respect that I also want him to... Pleasure to see you.
So welcoming Dr. Salim Shamas on the dais.
Thank you very much. Thanks, Brahim, for asking me to address this issue. Let me start by saying I am not against proton therapy. Okay? Proton therapy has its indication, definitely. I just wanted to point out some of the controversies that is coming on board. This is what's happening in the US. There is 46 proton therapy in the US versus 3,500 linear accelerator, 137 centers of proton therapy operating throughout the world. This addresses less than 1% of our patients. The expenses are extremely high to install a proton therapy, but is it worth it medically speaking? We all know from the radiation oncology, people hear the BRAC, there is no laser, is there? There is, but it's not visible in the white. Okay. So this is the BRAC peak, which is the quality of the proton particle. Basically, in 2 words, it deposits the energy at a certain depth in the tissues, and subsequently, very sharply after that, the particle dies, not depositing any energy. So basically, sparing the tissues after the area that we want to treat. The photon beams that's outlined in red, you know that there's an exit dose that comes out in the normal structures. And this is basically a comparison for the same patients between the proton and the photon, and the area that's outlined in brown, which is the spill-out dose of radiation, which we're trying to minimize with the proton therapy. The big question is it clinically relevant to do this for the complication? This is a recent article, 2024, coming from New Zealand, comparing 2 cases of proton versus photon brachytherapy, and they documented with their DVH that not always proton is better for certain cases. And this is a trial that we talked about a lot, not prophylactic, craniospinal irradiation for leptomeningeal disease with photon versus protons, and it shows the big advantage of protons. The big question is, are we comparing apples to apples? Involved field radiation versus craniospinal irradiation. This is not the same. Obviously, when we treat the whole craniospinal axis for disseminated disease, the results should be better. The questions that should be asked, should we treat this craniospinal of photon versus proton? And this would be more of a logical question to ask in this field. There is now a trial, the BN014, that's addressing this issue again in a randomized trials of focal irradiation to the brain versus craniospinal axis irradiation for leptomeningeal disease. And this is a real world experience of proton versus photon and craniospinal irradiation. They documented that there is not a significant improvement in overall survival. Obviously, this is a nasty disease. This is a terminal cases. More importantly, the side effects of the 2 treatments were not significant. Mind you, this is a small number of patients, so the statistics are a bit touchy in terms of delineating what's what. Most of the proton literature started with the CNS tumors. Now it's expanding to other sites of newly diagnosed glioblastoma multiforme, this deadly disease. We can see that the progression-free survival and the overall survival is no different between the 2 modalities. The cognitive decline, which is one of the major issues that we look at, is again similar, and it's not significant. Brain necrosis. In the early areas where proton therapy was instituted in the treatment, We didn't know much about what happens to the particle after it reaches a certain depth, and the radiobiological effectiveness changes as it goes into the tissues. And these are cases where they documented brain necrosis at the edge of the radiation field with the proton therapy. It's no more an issue because now they have mastered it, and that the treatment planning systems are taking into consideration this effect. So we are seeing the brain necrosis less and less. In the schwannoma, the benign tumors, this is a study 2023 where they documented that the hearing recovery or the hearing loss is more pronounced with protons than with photons. Again, we talk about small numbers of cases that and not randomized in terms of treatment. It's coming on board the esophageal cancer because of its location, especially the distal esophagus where we have the myocardium, the lungs, and the liver in certain cases in close proximity. And again, proton versus photons, there is no difference in medical outcome in terms of disease progression or overall survival. The quality of life, again, on several issues, have documented no statistically different difference. And the Netherlands just launched now, this was published a few days ago, the indication for proton therapy in esophageal cancer. And basically they have put a whole slew of recommendation. Once the patient fits all this, then he is referred for proton therapy and is covered for the treatment of proton therapy. There are cases where proton has an advantage in esophageal cancer, but it's not overall. And the prostate. And a lot of people are talking about the prostate, reducing the side effects, rectal side effects, bladder side effects. And this is presented at ASTRO last year, the particle quality of life, where they stratified people to proton therapy versus intensity modulated or VMAT radiotherapy in prostate cancer. And they were relatively well balanced in terms of clinical stage, the use of rectal spacer, hypofractionation, etc. And again, across several factors, there's no difference in the quality of life in the bowel, urinary incontinence, sexual function, medically speaking, biochemical recurrence, and clinical free recurrence, and all of those were equivalent. Progression-free survival is similar, and whether we or not we use the rectal spacer showed no difference when we use proton versus photons. So the updated analysis published in 24 about the proton and photon for prostate cancer, this observational study, there were no statistically significant differences. Mind you, we're still not talking about randomized, well-controlled trial. The big argument about whether or not treating with proton reduces the incidence of secondary cancer, and this is very important, especially when we're treating young patients with radiotherapy, and there is no evaluation, there is no solid data about this. The pediatric proton and photon therapy group, they trying to gather data from across the world to decide and to outline whether or not the use of proton reduces the incidence of secondary malignancy. There are a whole slew of phase 3 trials of proton versus photon in head and neck, in lung, in prostate, esophagus, CNS, obviously. So the data that we have so far is mostly phase 2 single institution trials, and now it's coming on board several phase 3 trials addressing these issues, and the data is awaited. What's against proton, the criticism against proton? It's a greater sensitivity of this particle to dose distribution and inter and intrafraction variation of anatomy. We have to be extremely precise, otherwise we may miss the tumor, and then the whole treatment will fail. We are having maturing treatment planning and treatment delivery technology. As I mentioned before, there was some incidence of radiation-induced cancer.
That was my reminder, but
I'm sorry. Okay. There is a lack of strong phase 3 trials of clinical superiority. It's a complex planning. My colleagues will be more in place to decide and to talk about this. It takes, they say, up to 3 weeks or more to create a perfect plan for the proton before initiating treatment, which may induce delays in the treatment. The big argument, it's increased cost. It's 3 or 4 times the cost of a photon treatment in terms of apparatus and in terms of treatment. And it's not readily available. The radiobiological concerns, we talk about the RBA at the end of the particle trial. It varies with the beam angles. There is a technical difficulty across mobile or in homogeneous tissues, which are being addressed, and we are in the learning curve. The cellular damage may be heterogeneous across a proton beam profile. So one option is what the Canadian did, is instead of investing heavily into proton facilities, where they have a waiting period to get onto radiation treatment, is they are bridging the proton gap. Whereas there's a consultation with the US centers, they send the data of the patient, and they compare the photon treatment plan to the proton treatment plan. And if there is a big advantage, the Canadian healthcare system will cover the proton treatment. If there is no big advantage clinically and in terms of planning, then the treatment is not covered. Thank you very much. And
Doctor, maybe we'll invite the next speaker, Dr. Saif.
So again, Dr. Saif will be back. He is a well-trained proton therapy specialist, and I guess he will be convincing us about using proton in 5 minutes.
In 5 minutes? Okay. Can I go next? It's not, or should I just say next? Or maybe they're
Can you
uploading
put the slides on?
Yeah. So I guess the first comment I have to say is that the scope of the talk is a bit too wide.
Do we have the slides ready for Dr. Saif? Dr. Ibrahim? Just a second. All right.
Sure. So the scope of the talk is really quite wide. It's a very huge topic to talk about common cancers, right? And so I can talk about 45 minutes for each site in terms of the data. So I really have to squish this down to maybe a different kind of objective for my talk, is really just to gain more sympathizers for proton therapy, and really why talk about it in the first place and why be interested in proton therapy in the first place. There's a wide adoption of proton therapy worldwide. The 10 top cancer centers in the world, 7 of them have proton therapy already available, and the other 3 are having plans. The increase in uptake of proton therapy since 2013 because of the introduction of single-room protons and also retrofitted linear accelerator proton solutions. I won't talk much about the advantages, but basically the advantages opens 2 windows of opportunities for radiation therapy. The first is reducing the integral dose, which we are talking about. We're trying to focus more on our studies. All of phase 3 studies look at mainly toxicity. We don't know. We know already that efficacy won't be as much of a difference because of the RBE similarity. However, the integral dose is something where we're trying to take advantage of, right? And we can see down here the difference between so this is a photon minus proton plan. So all of that is excess radiation. All of that is radiation you do not need. There is no benefit to that radiation whatsoever. So there's only downside to that area. The other thing is that it helps widen the therapeutic index. These S-curves, the tumor control probability curves, the more wide these curves are, the more opportunity there is to dose escalate. And so those are the 2 main opportunities for proton therapy. We already talked about some of the disadvantages. And I'll talk about them quickly. So the high cost, limited randomized trials, the technology, yes, there's a lot of issues with technology in terms of, or difficulties, let's call, with planning in radiotherapy. But we've come a very long way, and that's one important thing to know about protons, is that over the last 2 decades, it is significantly improved in technology. While in VMAT, we can say that in photon therapy land, there hasn't been much improvement in technology over the last 10 to 15 years. We've pretty much been stuck there. However, with protons, there's been a huge change over the last few years, and there's even more change coming. And some of these changes are actually turning some of these negative effects into positive effects. So for example, the end range effect, which is that unknown region beyond the Bragg peak, there is now what we call LET optimization for the proton plans, that we can actually use that region for our benefit. And I'll talk about that a bit quickly. We don't really need a lot of these older machines where they require these milling. The size of the protons and the cost for the land, the cost for the equipment, the personnel, the operational cost has significantly reduced in size, talking about a 70 to 90% reduction. Some things, here's what I'm going to spend maybe most of my time, and then I'll go quickly over some of the data. But basically, some things is that we need to understand, are we really against proton therapy for the right or the wrong reasons? Are we really just against it because of the cost and availability, which is something we are improving on? Or is it more related to something else? Because that integral dose that is unbeneficial for the patient, there are some other considerations and effects to it that may not necessarily be captured in randomized trials. And do we really need randomized controlled trials to improve or adapt new technology? Have we really gone through that process before? When we moved from 2D to 3D and from 3D to VMAT, did we really wait for those phase 3 randomized controlled trials, or have we really adopted the technology before those randomized trials? And why is this different in this situation? An important thing that studies will not capture, okay? And there are many studies. This is the list. I know a lot of people are screaming, we want the data. This is the list of all the ongoing phase 3 studies, which some of them have already closed, and we're waiting these results. They will help us, they'll help guide us in the future in terms of toxicity and so on. But a lot of these trials don't capture some important things. For example, in your practice as a radiation oncologist, ALARA should be your basis of how you treat patients. Meeting constraints is something that we usually do. If the larynx requires a mean dose of 40 gray, if you achieve 39 gray, you're happy, right? But many of these patients that you treat on your regular basis require re-irradiation, and that's when you're stuck, right? Because you've met you maxed the constraints of the cord in the original plan, and now in the re-irradiation plan, you're stuck in the re-irradiation because you really were not able to dive that dose down. So those are things that we don't really look into. Another important thing that relevant to some of the other specialties, so like the medical oncologists and the surgeons, they like the concept of proton therapy. Why? Well, the surgeons, they like it because all that integral dose leads to moderate levels of fibrosis in the planes, the surgical planes, and the vessels. So the surgeons will tell you that we always have a hard time resecting tumors after radiotherapy. And for the medical oncologists, they're very hyped about this, the concept of lymphopenia, right? This integral dose can lead to lymphopenia in the circulating cells. It doesn't lead to any reduced in immunity in patients, but it has been shown to cause reduction in lymph, especially protracted fractionated treatments. So these patients, for example, here, I want to show you just a quick technology update. This image up here is a proto-arc, okay? So it's using proton in the sense, the same way you use VMAT. So instead of using 2 or 3 beams, you actually use an arc of protons. And this was just recently shown in the last 2 years that this actually reduces the integral dose. You think that spreading that low dose of the proton would increase the integral dose, but actually it was shown to reduce the integral dose. And that is because that low dose spread in the protons is much, much smaller. But what do you gain as a benefit from doing that? Well, you gain 2 things. The first thing is that you improve your conformality even further with proton therapy. And the second is you can actually do something very unique. I've never seen this before. It's called the hot donut plan. I have an image. I couldn't really put it on the presentation, but if you ask me, I'll show you the hot donut plan. So basically, it's a ring of high-dose radiation, 0 dose in the middle, and 0 dose in the outside, which would be a great technology, for example, for prostate. Right? If you use this technology, which is proto-arc, especially with LET optimization, you can actually reduce the dose in the middle to 0, which is amazing for prostate because the urethra is there. So you kind of combine the both benefits of SBRT, which is the non-invasive component, and then also the HDR brachytherapy, where you can actually escalate the dose and then reduce the dose to the urethra. So the Astro updated their model in 2023. And we have actually gone through the practice ourselves in Saudi Arabia. We've updated our practice guidelines from 2018. This was a SARO initiative. And we basically divided all the evidence in terms of quality, and then we had an expert panel to revise the quality of the evidence and then give a recommendation level. So this is already approved for publication, so I'm giving you like a sneak peek. This is going to be published within the next few weeks. So these are recommendation level A, so what we think is the evidence was strongly convincing. And I'll talk only about the head and neck because that we have a phase 1 study. You don't need to have level 1 evidence. So for example, in the pediatric group, many of the studies that have already been published is convincing enough to use protons in the pediatric group. You don't need a level 1 evidence for that. Or, better to say that radiation oncologists won't wait for that data to use proton therapy. So these are the sites mostly. So as those studies come out, these recommendations will be refined, right? So we have moderately convincing, in which case breast, for example, with specific conditions. I'll talk about that quickly. These are partially convincing, so we still have a lot of way to go in terms of these sites. And these are the non-convincing. And I put actually the prostate there because that's what the panel reached to in terms of prostate. Prostate is still not out of the picture. There's still a lot of studies that are ongoing. And the technology used in that proton study is not the most advanced proton technology. So it's something you need to understand about these trials is that the technology of proton continues to evolve while we do these trials, whereas the VMAT plans and the photon plans remain relatively stable, right? And the other thing is that there's a learning curve with protons. Actually, anyone here can learn how to do protons. You just need 3 to 6 months of experience learning a few tricks and tips, and you can start using protons right away. But there is a learning curve, even among specialists, because as the technology evolves, you need to learn how to use that technology effectively. So just very quickly, so oropharyngeal cancer, this was one of the first phase 3 non-inferiority randomized trials, which showed that there was reduced toxicity with protons compared to photons, especially in the requirement for gastrostomy tube dependence. So that was significantly reduced with proton therapy. There was no difference in survival or in disease-free survival, although there was a trend.
Dr. Saif?
This is the last 2 slides, yes. So for breast, we gave recommendation B. So these are specific breast conditions, not every breast. Most breasts are not good candidates for protons. What we're talking about patients who have bilateral breast cancer requiring nodal irradiation, comprehensive, sometimes including the IMC as well, or some patients who have unfavorable anatomy. And we do have phase 2 study on this. And you can see in this phase 2 study, the mean heart dose in this proton, bilateral regional irradiation protons was 0.5. Okay, the range was 0.1 to 1.7. So how can you achieve that with photons, with bilateral? You'll know that's extremely challenging, extremely difficult. In terms of secondary cancer, we have a very good study, which I would like to spend more time on, but the basic underlying note here is that proton therapy reduced the risk of secondary cancer across the board. Okay, there was no difference between 3D and IMRT. But when you compared 3D and IMRT to protons, like the forest plot down here, it was heavily in favor of proton therapy, okay? So I'll just end my talk by saying that we should really be a proponent of proton therapy. For us in radiation oncology, technology is what we use to propagate the field forward. You can see in medical oncology field, they have a lot of these new drugs. I get a spasm every time I hear the word keynote because there's so many of them. But for us, what do we have, right? If we don't push the technology forward, we really don't have any other new tools to use. And I think that this potentially flash radiotherapy, which I'm also very fan of, but it has a long way to go, is something that I think we should all be a proponent of and hope that it actually works out. It will be better for all of us if we do have these new tools available. Okay, thank you.
Thank you very much. In the interest of time, we'll probably take in questions over tea and then maybe have the poll in now, because the next moderators have a Herculean task of finishing the session in the next 15 minutes, because we have the opening ceremony at 12. So we can have the poll on. Poll. And then any maybe.
Thank you, Dr. Saif, for the overview. Like regarding the modality of proton, we know that the steep of fall down of the beam is desirable most of the time. But what regarding the near miss? Like, is there any reported data about the missing in the target due to the Bragg peak steep off dose, and how you overcome this?
Yes, thank you. So there are technical ways to avoid these near misses. So you do what we call multiple planning. So you do MFO, and then in the MFO, so multi-field optimization, and then you look for robustness as well. So you do. So the software is optimized in a way where it generates 30, 40 plans in all potential scenarios of movement of the tumor, and then looks at the entire DVH. So if I show you DVH of a robustness plan, you'll see that it gives you all the possibilities. And so we look at, the way you look at a DVH in protons is different than in photons. You have to look at the robustness. So that robustness helps you overcome that concern.
There's no reported any data regarding miss in the target?
Not that I'm aware of, no. So in the past, it used to take 3 weeks, that is true. But now I think it's with the newer softwares, the newer advancements, it's coming closer to 1 week.
There's one more question at the back.
Until Mike reached there, integral dose, low dose with secondary cancer. Now we believe it's not the low dose that associated with secondary cancer. What do you think about?
So both intermediate and low dose is less important. So whether it's from the intermediate dose or from the high dose will not change, right? The high dose is the high dose.
Thanks for the speaker for for outlining all the benefits for the protons and these things. So my question actually is just to hear your opinion about the carbon ion therapy. So we are hearing right now that carbon ion have like better Bragg peak and higher LET. So what do you think about the clinical outcomes with carbon ion? Just wanted to hear your opinion about that.
Yeah, so carbon ions is what we consider a high LET particle, and so it's very different than photons. Protons is the most similar to photon therapy, and so that's why talking about carbon ions or any other like pions or neutrons is very different talk. It has more of an RBE advantage, but because they're larger particles, it's very challenging to use them in certain ways. The technology is a bit behind in terms of proton therapy, so the conformality and the effectiveness of the robustness and so on is a little bit more challenging. And you cannot use it in all the scenarios that you can use protons. For example, carbon ions, it's very challenging to use it in the adjuvant setting, in many scenarios as well, where you would potentially use photons because it's not really good for microscopic disease. Because of the high LET, you'll end up causing a lot of damage to normal tissue. Am I going over time?
Thank you so much. Probably you have to conclude this session and move on with the second one. Thank you so much for the speakers.
So we're moving to the last session before the opening ceremony because medical oncologists, as usual and as expected, are running late. So we are good on time. So I'd like to introduce the moderator who will be introducing our next speakers. He does not need any introduction. My dear friend, colleague, Dr. Majid Al-Ghamidi. He's a radiation oncologist practicing in Saudi, and he's also practicing with us in Abu Dhabi. He's the chairman of the Saudi Association of Radiation Oncology, very prominent radiation oncologist in the region. Along with him is our also very dear friend and colleague, Dr. Mariana Aslani. She's a consultant radiation oncologist practicing in Mediclinic in Dubai, and she's an expert when it comes to really difficult cases. I reach out to her as well for her opinion a lot. So without, I'll leave you guys to lead the last session in techniques before we go to the opening ceremony. Thank you.
Thank you very much, Dr. Ibrahim. So we'll move on to the next session, which is about the MRI-guided radiotherapy. If we have a poll, go ahead and put it. So the first speaker, it gives me a great pleasure to introduce Dr. Bokyoung Kim. She's a consultant radiation oncologist and the chair of Oncology Center at Sheikh Khalifa Specialty Hospital in Ras Al Khaimah. She has special interest in breast cancer, lung cancer, GU and GI cancers, as well as lymphoma and sarcoma, head and neck cancers. She has 25 years experience in treating these sites. She received her medical degree from Seoul National University, and she worked there for some time before joining the UAE for the chair of the radiation oncology. So Dr. Kim.
Good morning, ladies and gentlemen. My name is Bo-Kyung Kim. It's a great honor for me to participate in the historical first UAE GCC radiation oncology meeting today for the discussion of MR-guided radiation therapy. There is no conflict of interest. Sheikh Khalifa Specialty Hospital is located in Northern Emirates, and it was it was opened in 2014, focused on 3 centers of excellence, including oncology, cardiovascular, and neuroscience. It has been operated by Seoul National University Hospital, South Korea, since its opening. We have 2 linear accelerators, one Bursa HD signature. It is with the ultrasound, cone beam CT, and surface guidance. And the other one is View-Ray MRI-DN. It has the 6 MB and RINAC with continuous MRI guided real-time tracking. It is the first MR LINAC outside of the US and a second in the world. Oh, sorry. We started our first MR-guided radiation therapy service in 2018. And now the machine is inactive. We are waiting the upgrade of machine in next year. To improve the therapeutic ratio of radiation therapy, the concept of precision radiation therapy has been used as a part of the precision medicine. Various imaging guidance reduce the set of errors, but central challenges are the precision radiation therapies, intrafractional variability of the target, and interfractional variability of the target and OAR relate to the response in human physiology. To overcome such challenges, MR LINAC was developed in 2012. At first time, cobalt teletherapy machine was introduced, and then in 2017, MR LINAC was clinically used, and then now 3 MR LINACs are commercially available. All MRI machines providing the continuous MR images, real-time tracking, and on-table adaptive radiation therapy. MR LINACs can be used not only for the treatment delivery, and it can also be used for the MR simulator. It showed better soft tissue delineations without extra radiation exposure, even with some kind of the extra images. And MR LINACs is providing some image-guided radiation therapy with better soft tissue delineation without extra radiation exposure. And it also can be used for the real-time tracking for the new moving target. With that one, we can using some adaptive radiation therapy, and recently MR LINAC widened its scope to the biology-guided radiation therapy. Malignant brain tumor has high recurrence rate, and even the recent development of the conventional radiation therapy machines. But MR LINACs can be used for the functional biology adaptive treatment as a kind of the biology guidance radiation therapy. This may be a unique approach that helps to overcome the therapeutic resistance by some cellularity, vascularization, and hypoxia using diffusion weighting imaging, perfusion weighting imaging, and coupled MRI sequence. It helps to deliver the differential radiation dose to the target based on the functional biologic images, and such approach may improve the treatment outcomes. It is an example of the SBRT for liver cancers. MRI-guided radiation therapy shows superior imaging of soft tissue with the clear visualization of the tumor and normal tissues, and no need for visual and real-time imaging is possible. And also, functional images are increasingly available, with such kind of advantage making the increased uptake MR-Linac systems. MR-guided radiation therapy improved the treatment process with the better therapy guidance, treatment verification, and delivery control. With that such kind of accurate delivery, we can reducing radiation therapy fractions, and we also can doing some dose escalation with more confidence. It may be translated improved tumor control and decreasing normal tissue toxicity. I also showed the similar studies about that one. Prostate cancer is one of the highlighted cancer for the MR-guided radiation therapy. For the Miracle trial, it showed that the benefit of MR-guided radiation therapy. It showed the better acute toxicity profiles for the GU and GI toxicities for the physician-reported and patient-reported one. At the meta-analysis, it also showed the similar outcomes. The MR-guided stereotactic radiation therapy showed the better toxicity profiles for the GU and GI. And about the GU toxicity, SBRT method and prescription dose is the important factor.
Sorry, I apologize for this, but we have the opening ceremony, so if you can conclude in 1 minute, please, then we'll move to the next one.
If so, I will just move that one. Okay. 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 The high price is one of the biggest hurdles for the MR-Linacs, but when we compare the cost, we are commonly compare the MR-Linac with the conventional Linac. But I think that we can change some our thought, because proton therapy and MR-guided radiation therapy is one of the important tools for the precision medicine. About the precision by the MR-Linac of the real-time imaging and adaptive treatment cannot be compensated by the proton therapy. So I think that MR-Linac have many kind of the limitation with the high cost and long treatment time, and some limitation of the delivery and contraindication of the MRI. But MR-Linac has the advantage for the patient care, fidelity of the target, precise adaptive delivery, and possibility of the biology guidance radiation therapy, and also increasing necessity for the special cases, including SBRT and REALT, and difficulty cases for the conventional radiation therapy. It is our cases because we can use to treat the patient with multiple brain mets, with whole brain radiation therapy, with hippocampal sparing together. And this case is that recurrent hemangioendothelioma, taking the R1 resection, the patient can be treated safely with the visual guidance. Both patient is having the 6 and 8 years disease local recurrence-free without any complication. And this case is also the left adrenal mets. It is located very closely to the heart. Those patient is safely being treated with the FSR SBRT. So I think that is the importance of the MR guidance radiation therapy. Thank you.
So much. Thank you. She is a great colleague from Sheikh Shahboud Medical City, fellow of Royal College of Physicians and Radiologists. She's going to argue against routine implementation of the MR-guided radiotherapy. Thank you.
Thank you, Dr. Aslani. I've been given the uphill task of convincing everyone that a new technology is to be considered optional in this day and age. And I've been given about 7 minutes to do that in, so I'll try my best. Okay. So I'm going to be arguing on the basis of cost. Of course, we have to address that. Clinical evidence, technology-related issues, and the existence of effective alternatives at the moment. So the cost. I mean, we have to cross this barrier. It is expensive technology, and I'm sure Dr. Kim said that you have to compare it with protons. But is MR-guided LINAC therapy actually equatable to protons? We'll have a look at that in a moment. So the setup costs and the operational costs all add up quite quickly. One of the issues with MRI-guided LINAC therapy is the need for very highly experienced personnel, and a lot of them being present throughout the decision-making process for each session of delivery of treatment. And that's not something that a lot of radiotherapy centers can afford. So, putting it in perspective, for setting up an MRI LINAC unit with a single machine, you can set up a small radiotherapy department with a selection of machines of your choice and technology of your choice, and maybe even have some spare cash at the end. We'll go into the operational side of it as well. Longer treatment time, on-table time. Now, this is the biggest factor. Average treatment times of about 50 minutes. The range says 20 to 120 minutes. 20, I think, is a bit of an overestimate or an underestimate. But you can see that the adaptive workflows are very, very labor-intensive and time-consuming. And that's multifactorial, inherent to the technology itself, but also because of the complex workflow. I'm sure the MRI LINAC that's commercially available, they are looking at ways to address this, and most recently, they have introduced something called parallel workflows. But despite that, I don't need to convince you that this is a very, very labor-intensive workflow when the patient is lying on the table. So this then comes to the point that it seriously limits the throughput of the patients that can go through the machine in a working day. Why is this important? Of course, we all have to be conscious about what technology reaches how many patients. Incidence of cancer is rising, need for radiotherapy is rising, and at the moment, there is an estimated 15,000 LINACs worldwide and 85 MRI LINACs. Fast forward to 20 years down the line, the estimate is twice that number. Now, is a machine with a throughput of about 8 to 9 patients per working day going to be able to meet that demand? That's definitely not considered possible. However, are we discounting good technology with this argument? Because we know that it does offer superior soft tissue contrast, it does offer adaptive treatment planning, it does offer real-time imaging and gating, margin reduction, and perhaps even reduced toxicities. But before we delve into this a little bit more, I have to point out the data. There's a lot, and I do take on board the previous argument that we always don't need phase 3 data, but just look at this. All of this is retrospective cohort studies, maybe small volumes of patients having gone through phase 2 studies, and there is one randomized phase 3 trial till date. So the data is maturing, it is being gathered. At the moment, investigational is how I would say. Let's look at each of these points. Superior soft tissue contrast, I can't argue against that. No one can argue against that. However, does that relate to improved outcomes? There is no data yet to say that having a better view of the soft tissue actually translates into a long-term therapeutic benefit for the patient. Adaptive treatment planning, definitely a plus point of an MRI LINAC, but the definite negative of that is the long workflow. We can all imagine the task it is to have a patient lying absolutely still in a fairly claustrophobic environment for about 1.5 to 2 hours where we're meticulously planning. And at the same time, increased treatment times are known to increase intrafraction movement as well. So are we trying to address one thing and actually inadvertently causing another problem at the same time? That's what the thought process there. We do have alternatives for adaptive radiotherapy. We have CBCT-guided adaptive radiotherapy, much shorter workflows, and comparative outcomes from all the phase 2 and the retrospective data that's available. Okay, what about real-time imaging and gating for intrafraction movement? Again, another plus. How does it improve outcomes? Just bear in mind, real-time tracking is not the same as real-time adaptation or dose trailing. Dose trailing as a technology is not yet available for use. It's still in the concept process. So we can look and see that the tumor is moving, but in some sites, you can't do anything about it, such as the pelvis. Where you can do something about it is in areas that are affected by respiratory movements, such as the lung and the upper abdomen, and you can use gating with the MRI LINAC, I give it that. But then, as radiation oncologists, we're already dealing with respiratory motion, and we're managing it with multiple different techniques. Breath hold, it can show fairly good reproducibility in a compliant patient, I give it that. 4D guided planning with the ITV concept, VR gating, 4D CBCT is another concept, and historically fiducials and tracking. So the next 2 points are sort of interrelated: margin reduction and reduced toxicities. There is a lot of retrospective. You cut that short even more. Okay, margin reduction, there is good data showing that you can reduce the margin, and it can show that it's reducing toxicities, but has that really translated into beneficial outcomes for the patient? Because what is lacking is the long-term toxicity data and the data of long-term outcomes. That is important. The technology itself is not without its flaws. It's a single energy. Some machines have field size restrictions, 22 centimeters in the craniocaudal directions, MLCs only moving in one direction, no collimator rotation, small bore size, 60 to 70 centimeters, limited couch movement in only one direction, can't deliver electrons, can't deliver arc therapy, can't deliver non-coplanar beams. Are we compromising on a lot for some advantages? Well, let's give it a thought. And then there are some inherent unknowns about the technology itself. Magnetic field effects, we're still learning about it. The technology is still being adapted to deal with it. And therefore, the data and the practice itself is evolving along with the technology. Wider penumbra is a well-documented phenomenon. So we're trying to reduce the margins, but we're giving a bigger penumbra. That's the final one.
Thank you.
So the patient-related factors are also not inconsequential. Claustrophobia, 10 to 15% patients needing sedation just to have the procedure, times that by 30 for a long course of treatment. That's not very appealing. MR incompatibility, long treatment times. So I think I can safely say that because of its high cost, limited accessibility, technology-related limitations, limited clinical evidence, at this point, I would argue you can call it optional. And I will leave you with that slide.
We can take one question. Okay.
It is not a question. Thank you for your nice the lecture. I would like to explain something because I skipped many slides, so I do not explain about the point that argues by your side. Recently, we're having 3 systems, and the newly developed system having some kind of different structure of the MR, so they can providing some kind of the more wide big bore and more wide shift of the machines. And as the doctors, I also agree about that there is no need to all the facility need the MR guidance radiation therapy. But as the one who using that one, I strongly believe it might be widen radiation therapy, the scope, especially for more difficult cases. And also we are facing much more difficult cases these days with the retreatment and also more complicated cases with the combined systemic therapy. So for those cases, I think it is really needed, the machines.
Thank you very much, Dr. Kim. Thank you very much, the faculty, and it was very interesting. Now I think we have to go to the opening ceremony in the main hall. We're already 1 minute late.
We'll be back after lunch for the second session.
Sure. So what time is it to be back? So 2 p.m., we're starting 2 p.m. After lunch here, again, the radiation oncology track. Thank you very much.
Thank you.
Okay, Assalamu alaikum, good afternoon. While people are coming from lunch, I guess we can get started. So this first afternoon session is going to be about IDH mutant gliomas. We had a flavor already from our visiting professor, Tim. So more of the same probably, but this is a debate kind of a section which is more interesting to see the ups and downs or the pros and cons. I must say in the field of gliomas, we haven't seen anything really in over 20 years, as we heard. And really to be in a plenary session at ASCO was a big deal. Where, of course, all oncologists are watching, not just neuro-oncologists. So most doctors are interested in breast cancer, lung cancer, etc. But to put it on a plenary session, that's how important this discovery, certainly the Indigo trial that we heard about. So anyway, we are going to hear debates this afternoon for chemoradiation versus the anti-IDH, the ups and downs, like I said, and plus and minus. So I think we're going to start with Dr. Majid first. Yes, so Dr. Majid Al-Ghamdi, he's visiting he's actually from UAE, as we can see, radiation oncologist, and he will be arguing on the side of chemoradiation, right, which is a hard task to stay up to with the first, with the data on the anti-IDH and the presence of our professor. Okay, so Dr. Ghamdi.
Thank you very much, Dr. Hassan. Very happy always to conduct this kind of discussions because we always have these questions in the tumor board and there's no single answer. And I think we have the pleasure of having Dr. Closey, who's one of the co-authors on this trial. So we'll see what we can do with debating him on this topic. So how can I move the slides? Dr. Hassan, do you have any idea? Yeah. Somebody in favor of anti-IDH. Hiding this. Yeah, it's going to be that. So nothing to disclose that's relevant. So next slide. Next slide. Thank you. So see if, okay. So this slide is actually showing the timeline, the important milestones that are relevant to the radiation oncology community in terms of treating low-grade glioma. So I think one of the first or early clinical trials where it was conducted or was published in 1996, which was the EORTC 22844, and this was called initially the Believers study, which actually randomized the patient into low dose versus high dose. Both had the same outcomes. So the conclusion was dose escalation has nothing to add in these patients. So the next study was actually the non-believers study. So it's EORTC 22845 was published in 2002. And basically, do you have a pointer? And basically what it showed is was actually that it randomized patient to early versus late radiation treatment. So observation versus upfront radiation treatment. And it showed that radiation showed significant benefit in progression-free survival, but not in overall survival. And this trial also showed very good seizure control with radiation treatment. And then Pignatti and the group, out of the EORTC trials, they came up with their prognostic score that was used for so long, the Pignatti score, which was used to categorize patients into low risk and high risk. And the high risk was offered the treatment. So the treatment was offered up until 2005, or after 2005, we were categorizing the patients into low and high risk, and then we offer the high risk radiation treatment. The RTOG trial 9802 was published in 2016. So this is the most probably important trial before the Indigo, and it actually showed that chemoradiation, randomized patients to radiation versus chemoradiation, and it showed overall survival benefit with chemoradiation, and that was the standard of care up until now. And then the Indigo trial came along. It was published in 2023, which showed the vorasidenib was superior in terms of progression-free survival and time to next intervention compared to observation in high-risk patient as per the R2G. And then this led to the FDA approval of Indigo in 2024, and the approval was actually extended to patients with gross total resection, as opposed to only subtotal resection that was allowed in the trial. So what we know so far, based on randomized evidence for low-grade glioma, observation versus RT. RT is better for progression-free survival, but not for overall survival. And this is only applicable to high risk. The observation versus vorasidenib, this is Indigo trial, it showed a progression-free survival benefit, again, in those with residual disease, so high risk, by the RTOG definition. It didn't show, or overall survival was not one of the early endpoints, and there's no data on this so far. The next trial was the RTOG, so radiation versus chemo-RT. We know that chemo-RT is superior in terms of overall survival and progression-free survival, and again for high risk. The one that we are lacking is the direct comparison between chemoradiation versus IDH inhibitor for high risk, and that's why we have this discussion today. So again, the treatment prior to IDH inhibitor was based on the RTOG trial, at least since the 2016, the time of publication of this trial. Some people, they were using also EORTC high-risk criteria, which is shown here. The RTOG basically criteria was much more simple, which was based on the age more than 40 or subtotal resection. So whether you use EORTC criteria or RTOG criteria, the high-risk patient would have treatment with chemoradiation, and those low-risk, they would be candidate for observation. So observation, low-risk, treat high-risk with chemoradiation. So what we also know that adjuvant RT improves progression-free survival, but not overall survival. And we know that adjuvant radiation, it improves seizure very effectively. And we discussed that. And then the premise of the ID inhibitors was that we know that there's some late toxicity from radiation. And I think the disagreement is how significant are these cognitive late CNS toxicities from radiation in adult patients, because we know in pediatrics, of course, there's severe cognition impact of radiation, but in adults, how important is this thing, right? So we'll need to talk about that, because the whole premise of introducing the IDH inhibitors was to actually delay radiation, and we'll hear more about this from Dr. Closey, to delay radiation to prevent cognition negative outcomes. So again, the RTOG, they included grade 2 patients, 250 radiation versus chemoradiation. And this is again very relevant today as a trial, because it is still cited as the basis of the today's standard of care. So it was published in 2016, and on all kind of subgroup analysis, there was significant improvement in overall survival and progression-free survival, chemoradiation versus radiation alone, and chemo was PCV. And most now would probably use temozolomide as well. So when you look at histology, when you look at IDH inhibitor, IDH mutation, they all benefited from the chemo, adding chemo to radiation. But of course, did not answer whether observation versus radiation is adding any benefit. So probably this is the only, as far as I know, randomized trial that looked and extensively analyzed the toxicity from radiation. And this is important for today's debate about whether you use IDH inhibitor or radiation treatment. So what it showed in terms of toxicity, grade 1, grade 2, we see this all the time. And then grade 3, grade 4, less than 1%. So this is from the RTOG 9802. We'll come back to the CNS toxicity from that trial. And now we, just one slide about this trial, the Indigo trial, which actually was the basis of using vorasidenib, a very promising anti-IDH inhibitor that is being introduced into the landscape of the low-grade glioma treatment. So this trial, again, I'll leave the details for Dr. Closey, but the thing is they included 300 patient grade 2 residual or recurrent. And then the thing that maybe we can have more clarification on this from Dr. Closey is that all the patients in this trial, they were labeled as not in need for immediate radiation or chemoradiation, and that is a very subjective kind of criteria, right? So, and then they were randomized to vorasidenib versus observation, and the follow-up was 14 months. Median progression survival was much better with vorasidenib compared to observation. Time to next intervention as well, but there's no data on the survival yet. Toxicity was very, very mild with this medication. So here's the one slide on the caveats of this trial versus or the use of vorasidenib. So again, the included patient, they would qualify for high risk as per the RTOG. So they are, in many centers, they would not been offered the observation the first hand. Because those included patients in the Indigo trial, they were candidate for observation. So, but here, all of them, they meet the criteria of high risk. So many of the oncologists or radiation oncologists, they would not offer those patients observation because they are high risk as per RTOG trial. So this is one thing. And then again, the thing that definition of not in immediate need for radiation or chemoradiation, whether that is based on symptoms or left to the discretion of the oncologist and the team. There's no data on overall survival. What we have is actually progression-free survival. And of course, it was not compared directly to the chemoradiation, which is in many guidelines considered still the standard of care. And the short follow-up, only 14 months follow-up versus 12 years in the RTOG 9802. The long-term toxicity, because of the short follow-up, is still largely unknown. The early results are very promising, but it's still shorter than the RTOG trial. And then many of those patients are young patients, and many of them are female. So do you want to put the female on IDH inhibitor? She want to build a family and get pregnant. So I think it may be not appropriate for this patient group. And then the last thing is cost effectiveness of IDH inhibitor. So is that cost effective on the level of the healthcare system or not? So that's a big question that we want to, and of course the financial toxicity. There's a lot of talk about the financial toxicity in oncology medications and oncology patients. So that's a very important, I think, factor to consider. Now let's go back to because again, the premise of the introducing the IDH inhibitor was the negative cognition impact of radiation on those patients. So what data we have to prove this? So a couple of selected trial papers, and a couple of them were cited in the Indigo trial manuscript. So some, and all of them are retrospective data, and we'll come to the RTOG. Many of these papers, they talk about the tumor itself has the most toxic effect on the cognition. as opposed to radiation. And then they talked also in some of those papers that only high-dose radiation, but not low-dose, that actually have impact on the cognition. And then and many of those studies, especially the EORTC studies, in the old days, they were treated with whole brain, and it's not standard of care. And they were treated with all techniques, not VMAT, not IMRT, like 3D, and some of them just two parallel fields. So all of this, of course, it will cause cognition, but is it applicable to today's practice, where we have very conformal, very precise radiation delivery? And then also the cognition was measured using old scales. It's not measured with sensitive scales, and maybe we'll hear more about this from Dr. Closey, but and then of course retrospective data. And then in one study that was actually fairly recent, in the Neuro-Oncology, was published in the Neuro-Oncology, Dr. Flynn, they looked at the patient, it's retrospective, they looked at the patient who had, they pulled the data of those patients who received monotherapy with temozolomide versus radiation treatment, and there was no difference between the cognition outcomes, whether you give radiation or temozolomide, and this was using the Hopkins Verbal Learning Test, which is the most sensitive cognition measurement that we know. So back to the R2G 9802, because this is the randomized data, the most recent randomized data before the Indigo trial. So they looked at the cognition, and they had separate publication on the cognition from 2014. Unfortunately, in this trial, the cognition measurement was done used the mini-mental state examination, which is, we know, is not very sensitive. But with that measurement, there was no difference between those who had radiation and those who had chemoradiation. The caveat of this study was that the data was limited on the first 5 years, and we know that the cognition, it's actually very kind of late toxicity if it happens after radiation. So the data was limited to 5 years, and also the mini-mental state examination is probably not the best cognition measurement that we have. So these are the two caveats of this publication out of the 9802. And then the next question is, okay, so if we agree that there is some negative impact on cognition caused by radiation, then can we do something about it other than the techniques? And the answer is yes. And there's no randomized data on this, but I think it's coming. The proton therapy is one of the tools that can prevent or mitigate the cognition toxicity from radiation. And there is ongoing, indeed, trial that is using proton for low-grade glioma. The other technique is hippocampal avoidance. We have seen from the brain metastasis significant improvement in the patient progression when you actually use hippocampal avoidance in those patients. And the last thing, and the memantine as well. So we started using this in brain metastasis, and it has shown in phase 2 randomized trial positive impact in preventing or mitigating the cognition in brain metastasis patients. And the last thing that we also mentioned is IMRT VMAT. Again, most of the cognition thing that we have now in adult patient was based on the era of using radiation blindly. There's no VMAT, there's no precise technique. It was very old, including the 9802 trial. And the 9802 trial, it was started, they used 3D conformal. It was started in 1998, where there was no VMAT or IMRT. So this led to, I'm finishing now, but this, right after the approval of the vorasidenib for use in low-grade glioma, it actually, sorry, there's a screen here that I want to, okay. The ASCO, they updated their CNS 2022 original guideline on low-grade glioma, and to include actually the use of vorasidenib. So what they actually, the way they kind of rephrased their statement is that chemo-RT should be offered for high risk. And then observation, especially after gross total resection and younger age, can be considered, or in the case of concerns about toxicity. And in this patient cohort where you would consider observation, you can use vorasidenib. So that's basically the rapid response of the ASCO. Same thing we are seeing with the NCCN, where basically they included vorasidenib for the use of the low-grade glioma if chemoradiation is considered to be, or it can be deferred. And that is another big talk when you can defer chemoradiation. So I think the remaining answers is that do we need randomized clinical trial to assess chemoradiation versus IDH inhibitors? Can we do them? Do we need it? Does the progression-free survival benefit and delaying chemoradiation justify the use of IDH inhibitor compared to relatively cheaper chemoradiation? This is a big question, especially that especially that we are using IDH inhibitor because of the progression-free survival that we already achieved with radiation alone. So radiation alone is very beneficial for progression-free survival compared to observation. Same thing is the IDH. So is that enough to consider IDH? Is it cost-effective for the use for low-grade glioma in the presence of very cheap chemoradiation? And then the cognitive impact, is it bad enough? Do we have enough data to call this bad cognition outcome after the use of radiation in adult patient so that we can justify the use of the vorasidenib? And then what happens to the mitigation and prevention of the negative impact of radiation on cognition by using advanced techniques? Maybe we will be better in the future, and this will not let the chemoradiation go out of the picture for those patients. And then the other questions about recurrent tumor, higher grade, etc. So I'm not gonna, so I'll conclude here is that the IDH inhibitor represents a major advancement in the landscape of glioma treatment. We are very excited about this. However, the role of the use of the IDH inhibitors in the full scheme of the low-grade treatment should be defined clearly, and hopefully we will have more clearance as to where we fit the vorasidenib in the treatment for low-grade. And again, although we are very optimistic about the use of these medications, we should be careful in choosing between chemoradiation and IDH inhibitor as we continue to wait for more data. And the last thing is in the absence of direct comparison between vorasidenib and chemoradiation, considerations such as cost effectiveness and financial toxicity should be considered. And of course, as we do always, we individualize the treatment decisions in the multidisciplinary treatment. Thank you very much.
Thank you, Dr. Majid. I think if we can hear from Tim, I think we're a little bit short in time. I think the message is clear. So many unanswered questions, and then there is a lack of data on certain aspects. But if we can hear from Dr. Tim, and then maybe take some questions at the end.
First of all, great talk. It's really excellent. So are we doing this? Are we just moving on? Yeah. Or people just go ahead? All right. Do I have some conflicts. So the Indigo trial, just a little background on it. It enrolled really quickly. The patient population that we put on was put there so that we could measure actually the tumor that was there, that we could look at tumor growth rates coming into the study. So they had to be a year, at least a year to 5 years from initiation of being eligible for the study. They needed to have a 1 by 1 centimeter non-enhancing area. These were all patients that were in the watchful waiting setting. They had not initiated radiation and chemotherapy. It enrolled incredibly fast. These patients are actually out there. I'm not sure that the current neuro-oncologists use the high-risk, low-risk approach for IDH mutant gliomas because it was not defined with IDH mutant gliomas in mind. So that's the population that was chosen. The 1 year had to do with scarring that can occur and inability to interpret it. And PFS is a tough endpoint to try to measure what's going on with tumors. And so to have that be the cleanest possible setting, that's kind of why the population was selected the way it was selected, in hopes that we would have tumor growth rates coming in, that we would have a valuable tumor, that it would be unequivocal evaluations at best it can be with a blinded reader. And it's a double-blind trial. The first interim for efficacy, because there was an interim for futility, was negative or did not show any problems with futility. And so this happened very early. It was 14.2 months. Very short follow-up time, but a significant effect size. And as they were cleaning the data from September the 6th, they had these additional 6 months. And so the March the 7th, up to that point, was completely unblinded. And those data could be used a little bit more follow-up, up to around 20 months. Number of evaluation or number of presentations took place. But this is the trial, and you know, it's really an important point about who decides whether there isn't an immediate need of chemotherapy or radiation therapy. And yet the population existed there from the beginning. People didn't wait on these patients. They were there. This is how they were taking care of them. This is what happens in the US. This is what happens in Europe and the other countries that were involved. So the pattern of utilizing watchful waiting, I think, is more ubiquitously used and much more broadly used, and not obeying the study as it was defined. And so that population is there. And in the United States, it's there. They're just always, there's a lot of watchful waiting. And so that exists there. It's a double-blinded study, as I said, blinded review to determine progression-free survival. 73% of the patients still on study at the time of the March 7th, 44% in the placebo arm. There was no, when the updated data came, there's not a valuable time to progression, median time to progression. The vorasidenib or the placebo was still at around 11.4. Hazard ratio is still pretty good. The time, like for me, it's the top line that's most important here, the vorasidenib arm. It kind of gets at what are people doing after treatment on vorasidenib, which ones are changing over to another therapy. They did it very quickly in the placebo arm. They wanted to be on the study, so they, so this delta here, hazard ratio of 0.25, might be a little inflated because of that. We looked at a number of things, because this is really our first chance to look at this disease as an IDH mutant disease, and we looked at to see if there was any differences in PFS between any of these groups. Those who were, less than 40, those that were greater than 40. It did exist in the 1p19q. They do grow slower. Larger tumors didn't necessarily grow faster than smaller tumors, kind of interesting. And the effect size that was seen here was strong throughout. And as a matter of fact, even those who were over 40, it was a greater effect size that was seen. These are all numerical, right? Because these are not a statistical evaluation. They're numerical differences. But I'll show you some interesting data that came out of that I think maybe it gets to, and there was a recent publication about maybe we need to reassess what the risk factors are, because I think we don't really know what the risk factors are. The seizure benefit we talked about happens in both groups, happens in radiation and happens with vorasidenib, probably really associated with tumor shrinkage. That's what I've noticed in my patients who have gotten radiation, that those that have good tumor shrinkage are the ones that respond. The same thing, I think, is what we're seeing here. And that tumor shrinkage does occur with this, and it occurs over time. We have a paper that's going to be coming out in Lancet Oncology soon, which is updated data. And you could really see the extent, the breadth of patients beginning to have tumor shrinkage, and then the depth of that tumor shrinkage at 6 weeks, at 6 months, 12 months, 18 months, and 24 months for those that were followed up to that time. And it continues to get deeper and broader with that effect. So these are some of the data that I thought were helpful. This is looking at progression-free survival and binning the patient population based upon the baseline tumor size. So you can see it's broken down. The hazard ratios really stay about the same, and the progression-free survival is really about the same, and especially in the group that gets treated with vorasidenib. The group that has greater than 10 centimeters in the placebo seem to maybe progress a little early, but I don't think it's statistically different. But that's just kind of an interesting finding that tumor size may not be as important as a prognostic factor with regard to how fast the tumor is growing, the likelihood of that happening. What was really different is if the tumor was growing fast, it definitely had a shorter progression-free survival. The effect size was the same, but it was also relatively shorter in the vorasidenib arm compared to the groups that were growing slower. Makes sense, but you still had an effect size difference between the placebo, which is just saying that when you give this, you do get prolonged progression-free survival. And then the question that comes up is, what is the value of that? Which is, I think really one of the points that you were trying to make. These are the things that we understand as being prognostic. In terms of survival, the pre-postoperative volume seems to make a difference. Grade of the tumor, definitely, we see that. Growth rate, which is kind of this new thing coming out that I think is really helpful and was really one of the most striking things that were different. Enhancement, those that have enhancement versus not. Those who have gone through multiple therapies are not going to do as well in terms of their progression-free time as those that are just getting started. Copy number alterations in some of the methylation profiles. And there's this real, when we did the phase 1 study, we did not see the benefit in enhancing tumors to any great degree. It was mostly in non-enhancing tumors, and it was in those that were getting treated before any radiation or chemotherapy. That's where the largest effect that we were seeing, which is why we picked the population to go forward with. And it seemed like a population that, again, was actually being utilized. It doesn't fit the watchful waiting versus radiation population. And it's just interesting that it's not being used at all by anyone that way, the watchful waiting, at least in the United States, Canada, and in Europe. So all the questions you asked, I think, were perfect. Where should vorasidenib be used? Before or after radiation chemotherapy? What is the value of PFS in this setting? And maybe one of the other things is, where do you go wrong if you give it and then you have tumor growth and then you do radiation chemotherapy? Is there something in there that's likely to lead to a problem with resistance of radiation and chemotherapy? At least all the data are saying, no, that's not the case. With a targeted therapy, it's different if it's chemotherapy. You're creating mutations and you're creating a hypermutated phenotype where we know that creates more difficulty that doesn't appear to be the case in the preclinical data with some really interesting models out of Bill Kalin's lab, just showing that that's not likely to be the case. And so should vorasidenib be used for progressive disease post-radiation? So my bias with the totality of these data is that this patient population exists. The patients really like this. The patients need to be informed about all the pluses or minuses, just like you said, you know, I mean, they need to be educated, right? They need to be brought up to speed, and the discussion should always, it should never be automatically go to vorasidenib. It should always be a discussion. It should be a discussion in that multidisciplinary setting, but it should be a discussion with the patient. And the issues around reproduction, there are some of the same issues when chemotherapy is given, and you know, you could have kind of early ovarian failure, and whether you're collecting eggs or whether you're collecting sperm, you kind of do the same with both, and that's what we've been doing is discussing that. Some people are not interested in pursuing children, others are, and we try to make every accommodation for that. So I think there's an obvious place, you know, at least in the US, the patients play a huge role in making their own decision. And this population exists. They like the idea of this. And again, I hope that, you know, we always have them see our radiation oncologist and have the discussion. We always have them, you know, have a discussion with us as well. So they have kind of a broad evaluation, I think, of what's going on. And at least at this moment in time, at least at our institution, and of course we talk to others and how it's going in the US and in Europe, and almost all, but not all, but almost all, have gone down the path of this isn't going to interfere with anything. It will hopefully extend that progression-free time. And by extending that progression-free time, as long as we don't interfere with the ability for a known therapy to provide survival benefit, if it doesn't interfere with that, then that probably will be okay. I will say one other thing that we did, because we did detailed neurocognitive evaluation, health-related quality of life. And as these tumors got to the point where they were progressing, one question might be, are they worse off now? Have they declined in some way that would make now we're starting in a worse spot for them to be able to have this effective therapy kind of take place? And there was no change at the time of progression in neurocognitive function, health-related quality of life measures. It was very stable throughout that, which is just interesting, and it just gets also back to that. These grade 2 tumors, for the most part, high percentage of them, are slow growing, can be monitored. The changes in function are not significant, that can't be measured. And so can we do that? Can we go ahead and put this in place? The financial issues, I think, are real considerations. And, you know, it's harder for us in the US when it doesn't end up coming up. It doesn't, the burden, you know, there's a copay at $20 a month or something. You know, it's like, okay, that's tolerable. But I think those are real questions, and there are things that have to be addressed. When I also think about, you know, what other advances can take place on the radiation side, I've always been confused why 5400 is being used when 4500 seemed to be just as good. So, like, why are we doing that? Why not use less and then measure that and understand that? I like the idea of doing that. I like the idea of everything you talk about and conforming the radiation, doing everything we can, using protons, all of that. But I don't see yet how that interferes with the ability to kind of have this prolonged period of time that clearly happens with this therapy. We just got kind of like an easier one to measure. I'm going to say one other thing, and that is we did this perioperative study. And in the perioperative study, we did this to kind of look at pharmacodynamic factors and to choose vorasidenib over ivosidenib, but then we continued treating the patients after. And in the population that kind of met the vorasidenib, not having other, or the Indigo trial, not having any other therapies, any of those things, the median time to progression was 55 months, which makes me feel a little bit better. The longest patient I've had on is 8 years and going. And they're doing great. They're having, living their life and doing everything wonderfully. So I think the 20 months, we're still collecting all the data. That follow-up is hard. What is the real progression-free time? Given these prior data where we've followed the patients longer, I think it is going to be longer than that. So does it change things if it is longer or not? Is it really the same kind of discussion in the end? But that I think that kind of helps patients sometimes say, okay, I've got a median amount of potentially this much. If I've had a good resection, probably maybe a little bit better. Don't have a good resection, maybe a little bit, shorter. Is this worth it? Is it not worth it? And to date, in this multidisciplinary environment that we provide for our patients and have them see the radiation oncologists, the majority of the time they have chosen to go with vorasidenib. So I think I'll stop. I probably went too long. Well, he laid out, I thought, first of all, if we went through, you had great list there. And if we wanted to go through and kind of, pick them off one by one, we could try to do that. No, I was just saying, I don't know, we don't have to do that. I think we kind of addressed, but. Okay, I'm going to say this. When you did your talk, it was, there we go, now it's getting better. Oh, I thought it would be equal. It's a recency. Yeah, I mean this is obviously biased. So, you shouldn't ask like that.
Yes. Or whoever is speaking last, they will get the highest numbers because that's human nature.
That's just what's going to happen.
It's whatever's sticking in your brain. No, great discussions, really.
Convincing talk.
Well, he said.
Can I personally afford it with my insurance? Yes.
He mentioned the cost in the beginning. Yes, absolutely.
Yeah, the cost is, I'm sure, can be a big deal.
Just a couple comments from what you were discussing. I think the problem is we don't know if sequence matters, as you questioned the sequence, because the sequence question is critical. And I think the way you presented it, that we don't know. But don't you think when we are using usually target therapy, it's better to use it first? Because the later, right, and theoretically you'll have more potential resistance than radiation as a salvage. That's my thinking while you were discussing. The other thing, when we don't do prospective trial as you suggested, can we do something what we do with other solid tumor, matching and trying to see as close as possible to see is really going one way or another, maybe better for a matched type of patients? Has that been thought of?
I mean, I would imagine that most of the data from 9802 is a mix of CT and MRI. Whether they have all the data, because that's probably a really critical part of that, is like, who had one-by-one measurable tumor? How far out were they from their original resection? And then you would try to match it in that way. And it can be done. It's big confidence interval overlap. There's lots of problems that could come from it, but at least it would provide some information.
Granted what you mentioned about new techniques, new stuff, that maybe the cognitive side effect may not be as bad as when we were looking 10 years ago. But, I mean, again, if I'm a patient, I would be scared of this data if I have another alternative. So why not try the precision drug first and keep your RT salvage at a later time.
Yeah, I gave you some money earlier, so everything you're saying I paid you for, so thank you for that.
Thank you. I have nothing, nobody paid me. Eh?
I guess the Indigo trial. Now, the first to answer some of your questions, I guess I would have to ask Professor Flossie about are we expecting more publications out of the Indigo that will probably have longer follow-up, probably overall survival, cognition outcomes, right? Because I'm assuming you are collecting cognition as well. Cognition is there's no it's not very relevant to this trial, but to probably compare it indirectly with the other with the RTOG thing, right? Because the tumor progression can cause cognition problem, not only the thing. And also, I mean, it's important that we need to see the salvage treatment for those patients who progressed, and I assume most of those who progressed have radiation or chemoradiation.
Yes, I would think that's the case.
Maybe surgery.
Going on, yeah, and maybe surgery.
But we will have more kind of publications about the long.
I think the hard part is, you'd want to compare it also to the placebo group. And the placebo group has largely crossed over, but maybe we'd need to get the data from 9802 or maybe institutional data that could be matched that's more contemporary in some way, where patients underwent radiation and chemotherapy. But there'd have to be something to help us kind of, set a control in some way for the expected outcome of that population. Even the Catnon data are looking better than, data that existed before for grade 3 astrocytoma that's IDH mutant, even from the other studies. So yeah.
And I think you alluded to because the first time we heard about vorasidenib after the trial, we were thinking, because as radiation oncologists, we were struggling with is actually, as a CNS radiation oncologist, I worry about re-radiation much more than de novo radiation, because de novo radiation, we know, we do it every day and it's fine. The re-radiation is the real problem. Yeah. So I was hoping that we will use this drug to solve the problem of those patients, to avoid re-radiation as opposed to radiation. Yeah. And then I was told by multiple colleagues and some other high-profile people in terms of the science behind the low-grade glioma and the vorasidenib, and they told me probably it's not going to be effective.
As effective.
As effective, or what? So at least in our center, they refused to use it for recurrent tumors where I really needed to delay radiation. So.
Yeah, I think there are, so the two populations that we saw, mostly in the phase 1 study, were those that were recurrent after radiation chemotherapy that were contrast enhancing. They were rapidly growing. We didn't see much of an effect. And those that were kind of non-enhancing change. And the ones that were slow, non-enhancing change, and again, this gets into, I think, this growth rate part of it, seemed to have a tumor control for some period of time it would occur. Less so with those that were contrast enhancing. It's still interesting. I mean, when you look at the data, there's still some contrast enhancing population there that seems to be having what appears to be tumor shrinkage and some durability. It's just a minority of the patients.
Are we seeing chemoradiation versus vorasidenib soon as a clinical trial?
No, the clinical trials that are going to be ongoing are going to be radiation chemotherapy plus minus vorasidenib. Those are the big ones that are being planned. You can imagine, I mean.
Is that already ongoing?
The studies are planned and they have been approved. So I think that these are various cooperative groups that are running them.
And I think.
Some grade 2, some grade, there's a grade 4 that's being run by the company, there's a grade 3 that's being run by a cooperative group, and there's a grade 2 that's being run by. So
this trial is actually chemoradiation plus minus vorasidenib, which makes a lot of sense, which actually tells that the chemoradiation is the standard of care, and then the investigational arm is vorasidenib plus this.
So yeah, let me tell you.
And whatever we say, Dr. Hassan, he will not be convinced anyways.
No, but let me tell you the population is one grade 3, grade 4, so those not really in the right. The one that's grade 2 is the one where the magic term of patient is thought to need radiation and chemotherapy at this time before any other therapy. So what does that mean? What is that population? It's in the eye of the beholder. But nevertheless, we'll get an answer about that population.
Sounds very nice. Dr.
Do we have CCNU, by the way? We don't have CCNU here. Do you have CCNU?
We do. It's not always available.
Even when I was working, it's always...
Yeah. Most of the time we could get it, but yeah.
And maybe, are we done with? So maybe last question: did you use it for low grade? If you were to do CCRT,
yeah.
If you for whatever reason, would you give temozolomide or PCV?
Currently, I like giving PCV. I give temozolomide for astrocytomas that are grade 3. I'm sorry. I give temozolomide, for astrocytomas that are grade 3 and also grade 4. I kind of follow the Catnon for astrocytoma. For oligodendroglioma, I give PCV. For grade 2, I tend to give PCV because the data, I know, there's data. But otherwise, I mean, I'll also start a patient on PCV, and if they're having a hard time, I'll switch them over to temozolomide. I try to be practical.
Yeah, that's why I asked the question. We don't have CCNU.
Yeah, yeah.
Thank you.
Sure.
Thank you very much.
So thank you, everyone. This is a very great debate. We'll move to the next CNS session, so I hope that all the audience stay. And I know we're slightly delayed, so sorry, Dr. Thuraya and Dr. Jamali. So the next, I'd like to introduce the moderators for the next CNS session. We have Dr. Muhammad Hamadi, is he here? And we have Dr. Thorsten. Okay, so both moderators are here. Okay, great, so I'll step in. So it's really great pleasure to introduce our next two speakers, who are also experts in CNS, but we're gonna shift and we're gonna start with Dr. Ibrahim Al-Utain. Dr. Ibrahim does not need any introduction, but he will be giving us, so we're starting with Dr. Ibrahim's talk first. Yes. So Dr. Ibrahim is a chairman of Radiation Oncology, a dear friend and colleague, and he's an excellent speaker, and he'll be telling us, we're going to be debating, do we give pre-op SRS versus post-op SRS in resected brain metastasis. So with that, Dr. Ibrahim, all yours.
Thank you so much for the introduction. I need the pointers here. So I think that's not my slide, but that's okay. So we'll shift the gear here. We'll talk about more of radiation. And one of the common problem we see, brain metastasis, what to do with it. We'll be focusing on pre-op versus post-operative SRS. Try to go fast. We all know that the rule of adjuvant radiotherapy or post-op radiotherapy was established long time ago. So this is the standard of treatment since very long time ago with the Patchell trial in 1998, where it did show improvement on the brain control in comparison to surgery alone. But as you know, in the Patchell time, in 1998, the standard post-operative radiotherapy was whole brain, and since then, been a big shift from whole brain towards SRS. And we all know why, because multiple trials has showed that in comparison to SRS alone, addition of whole brain, although it does improve the brain control, the intracranial failure, but it doesn't add any benefit to the overall survival. Not only that, it's also associated with bad cognitive function. That's why the standard of care for intact brain metastasis since long time is SRS. What about in post-operative setting? in post-operative setting, we know from this very, very important trial done by the MD Anderson group, where they compared surgery alone with complete resection, observation versus SRS. So the post-op regimen that we use in that trial was SRS for the first time, and did show very good local control. We are talking about 72%. So we have level 1 evidence that we can use SRS, single fraction SRS, for post-operative. So, and again, similar to the intact brain metastasis, when this was compared, the single fraction SRS versus the whole brain didn't add anything in terms of overall survival, but it was associated with bad cognitive function. So that's why SRS is the standard of care for patients with intact brain metastasis or patients in post-operative setting. But we have one problem, which is large brain metastasis. This is, we know from the studies in the intact brain metastasis, we know that with large brain metastasis, the larger the METs, the lower the single fraction dose, and the lower the local control. So we are not doing well using single fraction SRS. And this is why fractionated radiosurgery became very popular, because using this fractionation, using the radiobiology, we could give lower dose per fraction by a higher total dose, and we are ending by having better local control with very reasonable lower radionecrosis rates. So probably fractionated is the way to go, especially for large brain metastasis. We're talking about intact brain mets. What about in post-op setting? Post-op setting, the same observation we had before, MD Anderson data, the one I showed you, the very important trial, showed that for lesions bigger than 2.5 centimeter, the local control dropped from 90%, 91%, until around 40s for lesion bigger than 2.5 centimeter. Meaning, again, bigger the size, single fraction SRS doesn't do well. And again, fractionated seems to have very, very, very good satisfying results in terms of local control with a very reasonable radionecrosis rates. And that's why this concept is being currently tested in the Alliance trial, where we are comparing a post-op setting fractionated versus single fraction SRS. Now we'll come to the main question. Should we go for pre-op or we go for the post-op? I think there are two ongoing major trials that will give us the definitive answer. The NRG BN012, where they compare pre versus post-op, both single fraction SRS, or the MD Anderson one with the same concept. We are waiting for the result. But until then, we know that our SRS, or single fraction SRS, has some limitations, especially when it comes to leptomeningeal disease. And this is something that I have to admit, that we are having this frequently in post-op setting, most likely due to iatrogenic dissemination of tumor cells in the CSF and meninges. And some studies showed that this is more common in certain histology, typically breast cancer, or certain locations posterior fossa. To address this is very important for us whenever we do post-op SRS, whether it's fractionated or single, to follow the guidelines, to keep in mind that we need a bigger CTV margins, especially if the tumor, the initial tumor, is in contact with the dura. You need to take 5 to 10 millimeter margin. Keep this in mind. Some of the recommendations, typically the Sunnybrook or University of Toronto, they even recommend having all the surgical tract inside our CTV. Can you imagine that, how big it is? But all this to control the issue of leptomeningeal. So I think radionecrosis, probably with fractionation we can get away from this. So why post-op SRS? Because the guidelines say so. The NCCN guidelines, This is what it's recommended. ASTRO guidelines, it's also the preferred option, the strongest evidence. So other reason, it's more of logic. Why do we need surgery to start with? What is the reason? We need it in most cases for large lesions causing symptoms or mass effect. So for those patients, actually you need an immediate decompression. And it's good to start with surgery, then you come after for the surgical cavity. Other practical reason, what if your surgeon left you with residual disease after pre-op? What are you gonna do? While if I go after him in post-op, I can include this in my CTV. I think I can end up here and leave the time for my colleague Majid.
Thank you, Dr. Ibrahim. This is not working. Okay. Pardon me. Yeah, you know. So thank you, Dr. Ibrahim, for this nice argument. Well, this time I'm presenting the emerging treatment. So as opposed to the first talk, which was I was advocating for the standard of care, but so we'll see what we can. How can we answer the point that Dr. Ibrahim raised in his presentation about the postoperative versus preoperative? So why preoperative SRS? So basically, some retrospective data showed better local control. Not proven yet, but there's some hint toward this side. But it's not the main reason why some people advocate for preoperative SRS. But because of the leptomeningeal disease is very important thing in the as advantage of preoperative SRS as opposed to postoperative disease. The toxicity of SRS, radiation necrosis, was shown to be less with preoperative. And logistics, we have some evidence that the preoperative is much easier for the patient for the workflow. And I think one of the points that Dr. Ibrahim mentioned was those who need surgery, they should go for surgery without delay. And there's a study that showed there's no delay. So just bring the patient in one day, CT sim, treat single fraction, send the patient to surgery. I think this is from MD Anderson. We'll see it now. And these couple points, the last couple points, are primarily they are speaking toward the local control thing, which is a better tumor delineation. So when we see the tumor better, we do the contouring better, and then you would think that the local control will be better because you treat every single bit of the tumor. And the other reason that can also improve local control with preoperative is oxygenation, because the tumor is intact and everything is, as opposed to postoperative surgical cavity where everything was devascularized. And the last thing that I was not, it is kind of indirectly incorporated here, but Dr. Ibrahim mentioned it clearly, the volume of your CTV. So it will be much better, but I mean GTV, we don't do CTV here, but it will be much smaller with the preoperative. I mean, not necessarily though, because sometimes the cavity can be much smaller compared to the preoperative tumor size. But anyways, so many of the people who are advocating for preoperative SRS, they use this kind of multi-institutional analysis. They included more than 180 patients. This is one of the early reports that is advocating clearly for preoperative SRS. So basically what they found was there's no difference in overall survival comparing preoperative versus, again, this is not randomized data, okay? So it's retrospective data. So local recurrence was the same, overall survival same, distant brain metastasis same, but the postoperative SRS was associated with higher rate of leptomeningeal disease and symptomatic radiation necrosis. Then this is phase 2, single arm, 1 to 4. I think this was the basis of the ongoing phase 3 clinical trial. 1 to 4 brain metastases, they all had preoperative SRS, and they found very good local control and overall survival rates, and also very low leptomeningeal and radiation necrosis rates. And then probably this is the most important paper, which is a meta-analysis published in 2023. They pulled all the data, the individual patient data of the retrospective studies, and they looked at the pre-op SRS versus post-op SRS, and the local control was better in preoperative. The leptomeningeal disease was less with preoperative. Radiation necrosis was less with preoperative. Overall survival was the same. And then this is the MD Anderson feasibility study that they did. It's a prospective study to assess the feasibility of doing preoperative SRS. So a single institution published in JAMA Oncology 2023, like 3 months ago. And they compared preoperative versus postoperative. There's a phase, this is the phase 3 trial. This is an ongoing phase 3 trial out of MD Anderson comparing preoperative versus postoperative. And this report, they already published the feasibility report out of this trial. The clinical data is still, actually, they are still collecting the data for these patients. So what they found is that SRT, fractionated stereotactic radiosurgery, within 30 days was actually, in terms of morbidity, was the same. The perioperative morbidity, comparing preoperative and postoperative SRS, they're the same. So preoperative is not adding to the surgical morbidity, let's put it that way. The treatment completion was much better in the preoperative in terms of the radiation, because most of them, they had their radiation without delay and the surgery without delay, as opposed to the postoperative. When they run into surgical complications, they would actually have delayed radiation treatment. So this is the early report of this trial, showing that it is very feasible, and we are still waiting for the clinical data comparing preoperative and postoperative stereotactic radiation treatment for brain metastasis. As through guidelines, they put preoperative as a conditional recommendation, so it's optional to do the preoperative SRS. So the conclusion is that the preoperative SRS is emerging treatment for brain metastasis. I think at some point it will be the standard of care as opposed to postoperative. So far, there's non-randomized evidence shows better rates of local control, leptomeningeal disease, and radiation necrosis compared to postoperative SRS, and we are awaiting the randomized clinical trial. Another big advantage of this, of the preoperative SRS, is that we don't delay the radiation as we see postoperatively, because you have to wait like 3-4 weeks after surgery if the patient did not run into surgical complications to start radiation treatment. So preoperatively, it does not delay the completion of the entire treatment, radiation and surgery. Thank you very much.
Thank you, Dr. Majid, Dr. Ibrahim. So again, question for the audience. If you have a patient, what would you offer? Pre-operative or post-operative SRS, based on the data that has just been shared? So we'll give some time for the poll. Just while you guys are voting and you're in a nice mood, I'll tell you something. So we are slightly late, and our last talk, which is the breast talk, our speakers, one of them has to travel. So we will, two have to travel. So we need to finish quickly. So we will continue with the sessions back to back. There is coffee outside. You can grab it and come back. But after this, oh my God, still 50%. Okay, so I think just for the sake of time, I think both points are very well convincing. I personally believe pre-op SRS is going to be the standard of care, but we cannot do it now outside the context of a clinical trial, at least. But I think I did not vote. Something happened. But I think for now, I think we have to stick with the post-op. But pre-op requires a lot of That's why I wish Dr. Sami was here. He's a neurosurgeon, so he will tell us exactly how difficult it is to plan for that. So thank you so much, both our dear friends, Dr. Majid and Dr. Ibrahim, for this. And we'll move gears now to the GI session. I'm actually moderating with Dr. Humaid, who apologized because he's stuck also in the main hall. So it gives me great pleasure, and not because we are in a radiation oncology room that we will, so there is no bias here. It's given me a great pleasure to introduce very dear friends and colleagues, both Dr. Thuraya Al-Hajri, who's a consultant and the chair of radiation oncology, and Dr. Faiq Jamali, who is a consultant and colorectal surgeon at Cleveland Clinic Abu Dhabi. So Dr. Thuraya will be talking to us about can we skip surgery in rectal cancer? Why do patients need to go for surgery if we have very good local treatment called radiation with our new techniques? So without further ado, Dr. Thuraya, the floor is yours. Thank you.
Assalamu alaikum. Good afternoon. Thank you, Dr. Ibrahim, for the invitation and the introduction. What is this thing? How to move? So the main idea of my presentation today is the organ preservation. As you can see, it's not easy to debate with the surgeons to remove them from their territory, but I'll do my best. So as you know that colorectal cancer is increasing in general. 1/3 of the cases are rectal cancer, and the incidence rate is increasing in both males and females. You can see that between 2010 and 2030, there will be increment of 124% of rectal cancer among the young age group between 20 and 34, and also about 46% between 35 and 49 years. The traditional treatment used to be easy. It was the German trial in 2004. We knew that it was mainly long-course concurrent chemoradiation followed by surgery, followed by adjuvant chemotherapy. And this showed that pre-operative chemoradiation was way better than the post-operative chemoradiation. It reduced the local recurrence 13 versus 6%. So it was one standard of care, but over-treatment or under-treatment for many patients. But now it's more confusing. We have more options. For example, chemotherapy, is it pre or post? Is it doublet or triplet? Duration of treatment. About surgery, is it TME or local excision? Also radiotherapy, is it short course? Is it long course? Should we add brachytherapy? And also the role of immunotherapy. So it's not easy to take the decision. So how to choose? I think the most important question is the intent of care. Are we planning for surgical or organ preservation? And if surgical, do we need radiotherapy? Also, if we need radiotherapy, is it short course or long course? And if radiotherapy is there, is it before chemo or after chemo? So the new paradigm is, with the modern therapy, is it possible to achieve complete cure without morbidity of surgery? And this is why, because of the complete clinical response after TNT, which may allow us to skip surgery. So why organ preservation? And this is the new movement. It's called the organ preservation movement. And it's mainly for improving the quality of life. Of course, we want to avoid permanent colostomies. We want to preserve the normal bowel function and also psychological well-being. Beside of this, there are comparable similar survival rates between surgery and the TNT. Again, why rectal preservation is mainly because it's less invasive. So we are avoiding major surgeries, infection, bleeding, nerve damage, prolonged recoveries, etc. You can see the history of cancer management, rectal cancer management. You can see here at the first in the 1990s, it used to be easy, less options. And throughout the years, you can see after 2020, lots of options, so more confusing. However, in the past, it used to be cancer disease focused, but now it is patient-centered care. So what is the rationale for organ preservation? The rationale is that lots of studies who did TNT with total neoadjuvant therapy showed that there is high or reasonable pathological complete response, like Stellar, Rapido, and Prodige trial. So the pathological complete response was about 28%. And also from the OPERA trial, that the 5-year TME-free survival was also high, we can consider it. And the other rationale is to avoid complication associated with radical surgery. So this is significant data from the International Watch and Wait database, registry of more than 1,000 rectal cancer patients who underwent TNT with watch and wait. The complete clinical response was 87%. And if there is local recurrence, it will be about 25%, which is within 2 years. And most of those patients underwent TME with 88% of having R0 disease. So the 5-year overall survival was 85%, and the 5-year disease-free survival was 94%. Of course, all of you know the organ preservation with the OPERA study. So OPERA study randomized patient to TNT, whether you start with the chemoradiation followed by chemo, or chemo followed by chemoradiation. Most of the patients went to active surveillance. And the median follow-up was 5.1 years, and the 5-year disease-free survival were equivalent, whether you start with chemoradiation or chemo. And there was no difference in the local recurrence-free survival or distant metastasis. So an OPERA study showed the risk of local growth was 25%. And if you are planning to do organ preservation for those patients, better to go with chemoradiation upfront followed by consolidation chemo rather than chemo followed by chemoradiation. And also the OPERA studies, the E is for the endorectal brachytherapy. So this is mainly for dose escalation of brachytherapy. Again, you can avoid surgery by just escalating the dose of radiotherapy using brachytherapy. And the population of this study is mainly like intermediate risk rectal cancer patients. So the idea is that dose escalation can increase organ preservation. Now we want to compare between TNT. Can we use the short course or long course? We are waiting for this German trial to get the result. This is one of our study in the National Oncology Center in Oman. So we presented this in ESTRO 2024, and it's mainly patients who received Rapido, but with simultaneous boost to the GTV. And we enrolled around 25 patients. So if you found almost half of them, if you give them boost, then the PCR is high. So actually, this is, we can, like, if there's collaboration between the GCC, we can open a randomized control trial for this topic. Now, I just want to recommend all of you to read this ISMO clinical guidelines, because it can help to direct you which management to choose. So I'll just go through it quickly. You can see the orange color is for surgery. So if the organ preservation is intended, I will go quickly through the vertical lines. So if you have early disease T1, T2, N0, so this line we are talking about, you have evidence to use either short course with direct trial, or you can use chemoradiation with the ACOSOG trial. And we are waiting for this trial to compare which is better. Is it a long course or short course for the early disease N0? Okay. We'll go to the second line. So these patients are considered as intermediate risk. You can consider OPERA trial or even TNT. And you can avoid surgery, keep surgery only for salvage. The third line, which is the high-risk criteria. And the high-risk criteria is mainly from the Rapido trial, so mainly T4 disease into MRF-positive AMVI and lateral lymph nodes. So these patients, mainly they go to the TNT. After that, you can wait, put the patients on active surveillance, and if they fail, you can go for surgery. And with the decision of regarding organ preservation, the patient has to understand that the risk of regrowth about 25%, and the patient has to stick to meticulous watch and wait surveillance with the sigmoidoscopy, DRE, and MRI. Now, another reason to avoid surgery is the immunotherapy. So we know that 2 to 3% of the rectal cancer patient can be deficient with MMR and MSI high. So this is phase 2 trial. It showed that patients who received dostarlimab, they had the clinical complete response, most of them. So I think now by default, all patients should be tested for this genetic mutation to avoid surgery maybe for them. And when to do the staging is controversial, but I would say quickly within 24 to 26 weeks. And here I decided to be nice to the surgeons and give them a chance that we can omit radiation, and there is still some role for them with the management of rectal cancer. So you can see here for if the tumor is in the upper rectum, then maybe surgery have a role, but still they need us for the adjuvant treatment. Or even with the T4 disease, if it is in the upper third of the rectum, as you can see, you can do the prospect trial or TNT, or you can go ahead with surgery followed by adjuvant treatment. So I just want to say to the surgeon, keep calm and let the radiation oncologist handle it. Thank you very much. Sorry, I had a flu, so my voice maybe is not clear.
So great talk. Dr. Jamali, yours.
Thank you. Thank you, Dr. Abu Ghaida, for the invitation. I have been officially ambushed because I did not know this was a radiation therapy conference. But it's a pleasure to be here. And it's hard to follow Dr. Thoraya, but I will try to destroy her, just like she tried to destroy me. So we will make this fun. All right, so let's talk about de-escalating radiotherapy. The slide is cut off. Is there any way we can fix it? So something has changed. The font has changed. It's going up now. Can you guys fix this from IT? No. You've changed the font. So look at this. Radiotherapy is in 2 words now, over 2 lines. The font has changed. Why did that happen? Maqsuda, mu'amara. Whatever they paid you, I pay you more. Fix it.
I think it happened with other presentations. I've noticed that the font was missing.
Yeah, it's okay. Anyway, it's just the title. I hope the rest of the... Yeah, DNA damage, clearly. Long-term side effects. Low anterior resection syndrome. Risk of second malignancy. Yes. Okay, much better. Thank you. All right. So, the price I will find out later. Can I have the remote? Thank you. All right, so I don't have any disclosures. So we know that radiotherapy improves local control, yes? Dr. Thoraya showed the slide. Everybody knows this data. But I will tell you the following. This data is from the 1990s. This is historical data. And we keep repeating the same slides. And it's time that we change. Because we are now 25 years away from where this data was collected. And if you look at our instruments at that time, and you look at the instruments that we are using today, you can see that there has been a significant progress in surgery. So we can't keep repeating those same old slides. That's the first point. With robotic surgery, we can offer more precision, less blood loss, less conversion rates, and better preservation of function. LARS rates are better, and margins and oncological outcomes are better. And we have tools to assess the quality of the specimens, and those are now included in our CAP analysis, and in every oncological center, there should be an audit of the outcomes of rectal cancer surgery. We also know that anorectal and sexual function are significantly worse when you give radiotherapy pre-op before surgery than if you don't, if you do surgery alone. The data is in multiple studies across a large number of years, and it shows basically that with surgery alone, the rate of LARS overall is 27%, and it goes up to 80% with the addition of radiotherapy. And this is taken from the Red Journal. This is your journal. And it says which treatment effects are the least brutal. So when we talk about surgery being brutal, the Red Journal is talking about radiation oncology and radiation therapy being brutal. And this makes it to the front cover of the New York Times, talking about when the Prospect trial came out, looking at when rectal cancer patients could be spared the effects of radiation. And that's what I'm going to talk to you about today. How can we spare our patients the effect of radiation? There are 3 trials that have looked at MRI-defined low-risk disease, where in the old days, those patients would all be getting neoadjuvant therapy, but those patients got upfront surgery. The Mercury trial, the Occam trial, and the Quicksilver trial, I'm sure you're all familiar with them. Those patients had low-risk disease, meaning they were node negative, there was no CRM involvement, and mid to upper rectal cancers, all got surgery. And the outcomes, if you look at the radial margin positivity, it's 2 to 3%. If you look at the local recurrence rate, it's 3 to 4%. You can't beat that. So surgery alone, no side effects, no radiation, no complications. So in these studies, summarized, let's talk a little bit now about the Prospect trial. This extends what we have been doing, so avoiding radiation therapy for those patients, but now we're talking about patients who are potentially N1 or even N2 disease. So if you look, mostly N1, T2, N1, T3, N0, N1, patients were randomized to chemoradiotherapy versus chemotherapy up front. If they had more than 20% response, they went for surgery. If they had less than 20% response, then they get rescue chemoradiation and then ultimately had surgery. You look at the curves, completely indistinguishable. You cannot separate them. So the patients that got chemo and surgery had exactly the same outcomes as the patient who had chemoradiation and surgery. And so you can easily skip radiation therapy for all of those patients that are included in this trial. But more importantly, let's look at the quality of life outcomes of that trial. If you look at the quality of life outcome, you can see that the patients who got the 5-FU with chemoradiotherapy in orange had much worse quality of life outcome. This is overall quality of life, but also when you look at bladder function, bowel function, male and female sexual function, the patients that got radiotherapy had much worse quality of life. And so yes, radiation therapy has a definite quality of life impact. And if we can avoid it, it would be better for our patients. And now, so as we talk about radiotherapy omission, we talked a little bit about the Prospect trial, but there are 2 additional trials, the Convert trial and the FORWAC trial. These are trials that were conducted in China, but the results are all identical to the Prospect trial. And it shows even in some of those patients, there were some patients with high-risk features that were included, and even then, the results were very similar. In the vast majority of patients, the pelvic recurrence rate is at the bottom line, 2% versus 2%, 3% versus 4%, 8% versus 7 to 8%. So these patients are including high-risk patients, and all of them did not get radiotherapy. They were treated with chemotherapy followed by surgery with excellent outcomes. At least 3 trials, prospective randomized trials looking at this in addition, so confirming the Prospect findings. And so the French have, and the Europeans, and we're going to refer back to the ESMO guidelines that Dr. Thoraya quoted. The French have been pushing forward this approach of what they call tailored strategy for locally advanced rectal cancer, where they are starting with the chemo first, using that as a guide as to where to go, kind of like the Prodige approach. They've been very in favor of neoadjuvant chemotherapy first, and the Europeans are kind of following in that. So there's kind of a divide between the Americans and the Europeans. So in Europe, they're trying a tailored strategy where they will give induction chemotherapy for all locally advanced patients. And then they follow them with MRI. Good responder could go to immediate surgery, the PROSPECT trial, or were randomized to immediate surgery versus 50 gray of radiotherapy, and the bad responder were randomized to 50 versus 60 gray of radiotherapy, so escalating doses of radiotherapy. I will not say anything. So they've taken this further in the GRECOR 14 trial, which is a multi-center trial. This is not published yet. We're looking forward to the results of the trial. But again, they're looking at the tailored management. So locally advanced cancer, you start with chemotherapy, you see what kind of response you get, and then you tailor the management accordingly. So this is a bit of a French approach. But what they're trying to do basically is they're giving induction chemotherapy to everyone. And then after induction chemotherapy, the patients will go into the organ preservation arm. If they go into organ preservation arm, then there's a variety of techniques that will involve radiation therapy. Or they go into the radiotherapy omission arm, which is what I'm arguing for. And in the radiotherapy omission arm, they will go to, depending on the PROSPECT trial or the GRECOR 4 and 14 and the NORAD trial, will go to either, will go straight for surgery without the use of radiotherapy. So radiotherapy omission. So you go into induction chemo, then organ preservation versus radiotherapy omission. That's kind of like the scheme that they're following. And if we look at the ESMO guidelines, this is for T1 to T3 localized rectal cancer in the upper rectum. If anyone can find the word radiotherapy here, I would be appreciative. Where? In the adjuvant setting, no one would do that anymore. We can debate that. That's very debatable. All right, but surgery, right? Those patients are best served with surgery. And then if we look at the localized rectal cancer in the lower and middle third, who can find the word radiotherapy anywhere on this slide? I understand, but still, I can't find it. These are guidelines. There's no radiotherapy here in this slide. All right, yes. So they talk a little bit about here, yes, for the note positive. So you can see that we are shifting away from that. And the final thing that I want to point to is this small but very interesting NEO trial that have looked at really low to mid-rectal cancer. And those are typically patients to whom we give radiotherapy. And these are patients that receive 3 months of chemotherapy with modified FOLFOX. And when they had the evidence of response, they got TEM surgery. And if you look at this, the organ preservation rate was about 57%. It went up to about 79% overall. And of the patients who got TME, there were 7 out of 10 patients here who had a complete response, T2N0. So even for low rectal cancer, there is room for patients to be treated with chemotherapy followed by local excision and avoiding radiotherapy for some of those patients that are highly selected. But the most important part is if you look at the large score of these patients, they had excellent large scores because of organ preservation and avoidance of radiotherapy in those patients. And so I think what we're debating now is we're moving from the one-size-fits-all to something that is tailor-made and custom-fit designed for the patient. And I think what we really have to be careful about and look at is what we call the risk factors for recurrence. And you have in the middle the green area, which is the T1 to T3 and 0 without any additional risk factors. As you go out, you get the positive lymph nodes, EMVI, some tumor deposits, T3C, T3D, and 1, but the CRM is not involved. And then at the extremes of high risk of pelvic recurrence, the lateral pelvic lymph node, the low tumor, the MVI, and over there, the elevated CEA, the N2 disease, the tumor deposits. So I think you have a kind of a spectrum if you look at. And what I'll submit to you is I think for the T1 to T3B with no additional risk factors, what you need to do is you need to find yourself a good surgeon who will do this case robotically, and that'll take care of it. I think as you go a little bit wider, you may need the help of your friendly oncologist, and in that case, you can call on your friendly oncologist for some chemotherapy. But definitely what you do not want is radiation therapy. Thank you very much.
I'm voting for you. We cannot skip this without questions. Come on, this was probably the best debate sessions we had. And thank you so much, both Dr. Thuraiya and Dr. Faq. I'll leave maybe a floor for some questions. If no one has a question, I'll start with. I have a question. خليني. Quick question. So I'm convinced. I really, you showed very convincing data, but my concern is the adjuvant, right? So you mentioned briefly we have to debate this, because if we want to follow the guidelines, we know that adjuvant radiotherapy after surgery is way more toxic, higher dose. There is no hypofractionation arm. It's all long course, and we need to dose escalate to account for the hypoxia that surgery can account, and the quality of life is miserable. How do you? I mean, the guidelines still tell us, there is risk factors after surgery. I mean, there's the green thing that you saw. There's give CRT, which is chemoradiotherapy, which is long course. So, should we cross it out? What are your thoughts about the adjuvant in the setting where patient might require either, because we're still giving positive patients, we're still giving positive margins, for example.
Right. So I think, honestly, my answer to that is it's how good you are with your pre-op evaluation and with your surgery. In the era of MRI-guided imaging, the rate of error has decreased dramatically. And in the era of robotic surgery, when you have good surgeons that know what they're doing, and in the era where we do the MDT discussion all together and we review those patients, I would submit to you that probably in the last several years, we have not had a patient who has had to receive adjuvant radiotherapy in the adjuvant setting. I think if in doubt, we will err on the side of pre-op. So whenever there's a doubt, we will err on the side of pre-op.
Yeah.
Because of exactly what you alluded to. So I would say that scenario is extremely, extremely rare if we do a proper preoperative multidisciplinary evaluation.
Okay. Dr. Hassan.
So a couple points. I have seen, cases where they should have received some neoadjuvant therapy, and the surgeon take them to the OR right away. 7 positive nodes, mid-rectal. These are unfortunate cases, but that's what's still happening, unfortunately. That's one point. The other point I want to mention, there is a big move to organ preservation, which you mentioned, in which case, unfortunately, we have to depend on the chemo and radiation together. So if you have a patient well-educated, how do you talk to him about that? Doing a chemorad with the hope of organ preservation versus a prospect approach.
Thank you. Very interesting. So in my mind, surgery and radiotherapy are local treatment modalities, and chemotherapy is a systemic option. Most of the patients will need one or the other, either surgery or radiotherapy. Everybody will, in my opinion, need the chemo part. So for most of those patients that are locally advanced, when we're aiming for organ preservation, they will get their chemo. The question then becomes trying to weigh the toxicity of radiotherapy versus the toxicity of surgery. And I think if you look at what's happening in the surgical world, there's this big move away from radical TME surgery towards an approach that more focuses on local excision in an attempt to provide organ preservation. And so we have to carefully weigh it by patient. If the bulk of the disease is endoluminal and there's not a lot of nodal disease, lateral pelvic lymph nodes, CRM positivity, those patients, in my opinion, are better off with systemic chemo and local excision rather than TNT with radiotherapy. For the patients that are in the extreme red that I showed you with very high risk of pelvic recurrence, we still need the radiotherapist sometimes. So I think we will give those patients TNT with radiotherapy and maybe salvage them with a local excision if needed. But those are the patients that are going to have the highest rate of LARS and problems with organ preservation.
I think, as I said, the decision should be from the beginning. What is the intent of treatment? Is it an organ preservation or surgery? For example, if a young lady is like 35-year or childbearing age, and they have like a colorectal cancer, and the patient, the infertility, maybe the patient should go for surgery and avoid radiation. But for example, if we have elderly patient who who doesn't want to have colostomy or for any reason. So we can offer this patient organ preservation and avoiding surgery. So everything should be discussed with the patient and in the MDT.
Yeah, I really like the French as well approach. It's very kind of tailored. So again, guys, just for the sake of time, we will not have a coffee break. So everyone can grab a coffee, but we will continue. Let's not all leave together so that we don't create that. Thank you so much, Dr. Jamal and Dr. Thoraya, for this. Really appreciate it. I think that was, and then I'd like to introduce our next moderator. So there is no coffee break. We move to the gynae session because our best speakers needs to leave. They're traveling. So I'd like to introduce the moderators for the next session. So if I can get the welcoming slide for the moderators, please. So I know the first moderator. He is our dear colleague and dear friend who works with us at Burjeel Cancer Institute, Dr. Amin Abyad. He's one of the prominent medical oncologists that I'm really lucky to be working with. Very meticulous, along with Dr. Raoul. Dr. Raoul, very warm welcome. Thank you. I've been seeing you. You've been there for a while, so I really appreciate you sticking around with the radiation oncologist. We'll go over to the gynae sessions. You guys could introduce the speakers.
Assalamu alaikum. It's really an honor to be among our esteemed radiation oncology colleagues. I mean, you don't get invited a lot to radiation oncology meetings. So it's really a pleasure to try to moderate the session. So now we're talking about endometrial cancer. We know that endometrial cancer is common. We know that what's unknown is... Cervical. Sorry? Cervical cancer. So I'm in the wrong session. Okay, so we know that cervical cancer is very common, and what's really needed to be answered is the question is that do we still need chemotherapy or we just in the era of immune therapy? So the fact that induction chemotherapy might not really be needed. So for that, we're going to have two speakers. I'll be lucky to introduce our esteemed colleague, Dr. Dalia. Dr. Dalia is a very well-known medical oncologist. She's currently working in Sheikh Shakhbout Medical City in Abu Dhabi. Dr. Dalia is very well-known. She's a patient advocate. She's a huge participant in all our meetings, and we all love her. Please, Dr. Dalia.
Assalamu alaikum everyone, and at the beginning I want to congratulate Dr. Abu Ghida for this interesting session. Thank you very much for inviting me to the session, and thank you, Dr. Amin, for the kind introduction. So my role here is to defend the role of induction chemotherapy in patients with locally advanced cervical cancer. So I think for decades we know that the standard of care treatment for patients with locally advanced cervical cancer is concurrent chemoradiation therapy. We know that very well. There's no doubt about that. Giving cisplatin plus concurrent plus radiation therapy, it's actually improved the overall survival over 5 years from 60 to 66%. So we have about 6% gain in the overall survival. However, it is not enough because most of the patients, about 50% of the patients, will recur within the first year after completion of the concurrent chemoradiation therapy. And that's why there was a lot of unmet need in this group of patients, how to improve this patient, or how to improve the efficacy of treatment in this group of patients. So they tried multiple approach, including adding more chemotherapy to cisplatin, adding different agents, but it didn't work. Only the cisplatin plus radiation therapy is the one standard of care up till now. One more actually achievement in the treatment of patients with locally advanced cervical cancer is the progress that happened in the techniques and machines of radiation therapy. Honestly, with the introduction of the IMRT and the VMAT technique in the radiation therapy field, it significantly improved both the local control. It reached to up to around 90% local control, as well as the overall survival that improved up to 75% with the new techniques of radiation therapy. Putting that together as well with the less toxicity and less side effect by delivering higher dose to the target volume with less dose to the organ at risk. So it's really make a big difference in the treatment of this group of patients. Then comes the question of chemotherapy. I'm a medical oncologist, so the chemotherapy is my concern. So what about adjuvant chemotherapy after finishing the chemoradiotherapy? We have a lot of trials testing this approach, but as per the latest OUTPAC trial that was published recently in the ASCO and the last ESMO as well, it didn't show any benefit. So adding more chemotherapy, post-concurrent chemoradiotherapy in patients with locally advanced cervical cancer, we didn't see a lot of advantage in overall or progression-free survival. Then in 2023, we actually 2 important clinical trials came out and presented together in the same ESMO 2023 presidential symposium. One of them, the interlace that I'm going to defend, giving induction chemotherapy, short course for 6 weeks, followed by concurrent chemoradiation therapy. And we have also another approved, so interlace already approved, and it's there. Many people are using it. And we have also the introduction of immune checkpoint inhibitor, together with the concurrent radiation, so chemoradiation therapy, followed by adjuvant or consolidative immune checkpoint inhibitor pembrolizumab, the keynote A1A trial. This is also standard of care, and this is also approved. So the concept of giving induction chemotherapy overall is to decrease the distant metastatic rate and to try to do better local control with only 6 weeks of weekly paclitaxel and carboplatin, followed immediately in week 7 by the concurrent chemoradiation therapy. So it was tested, this approach was tested in phase 2 trial, the CX2 trial, 46 patients, and they achieved about 70% overall response rate with using this approach. So it was worth to test it in a phase 3 trial, which is the interlace trial. The interlace trial, it is actually a pure academic trial, testing the concept of induction chemotherapy, weekly paclitaxel plus carboplatin AUC2 for 6 weeks, followed by immediately with chemoradiation therapy using cisplatin, and then versus the standard of care, which is just chemoradiation therapy. They enrolled patients with locally advanced cervical cancer, and I want to highlight here, it's very important because the interlace trial, they included patients with stage 1P, stage 1P1 and 1P2 with node positive, and the stage 3 and stage 4A. But they did not include patients with para-aortic lymphadenopathy. Of course, with adequate liver and kidney function and fit for chemotherapy. So they randomized about 500 patients between these 2 treatment arms, induction chemoradio versus chemoradio as a standard of care. And if you can notice here, there is no placebo in the control arm. They stratified the patient according to different factors, as you can see, site, stage, nodal status, the type of chemotherapy, the radiation therapy, whether this is 3D or IMRT, 2D or 3D, external beam brachytherapy, a tumor size, and the type of histopathology. The dual primary endpoint of the interlace was BFS and OS, as multiple secondary endpoints. I'm not going to disturb you by a lot of information, but just I want to highlight the important finding in terms of disease characteristics. I just want to highlight that about 80% of the interlace trial were patients with stage 2 cervical cancer. Most of them, more than 80%, have squamous, of course, and around 60% of them have lymph node negative disease. So only 40% with lymph node positive cervical cancer. When it comes to the adherence to induction chemotherapy, most of the patients completed the induction, 6 weeks of induction, about 85% of them. And when it comes to the cisplatin, yes, giving the induction chemotherapy followed by chemoradiotherapy, we can see here 69% of the patients completed the induction chemo followed by chemoradio versus 79% who completed the standard of care chemoradiation therapy. And here is the adherence to radiation therapy. And this is the primary endpoint. It is a positive trial, as I mentioned earlier. So there was a significant improvement of the PFS in favor of induction 6 weeks of chemotherapy followed by concurrent chemoradiation versus the control of just concurrent chemoradiation therapy with a hazard ratio of 0.65. It means about 35% reduction in the risk of disease recurrence or death due to recurrent cervical cancer. At 5 years, the progression-free survival rate improved from 64% with the concurrent chemoradiation to 73% with the induction 6 weeks of chemo followed by chemoradiation therapy. And this also translated into an overall survival benefit. As you can see here, the hazard ratio 0.61, and the 5-year overall survival, again, in favor of the induction chemo followed by chemoradiotherapy, 72% with the chemoradiotherapy alone versus 80% for the induction followed by chemoradiotherapy. And this is the subgroup analysis in terms of PFS, and this is the pattern of relapse. When it comes to local recurrence, pelvic recurrence, there was no definite difference between both treatment, whether we give induction followed by chemoradiation or whether we give just chemoradiotherapy. But if you look to the distant metastasis here, 20% of the patients who received chemoradiotherapy only developed distant metastasis in comparison to 12% with induction followed by chemoradiation therapy. So induction chemoradiation therapy plus the local control, it also helped to better control the distant metastatic rate. So it is a positive trial, no doubt about that. It takes about 10 years to get this result with a PFS benefit of about hazard ratio 0.65, OS benefit hazard ratio 0.61. The adherence to chemoradiation therapy was high in both arms. The overall survival also showed improvement in favor of the induction for chemo followed by chemoradiation, and it became one of the standard of care option in the treatment of this group of patients with advanced cervical cancer. This is not the only trial. Dr. Zainab will talk about the keynote A18 trial in detail. This is simply testing the concept of giving the immunotherapy plus concurrent chemoradiotherapy and consolidating the response we achieved with immune checkpoint inhibitor. Again, I will not go through it. It's a positive trial, no doubt about that. As you can see here, this is the subgroup analysis. As you can see here, I can feel the benefit mainly taken for patients with stage 3 and stage 4A disease. Here I put it together parallel in one table. It's not a comparison, we cannot compare this trial, but I just want to show you the difference. Honestly speaking, I feel it is not a debatable trials because we have different group of patients. The interlace, they excluded the patient with para-aortic lymphadenopathy, and it was done during the era of radiation therapy technology was not that advanced before the IMRT, before the VMAT. So, and while the keynote A1 trial, it's full of everything is new, the patient population of the trial also included having a very advanced high-risk disease with para-aortic lymphadenopathy, and in around 90% of the trial population, they used more advanced radiotherapy technique. Both trials are positive, both trials are there. Which one to select? I think this is the discussion. I think we will answer this question during the Q&A. So we have the induction in 2025. We have these two options available in our hand, the induction short course of chemotherapy followed by chemoradiation therapy, immune checkpoint inhibitor, if it is available. We have many countries that still the immune checkpoint inhibitor are not there, so it's an option to use the induction followed by chemoradiotherapy. But if it is available, the immune checkpoint inhibitor, we can use it together with the chemoradiation therapy followed by consolidation with pembrolizumab. My own opinion, I think sequencing all this together, including chemotherapy followed by chemoradiotherapy plus immunotherapy and consolidating whatever using the immune checkpoint inhibitor can help our patient. ctDNA is an option. I think we have recently heard about the CALA trial with analysis in the last ASCO with the ctDNA data, very impressive, and I think this is the future of our cases. Thank you very much.
Yeah, and the next speaker is Saida Ibrahim, and she is gonna tell us about the immunotherapy, the use of immunotherapy in the chemoradiation, the locally advanced cervical cancer. It's my pleasure. So she's pro using immunotherapy. Yep.
Thank you for the introduction. It's a privilege to be here with you in this important event. I would like to thank Dr. Al-Shamsi, Dr. Ibrahim, and Dr. Majid for the kind invitation, and thanks the organization committee. Actually, Dr. Dalia made my job so easy. So I'm not gonna repeat. I will go quickly through the topics that been presented, but with more details of inside the trials and how we can stratify and choose our patients. How can I switch? Okay, so as Dr. Dalia mentioned, for more than 2 decades, chemoradiation therapy has been the standard of care in locally advanced disease, cervical cancer. Advances in radiation therapy coupled with the attention to the radiation dose and also the time of radiation to be delivered to the treatment, that made a difference in the overall survival and the local control. But yet, up to 30% of patients still are relapsing, and we have die of metastatic diseases. Also, as mentioned, historically, multiple trials has been conducted by adding chemo or immuno, and showed also non-superior results, like the Outback trial when we added adjuvant paclitaxel for 3 cycles, or in the CALA trial with anti-PD-L1 durvalumab added. And as we can see here, there is no much of added improvement. Till the pembrolizumab era is there, and it showed a very good survival effect, like in the Pacific trial after showing the result in the lung cancer. So why not to try it in the cervix cancer? So this was the extrapolation from the lung trials, where the keynote trial that been published in the January 2024, which is the strongest, and the first trial showed effect on improvement of the progression-free survival and the overall survival by adding the pembrolizumab. And here, the strength of this trial is not only due to the number of cases, where they randomized 1,000 cases between the 2 arms of the standard chemoradiotherapy plus pembrolizumab, followed by 15 cycles of adjuvant pembrolizumab, compared to the standard arm, which is the cisplatin, for 5 cycles, concurrently with the external beam radiation therapy, followed by brachytherapy and the placebo, followed by the 15 cycles of placebo. So the importance also of this trial is the stratification factor, how they stratify their cases. So they look back into the details of these patients. Not only they include the full from stage 1B to 4, but they look into stage 1 and 2 separately and stage 3 and 4 separately. As Dr. Dalia mentioned also, they include the para-aortic lymph nodal involvement. They look into the quality of radiation therapy. So whether the radiation therapy was delivered by VMAT IMRT, with image-guided adaptive brachytherapy or non-image-guided radiation therapy modalities, plus the planned dose also, whether they were able to deliver 70 gray versus more than 70 gray of radiation therapy. So they saw that there will be no benefit in stage 1 and 2 diseases, but it showed a benefit only, the slides also are overlapping, but in stage 3 and 4, it showed a significant benefit toward the overall survival and the progression-free survival. So we have a benefit whenever we have lower vaginal involvement, parametrial invasion, pelvic organ invasion, and heavy nodal involvement, not only pelvic nodal involvement. In regard to the interlace, which is also a positive trial, and it showed an improvement in the progression and overall survival, but looking back into the stratification of their patients. So what about local control? Although we know that it affects the distant-free survival, but in the local control, we have 16% of local relapses within the patient of the interlace. And that's why when they dig more into the patient, they found like only 30% received image-guided brachytherapy, while the others just the conventional brachytherapy. Also, staging PET-CT scan and follow-up MRI was not mandatory with their protocols. So they can take it against them that there is a bias in their follow-up and their stratification of, or patient selection, who are like relapses and who are not, because of there is no documentation with MRI or PET-CT scan. Also the toxicity here. So the toxicity of the induction chemotherapy is a bit higher than the others. Okay, I'll be short. So who will benefit from the keynote? The strongest signal in stage 3 and 4. Stage 2B, 1B2 and 2B subgroup didn't show any clinical meaningful progression-free survival. So we can conclude that immunotherapy combined with the chemoradiation therapy is beneficial, and it is like FDA approved, and we can use it for stage 3 and 4A diseases. But yes, some experts note that the trial cohort was relatively, this is regarding the interlace. Yes, it showed improvement, but it showed like some fit selected patients. So there was bias in their selection, but still it's the first also phase 3 trial that proven induction chemotherapy can do improvement in the survival. So we can add, still we can add it, and it's FDA approved, and it's evidence-based. We have to look into the details of the EMBRACE, because the EMBRACE itself, which is the systemically applying IMRT with daily IGRT, as well as advanced image-guided adaptive brachytherapy, it showed like a very good local control rate. Because the involved lymph nodes were boosted by the IMRT, and the EQD2, the gold standard is to reach to the EQD2 to the high-risk CTV with a D90 of 80 to 85 grays, and to the GTV residual of a D98 of more than 95 grays, while minimizing the dose to the bladder, rectum, and sigmoid. Maximum treatment time also taken into consideration here, which is within 50 days. And previously in the EMBRACE-1 results, we have them already, and it showed that more than 85 gray is delivered to 90% to the high-risk clinical target volume, and the local control rate of 90% can be expected. So this is more than what happened in the interlace local control. And this is the difference between the old technique, when we have the box technique, radiation, rather than how nicely now with the IMRT and VMAT we can confine the dose distribution, and even we can boost these lymph nodes whenever we see them. Plus the residual here after the external beam, the brachytherapy here, we use image guidance to just focus our boost to the GTV and high-risk CTV, which is the parametrium, rather than the old technique, which is a blind, almost a blind technique. So this is a practice changing. This is the result of the EMBRACE, and it showed very good 5-year local control of 92%, with a minimum cumulative grade 3 toxicity, and the rate of fistula is 3.2% only. So if not in a trial and patient has a stage 3 and 4 chemoradiotherapy, we can conclude that we can do the chemoradiotherapy plus adding pembrolizumab. But if your center has limited access to image-guided brachytherapy, PET staging, and immunotherapy, we can go for the interlace style induction 6 weeks of chemotherapy, followed by chemoradiotherapy, which is also like evidence-based, but we have to take care of the toxicity. We should be aware like tumor resistance in the future can happen due to change in the PD-L1 status, and it is only suitable for low nodal volume involvement. Now, what about if we need to add induction chemo if we are already giving the pembrolizumab? While searching, I found this case report of a 53-year-old patient with a FIGO stage 3C squamous cell locally advanced cervical cancer who received like induction chemotherapy and showed a very good partial response after induction chemo and chemoradiotherapy. But metastatic disease happened after 5 months, and the patient was at that time prescribed a platinum-based chemotherapy, immunotherapy, and anti-angiogenic treatment. So after 3 cycles, the disease showed an unequivocal progressive disease. So they resulted that despite the tumor response to induction chemotherapy, the patient tumor exhibited resistance to carboplatin and paclitaxel chemo. Not only that, but also to the pembrolizumab and bevacizumab. So here we can conclude that the concern about the potential impact of induction chemotherapy on subsequent chemotherapy and targeted treatment efficacy is questionable here. And this observation is especially concerning because of the progressive disease occurred despite the addition of both immunotherapy and anti-angiogenic. So this needs a further trials to conclude whether we have to add induction chemo or no. So there are ongoing trial, which is the most important two are, this is the last 2 slides, I guess, is the NCT 05173272, which is currently recruiting a phase 3 trial. Experimental arm is the neoadjuvant chemotherapy, cisplatin paclitaxel, combined with serpolumab for 2 cycles, followed by concurrent chemoradiation, to be compared with the control arm, which is the concurrent chemoradiation alone. The other trial is the NCT 07061977, just registered in July 25. The experimental arm is the induction carbopacli plus pembrolizumab, followed by chemoradiation therapy, pembrolizumab, followed by maintenance, versus the control arm, which is the standard chemoradiation and pembrolizumab. Primary endpoint here is to determine whether induction immunochemo prior to the concurrent chemoradioimmunotherapy plus maintenance immunotherapy improve progression-free survival compared to the control arm, which is the keynote style now, the practice. So looking forward for these results. So this is my conclusion. We have to be cautious using induction chemo, which can increase toxicity and enhance the tumor resistance to immunotherapy. IMRT and image-guided brachytherapy are effective at reducing normal tissue toxicity and allow for dose escalation to the residual disease in the central pelvis. Also, induction chemotherapy can be used in low-volume nodal disease. Doing both induction chemo and pembrolizumab is best done within a clinical trial until the phase 3 data are mature. And standardization of the image-guided adaptive brachytherapy and advanced radiotherapy technique is crucial in making any trial in this matter. And thank you very much.
Thank you so much. So before you vote, let's summarize really quick both studies. Okay, we are discussing about using neoadjuvant chemotherapy in locally advanced cervical cancer or immunotherapy. So 2 different trials. I would say an old one and a modern one. Interlace, it took 10 years from 2012 to 2022, and only 39 of them, they received modern radiotherapy, what we call the IMRT or VMAT, okay? And they were mainly made in Mexico, UK. They got what they got. The waiting list for the radiotherapy, normally I've been in Mexico, it's around 2 months, okay? 70% of them, they were mainly 2B. Most of them, they were lymph node negative, versus Keynote A18. From 2020 to 2022, in 2 years, it took more than 1,000 patients to be recruited, okay? 90% of them, they got modern radiotherapy, so good technique. So the technique is crucial on that, okay? 84% of them, they were really high-risk patients with lymph node involvement. 22% of them, they have peri-aortic lymph node involvement. In the interlace, they just excluded, so we don't know this really high risk. So 2 different populations in 2 different times in the chronology, okay? So now look your specific patient where is, in the interlace or in the immunotherapy area. Because so far, we don't have data, and I would not be so brave to use the combination, let's say neoadjuvant and then pembrolizumab, okay? So saying that, with no questions after this, because we are in a hurry, just vote. Thank you so much.
Thank you so much. We'll move to the last session. It gives me great pleasure to introduce our moderators. I have Dr. Taghreed Al-Hindi. She will be moderating this session. And I think they're trying to get Dr. Nuhad. Dr. Nuhad is here, my friend. I didn't see you. Alhamdulillah. Dr. Nuhad, tfaddal. You're sitting in the back. So we want you here. So it's really an honor to introduce the moderator, Dr. Nuhad Ibrahim. He's a professor of breast oncology and one of my mentors and teachers that I had the privilege to work with at MD Anderson. And of course, Dr. Taghreed, she's a prominent breast radiation oncologist, one of the leaders in her field in Saudi. And we will have the last session today. It's going to be a debate about the role of local therapy in oligometastatic. I'll leave you to introduce the speakers.
Thank you. Good afternoon, esteemed colleagues. Thank you, Dr. Ibrahim, for the great introduction. We have finally reached our last session of the debate, which is quite interesting and one of the very common questions that is always debated in our breast tumor boards. So our topic today is about oligometastatic breast cancer. Is local therapy to the breast, whether surgery, radiation, justified? And we've got 2 prominent speakers. My colleague, Dr. Faiz Al-Shafeh, who's a consultant radiation oncologist in the southern region of KSA. He is with giving local treatment. And we have Dr. Saeed Rafa, who's a medical oncologist, against this statement. So with no further ado, Dr. Faiz, please go ahead.
Assalamu alaikum wa rahmatullah. Good afternoon, everyone. I just wanted to start by saying how honored I am to be here today, and thank you all for joining this talk. As the time of going to the airport is approaching for my flight and Dr. Taghreed, I encourage you all to put your seatbelt on because I'm going to go fast on my presentation. So today I'm going to be talking about is local therapy justified for oligometastatic breast cancer. Okay, we'll go through some epidemiological facts about metastatic breast cancer. We know breast cancer continues to be the 2nd common cancer that's diagnosed and the 4th leading cause for mortality. In the United States, I think there is some issues with the presentation, but in the United States, if we look at this figure, they looked at their cohort between 2001 to 2021. The incidence of breast cancer continues to rise. The incidence of stage 4 breast cancers continues to rise as well. In 2001, it was 5.8%. In 2021, it approaches 8%. This is the Australia population. They looked at their population for the last like 2 to 3 decades, and they reported the breast cancer incidence continued to rise. On the other hand, the survival is improving, and the death from breast cancer is improving as well. And this is, I think, due to the progression that we have made in terms of the management of breast cancer. Metastatic breast cancer is a heterogeneous disease. We have at least 6 subtypes of breast cancer. And it's not only these, like how many subtypes or molecular subtypes. We have oligometastatic breast cancer with either single metastases or up to 5 metastases. And we have polymetastatic breast cancer. The location of metastases itself matters. And the response to the therapy or systemic therapy matters as well. Duration of response matters, etc. So it is a huge group of population. This is a population-based study. They looked at almost 12 or 13,000 patients with de novo metastatic breast cancer. And they concluded that the subtype of breast cancer affects overall survival after metastases. It's not only the subtype. Patients with bone metastases, they did way better than other patients. Burden of disease matter. This is the Netherlands cohort. They looked at more than 3,000 patients. And there is significant survival differences between patients with single metastases, 2 to 3 metastases, and more than 3 mets, and even like more than 5 metastases. So the burden of disease matters in terms of survival. They also reported that local therapy also matters. Patients who were treated with local therapy either to the primary site or all of the metastatic spots, they did way better. The paragraph on the left-hand side showing the overall cohort where they treated locally at the breast site and the metastatic sites. And the one on the right-hand side is showing the overall survival difference between patients who they received SBRT to the oligometastatic spots. Now, role of metastatic directed therapy in metastatic cancer, generally speaking. We know this back in 1995, Dr. Hillman and Dr. W, they came up with this middle ground state between localized disease and metastatic disease, and they came up with the oligometastatic state. These are the definitions, or the main 4 definitions of oligometastatic or the oligometastatic state: synchronous oligometastatic disease, metachronous, oligorecurrence, and oligoprogression. And we know the seed and soil theory in terms of the treatment of oligometastatic cancers generally. The seeds are the cancer cells when they exit the source. The soil is the organ itself that provides a good microenvironment for the seeds to be implanted, to grow, and to become like another source for another seeds to metastasize. Direct attack to the seed themselves and to the soil proven to be beneficial. SBRT proven to be beneficial to attack the seeds themselves and to attack the soil. Role of metastatic directed therapy in oligometastatic breast cancer. So I will go through some retrospective data and prospective data, and finally systematic review and meta-analysis. This narrative review looked at all of the published data that's looking at oligometastatic treatment with SBRT. They identified many papers. This is one of them, like prospective phase 2 multi-center trial in Italy. They treated 54 patients with SBRT, 5 or less intracranial metastases treated with SBRT or extremely hypofractionated treatment. A median follow-up of 30 months. The median follow-up of 30 months, 1 and 2 years progression-free survival approaches 75% and 53%. The 2 years overall survival was approaching 95%, and no grade 3 or higher toxicity. This is very convincing. And this is the Milano study. They analyzed 2 prospective trials. They reported 4 years overall survival was 59%, and progression-free survival was 38%. Interestingly, patients with bone-only metastases had 5 and 10 years overall survival of 83% and 75%. Patients with non-bone mets had less overall survival benefit. This is a retrospective multi-center study published in 2021. They looked at their own data, and they reported like good overall survival at 1 to 3 years at 93%, 87%, and 81%. Progression-free survival was even good. And more than 60% of patients, they had zero toxicity from SBRT. And there was no local recurrence with a median follow-up of 3.4 years. So it was good to control the disease distantly. This is systematic review for some of the papers that we reviewed earlier. I brought this slide to look at the toxicity of grade 3 and more. It was almost negligible in terms of SBRT toxicity. This is the NRG-BR002 trial. They randomized patients with metastatic breast cancer, 4 or less non-metastatic spots with controlled primary to continue on the standard of care or to receive local treatment. This is the patient characteristics. We can appreciate 60% of patients were having single metastases only. And not only this, 80% of patients had I would say, the most indolent disease that we see in terms of the different subtypes or molecular subtypes of breast cancer, hormone receptors positive and HER2 negative. So someone would say at least 50% of the cohort, they had single metastases, ERPR positive, HER2 negative. And in fact, it was a negative trial. There was no benefit of offering local treatment, but there are some limitations. Number of patients was low. The median follow-up is very short, and most of the population, again, had single metastases, ERPR positive, HER2 negative. This is the CURB trial. They selected oligometastatic breast and lung cancer patients, randomized to continue on the standard of care or to receive SBRT to the metastatic spots. 47 patients were randomized in the breast group, 23 in the standard of care, and 24 in the SBRT group. The median number of lines of systemic therapy were approaching 4 lines, 3 to 4 lines in both arms. And if we look at their conclusion, it was negative again. But again, it has very, very small number of patients. And breast cancer patients tend to develop new metastatic lesions. Systemic progression was observed in breast cancer. If you look at this figure here, the breast SBRT, 63% of the patients, they developed metastatic disease or widespread disease, the same with the standard of care. So it is mainly systemic disease now. The chemotherapy was not even able to control it. This could be one of the limitations of this trial. This is a meta-analysis. They looked at 15 published data, and they concluded, so the data was for all the different sites. They identified also some of the breast data, and again, it was negative. There was no benefit of adding SBRT or treating the oligometastatic spots with SBRT. Now, we'll talk about the role of SBRT in maintaining systemic therapy. This is a retrospective data from France, published in 2022. They looked at their own data, and they concluded SBRT may be safely used to defer systemic therapy change in selected oligometastatic patients. And the median time to change systemic therapy was more than a year, which is a good number. This is the AVATAR clinical trial. We all know this trial. They were looking at also the same question. 32 eligible patients were randomized. The median follow-up was 24 months. The median progression-free survival was almost 10 months. 47 patients were event-free for 6 or more months. 44% of patients maintained systemic therapy unchanged for a year. and 36% for 24 months. No grade 3 or higher toxicity were reported, and 100% local control with SABR to the oligometastatic spots. Now I want to switch gears and talk about the safety of SBRT itself. This meta-analysis, they reviewed, again, all of the literature that was published and reported the toxicity from SBRT. They looked at more than 900 patients with more than 12,000 or approaching 13,000 of oligometastatic spots that were treated with SBRT. And the toxicity from SBRT was almost negligible. It was less than 2%. The estimate of acute grade 3 to 5 toxicity was 1.2%, and the grade 3 to 5 toxicity long-term was 1.7%. So it is like very, very safe treatment and very safe approach. And if we think about it, observation sometimes itself may cause like harm to the patient than offering SBRT. Some practical consideration. I wanted to bring this slide just like for our learning purposes. They do recommend some agents to be suspended during SBRT or when considered SBRT for oligometastases. And this is another summary done by a colleague who is an assistant professor in the University of Toronto, looking at the same piece of information. So my conclusion, changing or challenging the dogma. Is this the end of SBRT for oligometastatic breast cancer? The broad approach of withholding treatment for oligometastatic breast cancer based on negative trials deserve a critical rethinking, considering emerging modern technology or modern oncology principles and technologies like circulating tumor cells and circulating DNA that may help us to identify which patient will benefit more from treating the oligometastatic spots. Real-world experience and data, we have like our own data and our own practice that shows offering SBRT help the patients, and also the safety of SBRT. Absence of evidence is not evidence of absence. Negative trials due to small sample size and low numbers, lack of patient stratification, and limited follow-up in the trials that we mentioned earlier limit their universal applicability to this big and heterogeneous group. We have, again, supporting evidence beyond these failed trials, either retrospective or personal experience, individualized and multidisciplinary approach. Be careful with a blanket, no-treat approach. Treatment decisions require multidisciplinary evaluation. So my clinical conclusion, there remains a legitimate role for aggressive local therapy in carefully selected patients with oligometastatic disease. This approach demands balancing available data, clinical expertise, and comprehensive treatment overall plan. This is an upcoming webinar in October. It will be presented by Dr. Stephen David, the first author of the AVATAR clinical trial. And they will, Dr. Stephen David and his colleagues, they will also discuss the role of metastases-directed therapy for oligometastatic and oligoprogression in breast cancer. And I think this will be a good opportunity for us to learn more about this approach from the experts. Thank you.
Thank you, Dr. Faiz, for this interesting talk. Probably before you leave, do you have a very quick case scenario where you would be offering local treatment in the state of oligometastasis? So you get a, let's say, stage 4, an average 50-year-old lady, luminal versus, let's say, a HER2 positive breast cancer who presents with only single bone metastasis. Do you have a preference of treating oligometastatic site in either one of them after, of course, systemic therapy or not? Let's see, I mean, I just want to get your opinion on that.
Okay, I don't want to be biased because I always push the boundaries and offer the most aggressive treatment for many reasons. Number one, patients themselves, they seek and ask for the most aggressive treatment because they want to be cured, number one. Number two, we are able to deliver like SBRT and treat many, many, many spots with like very limited side effect profile. So my answer is yes. I would be keen to treat them safely. If we look at the side effect or the paper that looked at the side effects from SBRT, the 1.2 and 1.7% toxicity were from trials that treated patients in like between 2010 to 2015. Before we learned more from Saber Comet and Saber Comet 10 and Gomez trial, before we learned more about the ideal patients, ideal candidates, and the proper dose for oligometastatic patients. Also, they used like high doses that is used only for radical cases, early stage non-small cell lung cancer and other cancers. So when you are able to deliver like meaningful dose, tolerable toxicity or like very minimal toxicity, and the patient is seeking for aggressive treatment, I would offer them SBRT definitely.
Okay, so that is an interesting question because you've addressed the SBRT to the bone metastasis. Would you at the same time, since the patient presented with a de novo stage 4 breast cancer, would you also agree, let's say, if the medical oncologist pushes for a curative intent treatment even for the local disease? So going ahead with the chemotherapy, with surgery, and also local radiation to the breast, along with SBRT to the bone metastasis. Is that what you are
Yes, and we
for?
see this like very like, or most often in our clinics. We have patients with single or even like two metastases in their body, but they are fit and excellent and they want to go for aggressive treatment. So as an MDT or multidisciplinary team, we recommend that the patient start for neoadjuvant treatment, the standard of care, assess the response, and after we assess the response, we decide either to continue for aggressive and radical intent treatment, surgery and adjuvant radiation treatment to the chest wall and axilla or the breast and axilla, and offering SBRT to the metastatic spots. So yes, I would still consider, even if they show good response, I still give them the microscopic dose to the pre-chemo metastatic spots.
So probably regardless of the biological subtype of the breast cancer, you have argued with
I have the desire to treat them, yes. But I think circulating tumor cells and circulating DNA, if it gets like implemented in our practice and we learn more about who's going to benefit more from the early intervention or early like SBRT or offering SBRT after these type of treatments, this will answer lots of questions.
Thank you, Dr. Fayez. So it's one of the very common questions that comes up every time in our tumor board. So let's hear the other side of the debate. Dr. Said Rafi. So medical oncologist will be talking about systemic therapy, obviously.
First of all,
so he's against.
I'm absolutely against. So, right. So, thank you very much indeed, everybody. Thank you, Ibrahim, and the moderators, and thank you so much indeed, Dr. Faiz, to set the scene very well. So the question is that oligometastatic breast cancer, is there any role for local therapy? And my answer is, as you guess, is no. So why is no? Because our assumption is that SBRT to lesions detected by imaging, and that's imaging thing, would lead us to improving patient outcome. Is it not? So, you know, this is what we think. You know, we say that we scan the patient, we find something, we see it with our eyes, therefore we're going to treat it, and hopefully that is going. But we are not going to talk about the things that we are not going to see. We are going to see and treat things that we have some imaging for at the moment. So that is the assumption. And we think that we're going to actually, why are we doing it? Because we think that we're going to cure the patient because it's just only limited amount of disease that we have seen on the scan. But oligometastatic disease is not a single disease, first of all. It is just, you know, the definition. We are not talking about biology of the disease. We don't know how it is going to behave. We don't know whether it has already metastasized somewhere else. We are just simplifying things that I'm seeing things on the scan, therefore I'm going to treat it. So even amongst the ones that they have a small amount of disease, there is quite a lot of variations in the biology of the disease, in the image detection, the way that they respond to systemic therapy and stuff. And of course, you know, our definition is not only one definition. We have now come up with so many definitions. Synchronous oligometastatic disease. We have metachronous oligometastatic disease. We have oligoprogressive disease. We have oligopersistent disease. And, you know, how are you going to define it? You know, there are so many things. At the end of the day, metastatic disease is a metastatic disease. You know, it is not just because I'm seeing it on the scan, it is only one, and it was at the same time that disease was diagnosed, or it just appeared later on. It is a metastatic disease process. So the definition of oligometastatic breast cancer also is different, you know, often defined as less than 5 metastases, you know, the different sites, you know, ESMO, they have their own kind of definition, but again, you know, as we discussed, it is synchronous or metachronous or de novo after therapy, etc. And the biology, obviously, you know, we don't really need to ignore this one because, you know, we know each one of these things. And these are the ones that we have simplified, by the way. ER, PR, positive, HER2 negative. It is just the simplification of what it is actually going on in the biology. It is, you know, some terminology that we have defined to use it in the clinic, to unify the way that they treat the patient. But even the ER, PR positive, HER2 negative, HER2 overexpressed or basal-likes, they are, each of them, they have different behaviors and different biologies. So let's tackle the scan part of it, because this is the way that we actually detect the metastatic disease anyway. So imagine that you use an ultrasound scan. At the baseline, there is nothing. And then you do at time point 1, you basically detect this one. And then at time point 2, you do this one, and it is grown. And then your PFS is 3 months now, right? So we are using a different technique. We are using PET-CT scan now. Again, you know, baseline, nothing. And then, you know, I find very small things that I could not find it actually with an ultrasound scan. And that it takes around this amount of time to have a progression. Now it is PFS is 6 months. It's actually very subjective because of the techniques of the imaging that we have. So if I have a better imaging technique, I can find things earlier. Therefore, my PFS is supposed to be longer. So, you know, do you call it an oligoprogressive disease? This is oligopersistent or whatever. I mean, this is the, and then this morning we just learned that FAPI PET-CT scan, for instance, can even find things much earlier as well. So it depends on what is visible to us, what is the machine that we have that can detect things, and, you know, whether it is possible to give the treatment. So we have this lead time bias in all of our imaging scans and modalities, and the more advanced that we become, the more earlier that we will find things as well. Again, you know, differences in the molecular biology of the disease. We know that if you have a PIK3CA mutation, YAP has expression. Some people, they say that favorable response, you know, to outcome. We heard this morning that sometimes even in the early disease, some of these mutations, they make things even worse. You know, RB loss, you know, P53 mutation, as discussed this morning as well. Systemic therapy, you know, we have systemic therapy. Each of those systemic therapies, they have different kind of impact on the tumor biology as well. A lot of those retrospective, older studies with older, you know, generation of chemotherapies which are not applicable at this moment. And of course, you know, my colleague did mention about NRG B002. This trial, in fact, was designed as a phase 2, phase 3 clinical trial. So it was supposed to basically detect a signal for a go to a phase 3 trial. So what they did is that they randomized patient to arm 1, which was supposed to be receiving systemic therapy, and arm 2, which is the ablative therapy in addition to systemic therapy, and 128 patients in the phase 2 randomized, and they were planning to do 360 patients in a phase 3. And you know, Dr. Faiz mentioned very nicely that around 60% of these patients, in fact, you know, they have a disease, which is only one disease. Very small number of patients, they have more than one disease. Majority of these diseases, they are hormone receptor positive, HER2 negative, although that we have some triple negative and HER2 positive on that one as well. And then as you can see, there was actually no signal for the PFS benefit. In fact, if you look at this one, at 6 months, around 25% of the patient, they did progress after receiving ablative therapy as well. So the ablative therapy in those group of patients, they did not actually give them any favor because, it was a short period of time that they progressed. So they did not actually have any convincing hazard ratio here to progress the patient. And the same goes for overall survival, which you could not actually detect any signal as well. And, there was no subgroup whatsoever that you could see that ablative therapy is actually going to be effective in this group of patients. So they concluded that it failed to show any signal of improvement PFS and, of course, no OS, and there was no go signal to continue to a phase 3 trial as well. Again, we have the CARB data. Again, my colleague mentioned this one very nicely. This was not only breast cancer, it was also lung cancer as well. Only very small number of breast cancer. Nonetheless, it gives us some idea. 23 patients on the systemic therapy approach, 24 patients on systemic therapy and ablative therapy. Again, majority of the patient non-triple negative, although 40% of the patient, they have triple negative disease as well. And this is an interesting one, in fact, because you can see, obviously, first of all, there was no signal for the breast, right? So the PFS is, and then you can see how many of these patients, they dropped rapidly. Again, caveat is that a small number of patients, only 24, so you cannot really generalize that data. Nonetheless, there is something that I wanted to show you here, and that is, you see that there is no difference in between the two arms for the new disease development. So these patients, whether they receive ablative therapy or non-ablative therapy, they had the same type of progression of disease. It was not actually the same for lung cancer. There was some signal in lung cancer, but as far as the breast cancer is concerned, there wasn't much. And also, it is very important because you can look at the ctDNA. You can see this is the pattern of the ctDNA that we have at the beginning. It has really not changed much. Whereas, in the in the lung cancer, you can see that there was a little bit of reduction in the ctDNA pattern. So whatever it is, the breast was behaving a little bit differently in the CARB trial. And of course, another question is that whether, the ablative therapy for the local disease in the context of having a metastatic disease is going to be helpful, and that is EA2108. You can see again, around 130 patients in each arm of these trials. And again, it did not show the, treating the primary disease in the context of metastatic disease is going to actually improve the overall survival, although it did control the local regional disease. So if you have a patient which is having a problem here, bleeding, ulceration, infection, etc., and that appears to be very, very good idea for those group of patients. Now, of course, ctDNA, my colleagues also spoke about it. This is certainly something that in the context of early disease, we are just looking at the tracking of this ctDNA to see whether it is predictive of the behavior of the disease over time. And you can see if you have a preoperative ctDNA negative as opposed to being positive, you do much, much better compared with the one that originally are ctDNA positive. And again, it is the same in all different subtypes of this, whether it is hormone receptor positive or HER2 negative. So ctDNA does seem to be a prognosticator really in this case. Whether we can actually use the ctDNA in the context of metastatic setting to just tell us whether the behavior of the disease or at least the treatment can be modified, it's not really well studied yet. Nonetheless, we have this data which was actually recently presented at ASCO 2025, and you can see that what they decided is that they looked at the dynamic of the ctDNA in the metastatic setting, and you can see that they came up with, based on the different mutation and how this mutation they change over the time to put patient in favorable and unfavorable risk. And of course, those that they have the favorable kind of category of the ctDNA dynamics, they do better in terms of the way that they progress on the metastatic setting as well. So actually one of the faculties that are here, Professor Guarneri and her team, they did a very nice publication, and you can see actually the whole publication there as well. There are quite a lot of questions that are actually being discussed in that paper. Currently, these are the things that we are here at the moment we are doing. So obviously we confirm the finding with the radiology, and it depends on what kind of radiology we are going to use. It basically picks up all sorts of lesions at different time points. You know, again, the sampling of this, we discussed it at the MDT meeting, and then, you know, based on the finding, we started the patient with treatment. The ones that we don't know, and these are the matter of research, and we need to go and learn about it, is that really how this oligometastatic disease is going to evolve over years. You know, we don't really know much about the molecular relapse, you know, the molecular subtypes, you know, how is it going to impact on the behavior of the oligometastatic disease. We don't really know actually if we bring the treatment forward, the diagnosis is actually going to impact any treatment either. So we really have to go and investigate that one, whether, you know, for surgery for primary disease, as we discussed, and also the ablative local regional treatment as well. We do not have solid data, and these are the ones that we really need to. As it stands currently, there is no data, or at least solid data, apart from some ad hoc retrospective studies that local regional ablative therapy is going to change the biology of the tumor. And of course, you know, these barriers that we have to really break in the clinical trial by designing clinical trials that not only incorporate the ablative therapies, but also the systemic therapies, and, you know, we need to define our endpoint properly as well. So as it stands, currently the non-randomized single-arm series, in my opinion, they are misleading. You know, we cannot rely on those too much. Obviously, there is no proven OS or PFS benefit. In my opinion, delay in modern systemic therapies, where we do not really have any data to combine them or with a concurrent radiotherapy, may actually not serve our patient very well. We do not really have much data on combination with ADCs and combination with TKIs, etc. And then, you know, just starting the ablative therapy while we are delaying those modern systemic therapy may actually be detrimental to the patient as well. Having said that, local therapy does seem to improve the local control as well. So in conclusion, I think, you know, we should not routinely use local ablative therapy to patients with metastatic breast cancer. And with that, thank you very much indeed for your attention. Thank you.
Thank you, Dr. Saeed, for this well-explained topic. So I think we've got both sides heard. Let's look at the poll very quickly. Are you with local ablative therapy and, let's say, minimally oligometastatic breast cancer, such as the case that I have asked Dr. Faiz, or are you against that and you just want to totally rely on systemic therapy? So I think we have only 2 participants. It's about 50-50, or yeah. So still 50-50. So I think in my conclusion, I believe that, you know, local ablative radiotherapy in selected oligometastasis such as luminal subtype, you know, single or 1 to 2 breast bone metastasis only usually do better than, of course, having visceral metastasis and excellent responders to systemic therapy, despite, of course, having the negative trials, especially from CURB and BR002 trial, though they had very small sample size. I think we still have this question needs to be investigated further with research. Does anybody else have any further questions?
And the Anderson approach.
Of course.
Thank you, Ibrahim. You know, listening to both arguments, I think both reviewers did a great job, and both really hit on very important points. Let me try to tell you what are probably some of the things that need to be added to the arguments. and then try to reach your own conclusions. I agree with the fact that breast cancer is a systemic disease. I'm not looking at anybody because I forgot who said what. And therefore, once the disease is spread, you always assume that there is microscopic disease. By the same token, when you give neoadjuvant chemotherapy, you are treating microscopic disease as well. So this is a biological concept that we should keep in mind when we addressing this. The other thing is very well addressed is what is the definition of oligometastasis? What makes an oligometastasis oligometastasis? And are all were born equal? I see that most of the discussions here were focusing on radiation therapy to a bone lesion, but what about a liver lesion or a lung lesion or a skin lesion for that matter? Number one. Number two, the time that this oligometastasis appeared, did it appear 6 months, 1 year, or 10 years? And is there a difference? Number three, if it is a oligometastasis, and majority of the papers agree on less than 5 lesions. Okay, let's assume that 5 lesions is adequate, but where are they? Are they in bone and liver, lung and bone, skin, liver, lung and bone? Where are they? And how you're going to handle them? And are all equal? Number next. Let us assume that there is one solitary bone lesion by any imaging, and forgive me, Saeed, if I said, irrespective of how you discover it, and definitely there might be a lead time there, but are they all equal? And the only missing thing that I was waiting to hear before you address management or ablation of a solitary lesion, nobody wanted to see if this lesion is sensitive to systemic therapy or not in the first place. Because if it is resistant to chemotherapy or hormonal therapy or both, forget it. The patient is going to recur only as a matter of time. So if you are going to address solitary or oligometastasis, although I differentiate between solitary and oligo, and also I like to differentiate, I'm happy that it was brought up, between synchronous and metachronous, because they can be very different diseases. So here we're walking into an area that really we do not know what we are dealing with. So, and even if there are 5 lesions, are they addressed with one modality of treatment besides systemic therapy? I.e., if you want to do radiation therapy, do you need to have many fields to radiate them? If you want to do radioablation, can you do it? And is there not a limitation to the size of the oligometastasis? So the burden of the disease here, and I think Faiz addressed that also, is important. If you have 5 lesions, 1 centimeter each, and in both lobes of the liver, well, you can do radioablation, but if one of them is larger than the other, maybe the radiologist say, I cannot do it, or there is a lot of disease there. The other thing that I wanted to hear, but I did not hear it, is although you were addressing radiation therapy to a solitary or oligometastasis to the bone, but I wanted you to say, or hoping to say, that you are going to give a curative dose, not the palliative dose. So, and there is a difference between the two. Let us say if a patient has a solitary lesion in the humerus, to make it easy, are you going to give her 3,000 threads or 5,000 to 6,000 threads? How much you are going to? If you are not going to give her a curative dose, you are defeating the purpose. Number next, also I wanted, assuming that we are dealing only with a solitary bone lesion in the humerus, and you give systemic disease, and that lesion responds, would you jump right away to radiate it, or you want to repeat some kind of a staging like bone scan, PET scan, MRI, or whatever, to see if there is activation of solitary metastasis in other bones and other parts of the body, negating the fact that you are not dealing with oligometastasis anymore. So how do I handle these areas? First of all, yeah, multidisciplinary approach is very important. I want to make sure that the radiation oncologist is aware, the surgical oncologist is aware, because I might ask them to know how can you resect this external lesion, for example. So I want everybody to be on board. I would be very aggressive in the follow-up, even if I am treating or focusing in 2 centimeters in the liver, responding to systemic therapy. Still, I want also to look at restaging, including the bones, to see if there is any activation due to healing in the bones. So are we at this point in time, and from what we know, do we have a unified plan how to address oligometastasis? The answer is no. I think patient's care should be personalized. Multidisciplinary approach is very appropriate to see if we can ablate this lesion with a curative intent, is it possible or not. If it is in the vertebrum, for example, the radiation oncologist, more likely than not, will tell you, I cannot give a curative intent because I do not want to induce radiation toxicity to the nerve root or to the spinal cord. So would you still proceed with that? The answer is no. And there are so many things that you need to put it on your checklist so that you do not make bad decisions. Given all the above, if you really safeguarded all these issues, I will go for the treatment of oligometastasis with the understanding that all these issues are addressed ahead of time, not later. Yeah, patients want to be cured, but you have stage 4 disease. Your cure is wishful thinking. The patients hate to hear that, and they hate you when you tell them. But it is what it is. I will tell her, you know, I'm doing this, try to prevent or slow down emergence of more recurrences in your body. But things can happen 30 years later. We do not know.
Okay. Yes. Coming from a medical oncologist, huh? That's the conclusion.
Is there a voting?
Yeah, no, it's recorded. Dr. Faiz and Dr. Tagreed do have a flight, I understand. So we don't want to, but we are actually, this is the last session, and we always leave the best for the last. So if everyone can join for a final picture, maybe a final words from Aida, Dr. since you are here as well. Yes, you're the Emerson oncologist. Hey. But really, thank you so much, everyone, for this successful day. We'll take a group picture, and then whoever is staying for dinner, we'll see you at dinner. Whoever is traveling, safe travels.
I would like to thank you, Ibrahim, for your effort in doing this amazing debate, getting excellent spreading from the region and internationally as well. So congratulations on that. But consider next year doing it not a parallel session, because we missed a lot. Yes.
Yeah, we'll take a picture.
I'm improving in the rad onco, I'm getting 40%. Not